शारदा।
A very good morning to all. With blessing of Ma Saraswati and the successful completion of the inaugural ceremony, we now formally commence the scientific proceeding of the RSSDI Bihar Chapter Midterm Conference 2026.
This session will be graced by the chairmanship of two distinguished clinicians, Dr. Amit Kishore and Dr. Vaibhav Srivastava. I request both of them to kindly take their esteemed seats at the chair.
Respected Dr. Amit Kishore sir and respected Dr. Vaibhav Srivastava sir, it is a matter of great privilege to have two such eminent personalities presiding over our opening plenary today. With your kind permission, your blessings and your gracious approval, we seek your leave to invite our distinguished speakers to the podium one by one. May we have your permission, respected sirs?
Thank you so much, respected sirs. We are truly grateful. With the kind permission of our esteemed chairs, we now begin the opening plenary.
To opening this prestigious conference with the very first presentation of the day, it is my honor to invite Dr. Jitendra Kumar sir to the podium. Sir, we request you to please enlighten us on diabetes in elderly approach, a topic of immense clinical relevance in today's aging population. Sir, the stage is yours.
Good morning, everybody. All the respected dignitaries which have come here from different parts of the state. Myself, Dr. Jitendra Kumar. Today, I'm going to talk about diabetes care in elderly. First of all, who is elderly? This obvious question arises, and traditionally at most places 65 plus is defined as elderly person. In UK there is separate department of elderly medicine, and all those 65 plus patients are admitted in or consult elderly department. But this here in our country, Government of India recognizes 60 plus as senior citizen, and all the facilities are given for 60 plus. In Ayushman, 70 plus is defined as elderly, and all the patients above 70 years is given facility of Ayushman. So this can vary, but for practical purposes, we will take all the 65 plus patients as elderly diabetes. The question arises, why this needed to talk about diabetes in elderly? What is difference? This is not just prescribing medicine and bringing HbA1c less than 7 and we are happy that we have done our job. Because in elderly person, that it differs in many ways from other patients. In elderly person, there may be cognitive changes. All of you know that with age, cognitive functions deteriorates in elderly person. Patient may not recall many things. There are other diseases which patient is suffering from. Patient may not be independent. Patient may not be able to take care himself or herself. There is financial restraints. There may not be financial independence. Patient might be living alone, so loneliness is, there is nobody to take care of. तो पेशेंट आया हमारे पास ओपीडी में आया, हमने प्रिस्क्राइब कर दिया, लेकिन पेशेंट को कुछ समझ में आया कि नहीं आया, और पेशेंट अपना केयर कर सकता है कि नहीं कर सकता है. So when we talk about elderly persons and treatment of elderly person, we have to take care of all these things. That's why this is important, and this is needed to discuss this topic separately. And almost 1/3 of our elderly person is suffering from diabetes. It means every third patient is a diabetes. So it needs a special emphasis to discuss this topic. So we have to take all these things in consideration and treat the patient accordingly. So we have simplified all these things with 4M, that is mentation, mobility, medication, and what matters most. So we have to focus on these things. Mentation, as we talked, as with age, patient cognitive function changes, and especially in diabetes, risk of impaired cognition increases by 1.6 times as compared to non-diabetic patients. So there is chance of impaired cognitive function. So when a patient comes to our OPD, we have to just assess the cognitive function. And there are simple tests for this. We can just ask few words and ask the patient to recall all the words. Just give simple words, unrelated simple words. For example, apple, table, hospital, and ask the patient to repeat all these 3 words. Again, if patient answers these questions or repeats, then we can give simple task. Just for example, draw a triangle, draw a circle, and by this way we assess the cognitive function of the patient. Then we talk to patient and we try to find out whether the patient is depressed, because in this age group there are many factors which leads to depression, and during discussion we will find out that whether the patient is depressed. Because we have seen in recent days that patient is having lots of property of in crores, but they are living in elderly homes. Nobody is there to take care of. Then what is the status of mobility? With age, patient becomes weak. Patient may not stand from chair, patient may not walk, and there is tendency to fall. So we have to assess whether the patient is independent, whether the patient can follow the instructions what we are giving. What is the chance of falling? Because we have to avoid fall from at all cost, because elderly patients are weak and their bones are also weak because of osteoporosis, and fall can lead to easy fracture, and once there is fracture, patient becomes bedridden and there is delayed healing, and this further complicates the disease. So we have to assess the mobility function. So for this we can ask simple questions. Ask chair, आप चेयर से खड़ा हो सकते हैं कि नहीं? Just observe patient whether patient can stand without using their arms. If patient can stand, just ask him or her to walk for 10 feet and return back, and see what is the time taken for this. If this time is more than 12 seconds, it means there is likelihood of patient falling and patient needs a special care. About medication, we have to see which drug is patient taking. We should avoid all those drugs which can cause hypoglycemia, for example sulfonylurea, insulin, and try to change to other safer drugs which are less likely to cause hypoglycemia, for example metformin and DPP-4 or SGLT2 inhibitors. Patient might be taking lots of medicines apart from diabetes, for example hypertension. So you have to see which hypertensive drug is giving. There are certain drugs which are more likely to cause postural drop of blood pressure, and this will lead to further increased risk of fall. So elderly patients are themselves at risk of developing postural hypertension. And antihypertensive drugs further increases this risk, especially ACE inhibitors, alpha blockers. These are more likely to cause postural drop. So these drugs, as far as possible, should be avoided. There might be some other drugs patient might be taking, for example aspirin, atorvastatin. We have to assess whether these drugs are really useful for them, or it can cause more harm than good. For example, if a patient is 85 years of age, suffering from heart failure, suffering from end-stage renal disease, life expectancy is a few years, it may be 1 or 2 years. So whether these drugs are going to do any benefit to them, whether this will improve life expectancy or this is going to do more harm. I have seen patient taking aspirin for infarction and presented at different times with hemorrhage. So there is no need of giving such drugs. So we have to revise all this treatment. Then what needed most? Suppose patient is bedridden, patient is having incontinence of urine, patient is suffering from heart failure, nobody is there to take care of him. So patient is not concerned about what is the blood glucose. ब्लड ग्लूकोज HbA1c हम सेवन के नीचे लाकर इसमें क्या क्या करने जा रहे हैं. पेशेंट का सबसे मोस्ट इंपॉर्टेंट कंसर्न क्या है? बिकॉज नोबडी इज देयर टू टेक केयर, कोई चाय देने वाला घर में नहीं है उसको. सो दीज थिंग्स आर मोर इंपॉर्टेंट एट दिस स्टेज. इन अदर कंट्रीज, इन UK, देयर आर सेपरेट डिपार्टमेंट फॉर ऑल दीज थिंग्स. अगर कोई पेशेंट है जिसको घर पे हेयर ड्रेसर का जरूरत है तो उसके घर पे हेयर ड्रेसर जाके उसका हेयर कटिंग करेगा. उसको ऑक्सीजन का जरूरत है तो गवर्नमेंट विल सप्लाई ऑक्सीजन एट होम. बट हियर वी डोंट हैव ऑल दिस फैसिलिटी. एवरीबडी इज देयर बट नोबडी इज टू टेक केयर ऑफ दिस एल्डरली पर्सन्स. कहावत है ना कि वाटर वाटर एवरीवेयर, नॉट ए ड्रॉप टू ड्रिंक. पूरा घर भरा पड़ा है, पैसे की कोई कमी नहीं है. जिस घर को उसने बनाया था पूरी जिंदगी भर, सारे लोग उसी में रह रहे हैं, लेकिन पेशेंट को कोई चाय देने के लिए भी नहीं है. तो यहां पे हमें डिसाइड करना पड़ेगा कि सबसे यहां प्रायोरिटी क्या है. सो विथ ऑल दीज थिंग्स we summarize all this in 4 aims and we will decide the priority. So if the patient is cognitive impairment is there, patient cannot understand what we are saying and cannot take care of himself. Patient is frail. In these situations, we have to involve caregiver also. Who is caregiver? क्या घर में कोई ऐसा है जो उसका टेक केयर कर सकता है? किसी के पास टाइम है क्या इतना कि एल्डरली पर्सन को देखेगा? Whether a spouse is there or not. ऐसा देखा गया है कि स्पाउस के डेथ के बाद पेशेंट का डेथ भी बहुत जल्द हो जाता है. कोई देखने वाला नहीं है, पूरा घर भरा हुआ है लेकिन कोई देखने वाला नहीं. तो in this situation we have to provide caregiver or we have to counsel caregiver how to give medicines and how to take care of the patient. We have to assess hypoglycemic risk. Hypoglycemia should be avoided at all cost because hypoglycemia, there is more chance of developing hypoglycemia in elderly patient. Symptoms of hypoglycemia is not that obvious in elderly persons. जो क्लासिकल टीचिंग है कि पेशेंट को ट्रेमर होगा, पल्पिटेशन होगा, स्वेटिंग होगा, घबराहट होगा, इट्स नॉट लाइक दैट. If these symptoms may not appear in elderly persons, it directly will lead to death or coma. Hypoglycemia increases the risk of myocardial infarction. Why? Because in hypoglycemia there is increased secretion of noradrenalines, and this causes vasospasm and myocardial infarction. This increases heart rate, blood pressure, and this puts extra stress on heart muscle, and this increases the risk of myocardial infarction. All this can lead to, there is risk of arrhythmia. If hypoglycemia develops, there is risk of arrhythmia, and arrhythmia, dangerous arrhythmia, that is torsidis de pointis or ventricular fibrillation, and this will lead to sudden death. ऐसा कई बार हम लोग सुनते हैं कि पेशेंट डायबिटीज के रात में सोया हुआ था, सुबह में उठा ही नहीं, पता ही नहीं चला किसी को क्या हुआ. This may be because risk of hypoglycemia increases at night. Symptoms is not recognized, and there is more chance of hypoglycemia because of patient is not able to take food or glucose to avoid hypoglycemia. So there will be arrhythmia and there will be sudden death, and this is a recognized cause of death, and this is defined as known as dead in bed. रात में सोया और सुबह में उठा ही नहीं, किसी को पता ही नहीं चला कि क्या हुआ इसमें, and probably the reason is arrhythmia and sudden death. Dead in bed को अवॉइड करने के लिए हम लोग कभी कभी बीटा ब्लॉकर का भी यूज करते हैं. इसमें क्लासिकल टीचिंग था कि इसमें डायबिटीज में बीटा ब्लॉकर नहीं देते हैं, बट सेलेक्टिव बीटा ब्लॉकर कैन बी गिवन टू अवॉइड दिस सिचुएशन. दिस विल प्रिवेंट arrhythmia. So hypoglycemia has to be avoided at all cost. So certain drugs which are known to cause hypoglycemia should be avoided. For example, as we discussed earlier, sulfonylurea and insulin. Then, as we talked about polypharmacy, patient might be taking many drugs, out of which some drugs may not be useful, may not be required for in particular situation. In fact, they can do more harm than good. तो ऐसा नहीं है इसमें कि हमने पेशेंट मेरे पास आया, हमने उसे एडवाइस कर दिया ट्रीटमेंट और HbA1c less than 7, you are happy कि everything is all right. So, the preferred drug is metformin, SGLT2 inhibitor, GLP-1 agonist, although this is not widely used because of limited availability and very high cost, and DPP-4 inhibitors, and try to avoid sulfonylurea and insulin in elderly persons. Another important is to give cardiac protection and renal protection to delay CKD, and for that we have to keep blood pressure good control. Target is 130 systolic pressure, use of ACE inhibitor or ARB, use of SGLT2 inhibitors.
Sir, actually we are running short of time, so can you make it a bit fast?
Okay. So we have to screen for all this: retinopathy, neuropathy, nephropathy, and for foul play, we have to screen for different vitamins, especially B12 and vitamin D. B12 deficiency is a recognized cause of, recognized outcome of metformin treatment. So we have to screen B12 at regular intervals. Always check vitamin D time to time because this helps in control of diabetes. So, as we are running short of time, so I stop here. Thank you.
Thank you, sir, for such an informative lecture. So, care of diabetes in elderly is not only about giving anti-hyperglycemic treatment, it's also about taking care of the cognitive decline, social care, financial status, as well as taking care of the morbid status. So, coming to any questions? So, coming next session, I would like to invite Dr. Rana R.K. Singh for his topic on remission of diabetes sustainability.
Can diabetes truly be reversed and sustained? A question that has transformed our thinking in recent years. To address this with clarity and evidence, I warmly invite Dr. Rana R.K. Singh to the podium. Sir, please take us through remission of diabetes sustainability. We look forward to your insights, sir.
ये कर दें, यहाँ से करते आना पड़ेगा. So remission of diabetes, I have to talk on this topic. Remission of diabetes beyond achievement to sustainability. Subtitle: Challenges, Predictors and Clinical Strategies. I am Professor Dr. Rana R.K. Singh, Professor of Medicine in this college. So I am proceeding on this topic. Disclosure and conflict of interest. There is no relevant financial conflicts to declare or list specific amounts. Discussions will include off-label use of lifestyle interventions. Contents are based on current ADA and EASD consensus and recent trial data 2023 to 25. The core questions we face in this regard are: can the remission last, or is it always temporary? Remission is achievable in the direct trial or look ahead trial and direct ahead trials. But relapse rate are at 2 to 5 years remain very high. For example, 30 to 55% plus. And this sustainability is equal to the new clinical frontier. Defining remission as per ADA 2021 to 24 guidelines. What is remission? Remission is achieving the HbA1c less than 6.5%, that is less than 48 millimole for more equal to or more than 3 months without glucose lowering pharmacotherapy. Mind it. The remission is HbA1c less than 6.5% for equal to or more than 3 months without glucose lowering pharmacotherapy. What is complete remission? We define complete remission as normal glucose, that is HbA1c less than 5.7% of the therapy. And now we come to the prolonged remission. It should be more than 5 years. Note, remission versus cure, and the beta cell dysfunction persists in this regard. Now we come to the key evidence, what works initially. In the direct trial in UK, intensive low calorie diet, that is 800 kilocalorie per day, leads to 46% remission at 12 months. It's very important. The intensive low calorie diet, 800 kilocalorie per day, leads to the 46% remission at 12 months. Now we come to the look ahead trial. In this case, the lifestyle intervention leads to 11.5% partial remission at 1 year. Now we come to the bariatric surgery. Here, 30 to 60% remission occur at 1 to 3 years. 30 to 60% remissions occur at 1 to 3 years, depending on procedure. But sustainability drops significantly beyond 2 years. Now we come to the sustainability problem and relapse data. Trial 2-year remission is 5-year, trial 2-year remission. There is 5-year remission, 2 to 5-year remission. In the direct trial, 36% versus 13%. In the look ahead trial, 8%, less than 5% partial. In the surgical RUX NY trial, 60%, it led to 30 to 40%. Key message: without ongoing intervention, most relapse occur. Without ongoing intervention, most relapse occur. Why does the remission fail? The pathophysiology of relapse. There is weight regain is the primary driver. Reaccumulation of pancreatic and liver fat occurs. After the remission, if one eats more, there is weight regain leading to reaccumulation of pancreatic and liver fat. There is progressive beta cell decline, which is not fully reversible in long-standing type 2 diabetes. Now we come to loss of metabolic memory. There is sustained caloric restriction is very difficult. It's very easy to say, but very difficult to practice. In this regard, it's very important to mention here that durability of weight loss is the single strongest predictor. Mind it, durability of weight loss is the single strongest predictor. Now we discuss predictors of sustainable remission. Clinical pulse. What are the For favorable factors: shorter diabetes duration, 1 nanogram per ml. Greater initial weight loss, more than 15 kg or more than 15% body weight. Absence of prior insulin use. Sustained weight maintenance. It's non-negotiable. Now we come to the strategies to enhance the sustainability in lifestyle. Very low energy diets, VLED as induction. Then structured weight maintenance programs. Some people may even say it VLCD, very low calorie diet. The extreme weight loss maintenance leads to more than 10% body weight loss sustained. Extreme weight loss maintenance leads to more than 10% body weight loss sustained. The high physical activity leads to more than 200 to 300 minutes per week. It's moderate to vigorous exercise. Mind it, high physical activity is very essential in this regard. It leads to more than 200 to 300, that is more than 200 to 300 minutes per week exercise. Moderate exercise is needed in this regard. It's moderate to various vigorous type of the exercise. Now we come to diet composition. In this case, one should take higher protein diet, lower glycemic load, time restricted eating as per emerging data. Now we come to the role of pharmacotherapy in sustaining remission. Here, semaglutide is now a wonder drug. Now it's considered a wonder drug. Semaglutide and trizepatide are worth mentioning in this regard. These two drugs can prolong the remission by preventing weight regain. These two drugs are very, very helpful in this regard. Step trials extension data में, though it's a bit costlier, but these two drugs are very, very important in this regard. Now we come to the role of metformin. Though there is no role in remission induction, but it may delay relapse in prediabetes after remission, though it's unproven. Now we come to the use pragmatic approach. Restart the low dose drug if HbA1c rises more than 6.5% despite the lifestyle management. It's very, very important. We must use pragmatic approach. We should start the low dose drug if the HbA1c rises more than 6.5% despite the lifestyle changes. What is the clinical consensus in this regard? Drug-free remission is ideal, but drug-assisted sustained remission is acceptable. Mind it, though the drug-free remission is very ideal, but the drug-assisted sustained remission is also very acceptable. Now we come to the role of bariatric surgery. It's the most durable option. Its durability, 5-year remission rates, 30 to 50%. In the gastric, in this regard, gastric bypass is better than sleep. Now we come to the predictors of sustained remission post-surgery. Younger age, lower baseline, HbA1c, greater excess weight loss. Now we come to the late relapse occur due to the anatomical reconstitution of the gut hormone effects and weight regain. Even after surgery, there can be late relapse occur due to the anatomical reconstitution of gut hormone effects and weight regain. Now we discuss monitoring for the relapse. It's a practical protocol. Every 3 to 6 months, in sustained remission, we should check for HbA1c. Our target must be 6% on the 2 consecutive values. We must try to maintain the HbA1c, target 6%, 2 consecutive values. Fasting glucose and C-peptide, trending down signals, beta cell fatigue. Fasting glucose and C-peptide should also be estimated. The trending down signals the beta cell fatigue. What's about body weight? Regain of more than 5 to 10% initial loss is very high risk signal. Mind it. Body weight regain of more than 5 to 10% initial loss is very high risk signal. What about the action on relapse? Don't call it failure, but restart the metformin early in this case. What about the patient selection? Who to offer remission attempt? Ideal candidates are obesity associated type 2 diabetes, less than 6 years duration, motivated, good support system. Motivation is very important in this regard. Poor candidates are long-standing type 2 diabetes mellitus, more than 15 years, low C-peptide, and advanced complications. Shared decision making explain the high likelihood of eventual relapse, frame remission as a remission attempt, not cure. Key take home points for the clinicians.
Sir, due to time constraints, sir,
I'm just finishing.
Thank you.
Remission is achievable, but sustainability is the real challenge. Weight regain is the first enemy. Is prioritize the long-term weight maintenance. Duration of diabetes matters most. Intervene early. Accept the drug-assisted maintenance as a successful outcome. Relapse is not a failure. It is the natural history of a chronic disease. Mind it. Relapse is not a failure, but it is the natural history of a chronic disease. Conclusion and future directions. We need better predictors of who sustains remission, like the genetics and metabolomics. Digital health and continuous glucose monitoring may improve the long-term adherence. Combined approaches, lifestyle plus pharmacotherapy, GLP-1A receptor agonist plus metabolic surgery in the selected cases. Final message, sustainability requires chronic disease management. It's not a one-time intervention. Thank you, sir.
We are truly honored by the presence of Dr. Rana R.K. Singh, sir, on this stage today. There was a presentation of exceptional scientific depth and clinical relevance. We thank you most warmly and sincerely, sir.
Autonomic neuropathy, a complication that often goes unnoticed until it is too late. To bring this silent threat into the sharp focus, I request Dr. Amit Kumar sir from Saharsa to kindly come forward. So please guide us on autonomic neuropathy, the silent killer. The floor is yours, sir.
Thank you so much. Good morning, all respected faculties, senior colleague, and junior students. Thank you for scientific committee to given this opportunity as a speaker to talk on autonomic neuropathy. So this is the one of the most overlooked complications of diabetes, जो nowadays बहुत सारे diabetes later complication और delayed complications हम लोग books में पढ़ते हैं और day to day practice में भी देखते हैं, but this is the most नजरअंदाज overlooked complications हैं जो lethal है. So we are I am going to talk to this topic as a brief. So autonomic neuropathy, a lethal but overlooked complications. 20 to 40% of all people with diabetic worldwide are affected by autonomic neuropathy. So 5 times increase in 5-year mortality with confirmed cardiovascular autonomic neuropathy. And more than 50% of cases remain undiagnosed in routine clinical practice. So less than 15% of diabetes patients in India undergo formal autonomic screening. That patients 85% से ज़्यादा patient का screening ही नहीं हो पाता है. And so first talk sir ने जो लिया था, that is dead in bed syndrome. So that is comes under this less than 15% that patient is not screened. So we have on the either slide there is a submerged iceberg. So everyone we can see visible symptoms of some patients having few symptoms that comes to the physician. Sir, we having resting tachycardia, orthostatic dizziness, and some patients having complaint of syncope. But some subclinical, that is submerged complication symptoms which is overlooked. That is patients having damage and irreversible lethal complications, and that is HRV reduction, heart rate variability reductions. In autonomic neuropathy we can see silent myocardial ischemia, early parasympathetic denervations, QTC prolongation in ECG, and baroreflex impairment, there is a deregulation of blood pressures. So what is diabetic autonomic neuropathy? That is DAN, a spectrum of damage across every organ the autonomic nervous system controls. So damage of autonomic nerve fibers supplying the heart, blood vessels, GI tract, genitourinary systems, sweat gland, and pupils. So we have some complications that pupillary motor systems, patient will come with impaired pupillary light reflex, cardiovascular systems like resting tachycardia, arrhythmia, and sudden cardiac death can happen and can highest prolong weight also. Gastrointestinal systems impaired, like patients having complaint of altered bowel and bladder, like some patients having complaint of diarrhea and loose stool and alternate day. So patients having genitourinary system dysfunction like bladder dysfunctions, and some patients having complaint of erectile dysfunction. Some patients having pseudomotor system complain like abnormal sweating and anhidrosis also complain with autonomic neuropathy. So, and by the epidemiology globally we have some hidden in the plain state. We can see that is purple color, that is in USA according to Eckhart clinical trial we have 29%, and we have seen in Europe there is 36% of prevalence globally, and Southeast Asia like China and India, Bangladesh, we have seen 54 to 99% patients having prevalence of CAN. So CAN independently predict all cause of mortality. There is some clinical trial of MSA and that across every major outcomes trials. So the clinical burden of Indian nations, we have specific crisis. We can see again the 100.1 million diabetic patient in worldwide. In South India or that west of part of the India, we have because some screening is very high and patient have lesser than complication like Bihar and Orissa and Bengal region, we have there is late diagnosis and delayed complication is more common. There is rural gap also, less screening also the main reason. So total 1 million people with diabetes in India, that is largest absolute diabetic population globally by IDF 2023, and 54 to 99% can prevalence in India hospital-based type 2 diabetes cohort. So again, less than 15% Indian diabetic patients receiving formal autonomic screening, and that is a critical gap. So screening gap is less than 15% and more than 85% patients having unscreened. So what are the pathophysiology of diabetic autonomic neuropathy? This is the molecular assault on autonomic nerves. That is, first is parallel pathway, excess glucose in the body with leads to sorbital accumulation and finally axonal swelling. Second is hexoamine pathway, that is glucosamine 6-phosphatase. Then later stage we have gene transcription and dysregulations. And protein kinase C pathways, there is later stage endoneural ischemia can happen. And advanced glycation end product pathway, we have structural apoptosis can happen, and mitochondrial ROS storm, that is ROS production, and mitochondrial member collapse and neural apoptosis can happen. So lastly, metabolic memory effect, that is epidemic oxidative damage persists after the glucose normalizing और irreversible injury. Actually होता क्या है कि कुछ पेशेंट जैसे legacy effect we are seeing, that is metabolic memory. So what is metabolic memory? जैसे कहते हैं कि कोई राजा है, बहुत पहले 50-200 साल पहले राजा था और उसकी अभी भी राजशाही है, तो that is metabolic effect और legacy effect. Memory रह जाता है बॉडी में. After good control of डायबिटीज ऑल्सो बॉडी उसका बहुत अच्छा कंट्रोल, ग्लाइसेमिक कंट्रोल जा रहा है, HbA1c इज गुड कंट्रोल, बट देर इज कंटिन्यूस ऑफ डैमेज. दैट्स वाई वी आर टेलिंग और वी आर कीप टेलिंग कि आफ्टर कंट्रोलिंग द ग्लूकोज patient have to be monitorized every 3 months or 6 months or yearly, so that we can prevent the relapse or we can damage the tissues for after controlling the sugar. That is the legacy effect or metabolic memory. So from molecular damage to autonomic dysregulations, there is the sympathetic vago imbalance to arrhythmic cascades. We have earliest change vagal fiber loss and vagal denervations, elevated resting tachycardia, and the first detectable autonomic sign can present with patients. And sympathetic cardiac denervations, progressive loss of heart rate variability, and the cardiac rhythm is flattened. Sympathetic vagal imbalance, low frequency or high frequency ratio is elevated, and arrhythmic substance established. That is QT interval prolongation, sympathovagal mismatch, lengthen, ventricular repolarization, or patients having risk of TDP, torsidy pointed. That is also discussed with Dr. Jitendra sir, sudden cardiac death. That is, patients may have ventricular fibrillation can have torsidy pointed. In ECG we can see, and later patients having ventricular fibrillation and sudden cardiac death can happen. So baroreflex are disruption because of irregularity or patient body is not regulate the blood pressure. So baroreflex is disruption and patients can present with orthostatic hypotension. So exercise intolerance can happen and impair blood pressure regulations. So blunted epinephrine response, reduced counter-regulation surge, and hypoglycemic unawareness can happen. So this is the parasympathetic vagal system and sympathetic systems. Vagal loss, resting tachycardia, earliest sign can happen, and later stage sympathetic denervation, heart rate variability is lost. So can staging from subclinical to life-threatening. Each stage demand a different clinical response. Stage 1 subclinical can, that is intervention windows. Stage 2 is defined can, and patient have irreversible damage begins from the stage 2, and stage 3 severe advanced can, patient have high mortality risk and 5 times increase in the 5-year mortality with confirmed can. So can is cardiovascular autonomic neuropathy. So mortality risk in stage 1 is very less and stage 3 is very high. So what are the cardiovascular manifestation of CAN? So lethal spectrum are resting tachycardia, that is earliest sign, and fixed heart rate in advanced sign, that inability to vary heart rate with exertion, posture or Valsalva maneuver, and that is a hallmark of complete cardiac denervation. So, orthostatic hypotension is systolic drop of 20 millimeter of mercury or diastolic more than 10 millimeter of mercury within 3 minutes of standing, that is increased risk of syncope. And silent myocardial ischemia, absent anginal warning in that patient, diabetes patient. We have delayed treatment and later higher in the hospital mortality and worse in the left ventricular remodeling. That is the silent killer. So prolonged QT interval, that is QT is more than 440 milliseconds, that is the risk of torsade pointed, ventricular defibrillations and ventricular fibrillation and sudden cardiac death can happen. So beyond the heart, multi-organ autonomic dysfunctions. When the autonomic nervous system fails, every organ pays to price. So gastroparesis can happen, diabetic diarrhea or constipation, alter bowel can happen, neurogenic bladder can happen, patient can complain of recurrent UTI or urinary hesitations, retention. Sometimes we can mismanage with overacting bladder or prostate hypertrophy. So patients can complain of hypoglycemia, unawareness, that is blunted adrenergic contours, response to low glucose, severe life-threatening and hypoglycemic risk. Some patients having gustatory sweating, that is sweating triggered by eating Frey syndrome variant, and pseudomotor dysfunction is the hallmark. Erectile dysfunction can happen in patient with most common male sexual dysfunction in type 2 diabetes, and more than 50% male patient or patient with are affected. So hyperglycemia, unawareness and can a dangerous alliance when the body loses its own warning system. Dead in bed syndrome, that is rare but preventable and unforgivable to miss. So in case we have seen the ECG graph, there is RR is fixed but QTC prolongation in CAN substrate. We can see in the slide. So EVIC test is the gold standard test for CAN diagnosis. There is 5 cardiac autonomic reflex test. We are say CART test and validated since in 1985. Test 1 is deep breathing. Test 2 is Valsalva ratio. Test 3 is 30:15 ratio. Test 4 is orthostatic blood pressure, and 5 is hand grip test. So these tests we have a scoring system. Score 0 pre-test per test for normal, and score 1 for first test for borderline, and score 2 is abnormal. So total score guide can stage and see the staging slides also. So what are the HRB? That mirror of autonomic health, decoding autonomic balance through beta to beta variations, time domain, then frequency domain, and non-linear prognostic in domains. So we have normal HRV in the autonomic health at a glance, and CAN patient with pioneer is the plot. So we have differential diagnosis. What else cause autonomic dysfunctions? Always exclude these conditions before confirming DAN, diabetic autoneuropathy, amyloid neuropathy. So that is either familial or acquired. Multiple system atrophy, that is patient of cerebral or Parkinson's features, we have to rule out. Drug-induced autonomic neuropathies, we have to rule out. Autoimmune conditions like Sjögren syndromes, SLE, GB syndromes, and some anti-SSA antibody panel, we have to rule out from paraneoplastic syndrome. We have to rule out pure autonomic failure, nutritional deficiency like vitamin B12 and vitamin E deficiency. Infectious neuropathy can also can happen. We have to rule out from diabetic neuropathy, from HIV-associated autonomic neuropathy, changes disease in endemic region, that is serology screens. We have to all the rule out of other differential diagnoses. So step by step CAN screening algorithm, we have a stage 1 screen all patient, step 2 is initial office screen, step 3 performing EV batteries, define CAN, cardiac workout, and patient having to step 5 is severe CAN, and we have to follow the protocol. So there is the cornerstone of CAN management metabolic optimizations are in type 1 diabetes. We have to several clinical trial, UKPD trial to have HbA1c target. We have to in individualization of the patient. So we have to look for all patient, not a for treatment for all. We have to individualize each patient to control the neuropathic patient. So we have SGLT2 inhibitor and GLP-1 receptor agonist. This is a new frontier, the cardiovascular autonomic protection. SGLT2 inhibitors are empagliflozin, dapagliflozin, and canagliflozin. All are cardioproductive across major cardiovascular risk. Reduce the mortality rate also. GLP-1 receptor agonist, liraglutide and semaglutide, this is the leader and sustained 6 cardiovascular outcome data. There is several trials has done, there is the reduce the cardiovascular risks. So management of orthostatic hypotension in CAN. So we have compression garments, we have head of bed elevation raised to 13% of reduced nocturnal hypertension, dangle rise technique, liberal hydrations, patients having a small frequent meal and avoid triggers. We have some pharmacological treatments like fluorocortisones, we have midodrine, we have droxidopa and pyridostigmine. We have pyridostigmine is 30 to 60 milligram thrice a day. This is the most frequently we are using. So, yeah, we have 1 or 2 slides more. Managing CAN related tachycardia and cardiac risk. The rate control and HRV distortion is the main focus on. We have in neuropathic patient, we have to use beta blocker, that is cardioselective, bisoprolol or metoprolol, most frequently used, ivabradine, and patients having AC inhibitor and ARBs we can use, and correct reversible and causes the first thyroid dysfunction, anemia, and volume depletion we have to prevent. So QT prolongation and arrhythmia risk can be avoided by these drugs. So restoring the warning, managing hypoglycemia unawares in CAN, we have such instrument is there, and newer AI technique we have to control and monitor the autonomic neuropathy and diabetes. All the patients of, we have some research highlights from 2022 to 2026. So these are the device we can use to monitor all the patients having sugar and blood pressure and HRV. So these are the clinical case studies. We have 48-year male type 2 diabetes since 9 years, and HbA1c is 8.2 on metformin plus glipizide, refer to unexplained resting tachycardia. Patients can complain with fatigue and mild exertional breathlessness, occasionally lightheadedness or standing. There is no chest pain. So we have early and subclinical stage. We have to regulate and the patient on AC inhibitor and aerobic exercise, and there is measurable autonomic pathway. We have to control the patients. So these are the same cases on advanced CAN management. We can manage with first line, second line, and third line therapy. These are the future perspective of emerging therapies. There's regenerative neurology, gene therapy, next generation biomarkers, digital health and AI-driven care, and emerging pharmacotherapy, that is mitochondrial target antioxidants. So these are summary and key takeaway message. What every clinician must carry forward: CAN common and lethal, affects 20 to 40% of diabetes, and CAN carries a 5-fold increase in 5-year mortality, and parasympathetic damage come first. Early CAN is reversible, vagal fiber loss proceeds, sympathetic dysfunction, that intervention window is narrow and must be missed. QTC prolongation plus CAN arrhythmic alert we have to look for. Screen early, treat early, multifactorial management can win the target. CGM and non-negotiable CAN we have to. Insulin demand and continuous glucose monitoring to each patient. Conclusion of the today's topic: the call of action from silent killer to detect, manage, and survive. CAN is a common, lethal, and detectable yet scandable underdiagnosed across India and worldwide. The tool exists today: EVIC battery, HRV, and ECG monitoring systems. No clinical has excuse to miss these dangerous signs and diagnosis. India carries the world heaviest CAN burden. RSSDI must champion mandatory national screening protocols and multifacial management of glycemic, BP control, lipid, and lifestyle modifications. SGLT2, GLP-1 is the good control, and their patients having good survivor outcomes. Individualized glycemic target in advanced CAN, patient safety overweight, strict HbA1c numbers. Please today screen every appropriate patient, document can, stage and act on finding stage. The heart cannot feel itself, on rhythm is already dying, let us listen for it. Thank you.
Thank you, Dr. Amit.
Any questions?
We'll have afterwards.
Okay, thank you.
We sincerely thank Dr. Amit Kumar sir for that eye-opening and clinically significant presentation. The awareness you have brought to this silent yet serious complication is truly invaluable. We are most grateful, sir.
The liver and diabetes, a relationship that is increasingly demanding our clinical attention. To explore this important synergy, I warmly invite Dr. Narendra Kumar from AIMS to the podium. So we request you to please speak on MASH, formerly known as non-alcoholic steatohepatitis, and its synergy with diabetes. So we welcome you to the stage.
Good morning to senior faculties, all residents and dear students. First of all, I would like to thank the organizing team for giving me the opportunity. For giving me the opportunity to share my idea on this prestigious platform. So, in the next 15 minutes, I would be talking on the interrelationship between the MASH and diabetes. So, coming to the definition of MAFLD or MASLD, that is a metabolic associated steatotic liver disease. It is defined on the basis of detection of liver steatosis, on the basis of either liver histology or non-invasive markers like CAP or imaging, mostly on the basis of ultrasound, with at least one of the three criteria. These are the overweight or obesity, diabetes, or clinical evidence of metabolic dysfunction in lean subjects. So why this topic matters for us? So considering the global scenario, the prevalence of MASLD is approximately 65% among diabetic patients. Of those, 35% have MASH, that is a steatohepatitis, and 7% of them might have the MASLD related cirrhosis. And diabetes is the strongest predictor of fibrosis progression. So MASLD not only leads to liver related morbidity like cirrhosis, hepatocellular carcinoma, but it also causes extrahepatic manifestation. The most important of them is cardiovascular disease. In fact, cardiovascular disease related death is one of the most important cause of death among the MASLD patient. MASLD also causes increased mortality, overall increased mortality in the patient of among the patient of MASLD. Now coming to the Indian scenario, in India it is also in the line of global picture. So here the prevalence is about 60 to 85% in the diabetic patients. 1/3 of them have the MASH. Advanced fibrosis are seen in 34.4% in the patient with diabetes when we compared with MASLD without diabetes. So it almost doubles the risk of diabetes, almost double the risk of MASLD. Now the MASH diabetes axis. So both diabetes and MASH have the common pathophysiology. Many of they share the insulin resistance. Both are characterized by the insulin resistance, and they have adipose tissue dysfunction, lipotoxicity, and there is a state of chronic inflammation in the both of the conditions, and there is a oxidative stress. Both diabetes and MASLD have bidirectional relationship, means diabetes due to hyperglycemia accelerate the fibrosis, and MASH by causing the insulin resistance further worsens the diabetes, or you can say the glucose intolerance. So coming to the pathophysiology, so what does the hyperglycemia and insulin resistance do in the liver? So basically, the hyperglycemia induces the de novo lipogenesis inside the liver. That is mostly responsible for the steatosis. Along with hyperglycemia and free fatty overflow to the liver, they causes a state of oxidative stress. That means it generates the reactive oxygen species. These reactive oxygen species causes the damage to the sinusoidal endothelial cells. That is the key cells involved in the pathogenesis of the mast cell. So damaged endothelial cells causes the cell injury as well as recruitment of the inflammatory cells. That is responsible for the steatohepatitis. Also, the normal endothelial cells prevents the activation of the hepatic stem cells. That is the key cell responsible for the hepatic fibrosis. So injured endothelial cells are not able to further inhibit these hepatic stellate cells. So there will be activation of the hepatic stellate cells, and so the initiation of the hepatic fibrosis. Now, there is an organ to organ interaction in case of mast cell D. So what does it mean? It means the presence of liver steatosis causes the release of the hepatokines. These hepatokines causes the insulin resistance in the skeletal muscles. So insulin resistance in the skeletal muscles means they will be the muscles are not able to store those extra glucose in the form of glycogen. So what will happen? All those extra glucose will go to the liver as well as adipose tissue. So inside the liver, this extra glucose will further cause the de novo lipogenesis, and inside the adipose tissue there will be lipogenesis, extra adipose fatty deposition. So, liver steatosis leading to hepatokine, insulin resistance, and at the same time, insulin resistance inside the muscle will further predisposed for the or contribute to the hepatic steatosis. So there is a bi-directional link. Fatty liver influence the insulin resistance, and insulin resistance further contribute to the hepatic steatosis. Now, which patient should be screened for the mast cell D? Now, the ADA has the recommendation. ADA recommends all the diabetic patients should be screened for the mast cell D. So, how to screen? So, screening is mostly based on the basis of imaging study, mostly ultrasound. So, ultrasound evidence of fatty liver. वैसे patient में we have to go do FIB-4 score calculation. What is a FIB-4? It is a score mostly based on the 4 parameters. These are age, AST, LT, and platelets. These are very simple. This is a very simple test to do, and there is online calculators available for the calculation of FIB-4 scoring. So based on the FIB-4 score, the patient with mast cell disease and diabetes can be categorized into 3 risk categories. If a score is less than 1.3, means patient is in the low risk group. Such group of patient can be managed at the level of primary care. When the risk score is between 1.3 and 2.67, that is the intermediate risk group. Such group of patient requires further evaluation with the help of transient elastography. Patient with high risk means a score is more than 2.67. Then such group of patients should be referred to a hepatologist for better management and evaluation. Now, as we know, the cardiovascular disease is the biggest threat among the patients with mast cell D. So mast cell disease not only cause the liver failure, but cardiovascular disease related death is the most common death among the patients with mast cell D. So holistic care model should be applied, and treatment must address the aggressive dyslipidemia control, optimization of the blood pressure, and weight reduction. So coming to the management as it is a multi-system disorder, so management involves the multidisciplinary care, lifestyle interventions and pharmacotherapy. So coming to the lifestyle interventions, so the lifestyle interventions are basically aimed to achieve the weight loss. So 3 to 5% of weight loss is associated with reduction in the reduction, or you can say the resolution of the steatosis. When we achieve the 7 to 10% of weight loss, there will be resolution of the steatohepatitis, that is a MASH. And more for the fibrosis regression, we have to acquire more than 10% of the loss of body weight. So what intervention we can apply? So basically we have two options. The mainstay of therapy is basically the calorie restricted diet as well as exercise. The best evidence is seen with the Mediterranean diet, and aerobic exercise with at least 150 minutes per week is recommended. Now what are the drugs available for management of MASLD? As we can expect, as there is a common shared pathophysiologic process, so we can expect here the anti-diabetic drugs might be beneficial for the case of MASH resolution. So here are few drugs that has shown the proven benefit for the MASH. These are the pioglitazone, semaglutide, tirzepatide, and now the SGLT2 inhibitors has now begun to show the evidence for the beneficial effect among the MASLD patients, especially in the Asian group of populations. Now, this is a newer drug, resmetirom. This is the first drug now approved by the FDA for the management of MASH. So it is indicated for the MASH, non-cirrhotic MASH. So for the advanced MASH with advanced cirrhosis, advanced stage of fibrosis, these drugs should be avoided. Here the trial, the Masteronase trial data has shown there is a 30% of MASH resolution among the MASLD patient versus 10% of placebo. There was also significant reduction in LDL, and so this is considered a milestone in hepatology, diabetology partnership. Tirzepatide is now emerging drugs. The Synergy NASH data trial has shown the robust benefit of this drug in the MASH resolution. It has shown up to 74% of MASH resolution. Also, there was significant reduction in the liver fat. So, the take-home messages. So, a screening early to have the better management of the patient, and even there might be advanced stage of fibrosis even in the absence of LFT derangement. So, don't wait for LFT, deranged LFT. Every type 2 diabetic patient should be screened for the MASLD. Treat the whole patient, not only the MASLD, because it is a multi-system disorder. Think cardiohepatology. As we know, the cardiovascular death is the most important cause of death among the patient with MASLD. Achieve the target weight loss of 10%, that is the magic number for the fibrosis of regression, and multidisciplinary care is required for the better management of the such group of patients. So these are my references. Thank you.
Thank you, Dr. Narayan. We will go for the next speaker.
Yes. We extend our deepest gratitude to Dr. Narendra Kumar sir for that brilliantly comprehensive and clinically enriching presentation. Having a faculty of your stature and experience with us today is truly a privilege for all of us. We thank you most sincerely, sir.
Gestational diabetes mellitus does not end at delivery, and yet postpartum follow-up remains one of our most significant gaps in care. To shed light on this critical issue, I invite Dr. Ranjan Kumar sir to the podium. Sir, please take us through GDM, postpartum follow-up gaps. The stage is yours, sir.
Good morning to all of you. The today topic is gestational diabetes mellitus. Gestational diabetes mellitus is a condition characterized by glucose intolerance that is first identified during the pregnancy. It is the most common medical complication in pregnancy and usually develop in second and third trimester of the pregnancy. Because of there is increased insulin resistance in this period. Prevalence. Gestational diabetic mellitus is highly prevalent in India, affecting approximately 22.4% of the pregnant women. Globally, International Diabetes Federation estimates that one of the 6 live births are affected by the hyperglycemia in pregnancy, with global diabetes, gestational diabetes mellitus prevalence setting around 15.6%. What are the risk factors? Risk factor of GDM. The previous GDM is the strongest risk factor for the future diabetes mellitus, gestational diabetes mellitus. Next is ethnicity with the high prevalence of the diabetes, and maternal age more than 35 years, family history of the diabetes, first degree relative of the diabetes, obesity, BMI more than 30 kg per meter square, and previous history of microsomia, that means birth weight more than 4.5 kg, and there is a history of polycystic ovarian syndrome, iatrogenic glucocorticoids and antipsychotic treatment. So these are the risk factors for the GDM. What is the pathophysiology? In pregnancy, there is a certain hormone releasing from the placenta, such as HPL, progesterone, estrogen, cortisol, and prolactin. These hormones are responsible for increased maternal insulin resistance. In normal pregnancy, this resistance is compensated by the beta cell overactivity. But in some cases, insulin secretion is compromised and blood sugar level is raised. So, maternal hyperglycemia lead to the increased glucose crossing in the placenta that lead to fetal hyperglycemia, and fetal pancreas start to secrete more insulin, and that lead to hyperinsulinemia in the fetus and lead to microsomia and metabolic complications. WHO recommends 25% oral glucose tolerance test performed after overnight fasting. The diagnosis of GDM is made if one of the following plasma glucose value is met or exceeded. The time during OGTT, the fasting more than or equal to 92 milligram per DL. After 1 hour of the OTT, 180 more than or equal to 180 milligram per DL, and after 2 hours more than or equal to 153 milligram per DL. KDA recommendation for the screening of diabetes in pregnancy. What is the time period for screening of the diabetes during the pregnancy? The first and prenatal visit 4 to 12 weeks. A screen for the pre-existing diabetes are using the fasting blood sugar and HbA1c. The diagnostic of the diabetes is fasting blood sugar is more than or equal to 126 milligram per DL, and HbA1c is more than 6 point equal to and more than 6.5%. At the duration of 24 to 28 weeks of gestation. A screen for the gestational diabetes mellitus. For using this 75 gram of OGTT, the diagnostic cutoff is fasting blood sugar more than or equal to 92 milligram per dl. After 1 hour, more than or equal to 180 milligram per dl, and after 2 hours, more than or equal to 153 milligram per dl. Any of the abnormal value, either fasting or after 1 hour or after 2 hours, any of the abnormal value lead to the GDM. At the duration of 4 to 12 weeks of the postpartum, a screen for the pre-diabetic and diabetic using the 75 gram OGTT with the non-for pregnancy diabetic criteria. What are the complications? Complication during the pregnancy and delivery. Maternal complication related to delivery, pregnancy and delivery, that is short-term complication and long-term complication. The short complication is preeclampsia, gestational hypertension, hydramnios, urinary tract infection and vaginal infection, instrumental delivery, cesarean delivery, traumatic labor, perineal tear, postpartum hemorrhage, and difficulty initiating and maintaining the breastfeeding. These are the immediate complication or short-term complication of the gestational diabetes mellitus. Fetal complication, short-term fetal complication, stillbirth, neonatal death, preterm birth, congenital malformation, microsomia, cardiomyopathy, birth trauma, hypoglycemia, hyperbilirubinemia, and respiratory distress syndrome. Complication after pregnancy. Maternal complication on the long term, recurrence GDM in the subsequent pregnancy, type 2 diabetes mellitus in future, hypertension, ischemic heart disease, increase the risk of the non-alcoholic fatty liver disease, dyslipidemia, and chronic kidney disease. Fetal and offspring complication on the basis of long term, that is metabolic syndrome, hyperinsulinemia, childhood obesity, excessive abnormal adiposity, high blood pressure, and earlier onset of cardiovascular disease. The blood sugar goal in the pregnancy associated with the diabetes. In pregnancy, glucose measurement, fasting blood sugar in the GDM must be maintained in between 70 to 95 milligram per dl. That patient is treated with insulin. If the patient is not treated with insulin, the goal is less than 95 milligram per dl. After first hour of postprandial glucose, the target is 110 and 110 to 140 milligram per dl if the GDM is treated with the insulin. But untreated patient target is less than 140 milligram per dl. After 2 hours of postprandial, the target is in the GDM treated with the insulin 100 to 120 milligram per dl, and without treatment with the insulin, target is less than 120 milligram per dl. What is the approach? If the fasting blood sugar level is more than 125 or PP is more than 199 milligram of DL, that is diagnosed as a diabetes, I refer to diabetes management. If the fasting blood sugar 100 to 125 and PP is 140 to 199, impaired glucose tolerance test, we consider for the referral for the management, weight loss, physical activity, counseling, and if needed, metformin. Next is, if the blood sugar level less than, fasting is less than 100 and PP less than 140, that patient is normal. Postpartum care. Insulin resistant decrease dramatically immediately postpartum, and insulin requirement need to be evaluated, adjusted. During pregnancy, we manage the diabetes with the help of the insulin. But after delivery, there may be not required insulin treatment for the future. So, regular assessment in the postpartum period, assessment of insulin requirement must be needed. Second option is contraceptive. We advise for the contraceptive because accidental pregnancy is highly complicated in the mother with the GDM. The women that a history of the GDM have the lifelong screening at every 1 to 3 years. The history of previous GDM and pre-conception planning for the subsequent pregnancy. Next pregnancy से पहले क्या हम लोग को करना चाहिए? Screen for the type 2 diabetes mellitus before the conception, and HbA1c assessment and OTGT assessment. Achieve healthy weight, balanced diet and regular exercise. Early antenatal booking in the next pregnancy, and early glucose testing. Lactation. Lactation is an important factor that decrease the insulin resistance. So, lactation of the GDM mother must be promoted. Contraception. Well-proof and highly efficacious contraceptive method should be advised for the patient suffering from the GDM. Copper, such as copper IUCD, levo, norgestrol, IUD, implant, barrier method, sterilization, use with caution. The dietary management. The patient suffering from the GDM must be advised dietary management at least minimum 125 milligram carbohydrate daily. Emphasize the whole grain, fruits, vegetables, legumes, lean protein, nuts, seeds and fish. Avoid sugary drinks and processed food. A small frequent meal with the controlled carbohydrate portion. Exercise at least 150 minutes per week, moderate to intense exercise, brisk walking, stationary cycle, swimming, 20 to 30 minutes most of the day of the week. Avoid high risk activity and exercise, contraindication. Take home message. Gestational diabetes mellitus, one of the most common medical complications of pregnancy, and that is increasing in prevalence globally. The GDM is associated with obstetric and neonatal complications primarily due to increased birth weight and major risk factor for future type 2 diabetes mellitus. And obesity, cardiovascular disease for the child. So detecting the GDM is important because perinatal complication and stillbirth risk for the increase reduced by the treatment. A GDM can be easily controlled by the diet and exercise. Insulin is the first line treatment for the GDM. Thank you.
Thank you, sir, for your amazing presentation, sir.
We extend our heartfelt gratitude to Dr. Ranjan Kumar sir for that deeply insightful and thought-provoking presentation. The gaps you have highlighted today, once our clinical practice most urgently addressed. Thank you so much, sir.
That brings us to the Q&A for our opening plenary. I now request our esteemed chairs, Dr. Amit Kishore and then Dr. Vaibhav Srivastava, to kindly moderate the discussion. The house is open for questions.
Any questions? I would like to add one more thing about MASH and diabetes synergy. That nowadays, Saroglatazar is a drug which is used commonly nowadays, and it's very helpful in controlling dyslipidemia. It also reduces the blood sugar level. So eventually it helps in improving the liver metabolic profile. So, and it is very commonly used nowadays. Saroglitazide, it comes by the name of Lipaglyn or Voxa.
I have a question regarding this diabetic autonomic neuropathy session. So what should be the first, if we are not having some adequate instrumentation, so how we should diagnose a patient that he is having a component of diabetic autonomic neuropathy? What common tests we can do in our clinic?
Thank you, sir. This is the very good questions regarding autonomic neuropathy. The basic questions, we have plenty of diagnostic tools, but where we can minimum resources where we have to diagnose. First of all, clinical. When sir patients will come and in OPD, in a walk-in patient, we have to ask the patient of clinical presentations, like patients having some palpitations because of heart rate must be high in the resting times. Patient don't have any other system involvement, don't have any infections, and patient is still having more than 100 blood beat per minute. So this is the one of the earliest sign can present with autonomic neuropathy with diabetes patient. And what are the clinical aspect, and this and other are the diagnostic tool. Basics are ECG. In ECG we can see the patients having HRV. Normally whenever we can see the ECG, there is somehow variation between the heart. So in lead 2 or any lead, if we can see the patient's ECG, there is some variability. Heart rate between the RR interval, there is minute variability. But if in patients with autonomic neuropathy confirmed, so we have look for heart rate variability is reduced, and in that patient QT prolongation is very significant. So this is the main first line diagnostic tool we can see the patient to diagnose.
About the orthostatic hypertension.
Yes, blood pressure regulation.
It is a very common thing that you take the reading in the supine position and then in the standing position.
Yes, sir.
You will get. And 2 or 3 symptoms which patient comes with diabetic autonomic neuropathy. One is this, they always complain that there is some sweating during mastication, gustatory symptoms. Gustatory symptoms are there, and this tachycardia, beside tachycardia, orthostatic hypotension is one of the factor from which we can assess. I have a machine in which all these Valsalva maneuver and these things are done, and the grade of diabetic autonomic neuropathy is clearly displayed. But those who are not having that much, then these 2-3 tests must be done to rule out the diabetic cardiac autonomic neuropathy. Thank you.
Thank you. Thank you, sir.
Any other questions from the audience?
That brings us to the conclusion of this session. We express our heartfelt thanks to our respected chairpersons and esteemed faculty for their invaluable contribution.
It has been a pleasure having you with us today. Your memento awaits you in the next room. Please do collect it at your convenience. We request our volunteers to escort our respected chairpersons to the facilitations area.
Good morning, ladies and gentlemen. We now transit into our session 2 for the day, Diabetes Care from Practice to Precision. This session focuses on key contemporary challenges in diabetes management, diabetic complications, precision nutrition, and evolving novel therapies shaping the future of metabolic care.
To chair this scientific session, we are privileged to have distinguished academician and clinician whose contribution to diabetology, medical education, and patient care has been widely recognized. I would like to request Dr. Sanjay Kumar sir and Dr. Ranjan Kumar sir from Patna kindly take the seat.
Thank you, sir, for your gracious presence. We now begin with the clinically important topic highlighting the diagnostic challenges and therapeutic complexities of type 1 diabetes presenting in adulthood, an entity often under-recognized in routine practice.
I humbly invite Dr. Saibal Guha sir for his wisdom on type 1 diabetes in adults, closing the gaps. Thank you, sir.
Pranam to my seniors in the audience and good morning, dear friends. From different topic, this is a slightly different topic than what was being discussed in the first session. So I'll be talking on type 1 diabetes and how to close the management gap we have. So what is type 1 diabetes and why it's a challenge in treating and diagnosing it? First and foremost reason is the misconception, because it's traditionally considered to be a disease found in children. But 50% of type 1 diabetics actually are diagnosed in adulthood, and most of them are misdiagnosed as type 2 DM. And this leads to delayed insulin initiation, increased risk of diabetic ketoacidosis, and poor long-term outcomes. We all know that the incidence of type 1 diabetes is rising. The adult onset type 1 diabetes is grossly under-recognized, and we don't have very strong Indian data. So probably because the disease is underdiagnosed to a large extent. So that is the reason why there's a large management gap. There is a gap in diagnosis, as we have discussed. It's often misconstrued and misdiagnosed as type 2. Then there is therapeutic inertia, which is mostly on our part. We fail to recognize type 1. We fail to initiate insulin right at the outset. And many a times we try with different oral drugs in the initial stages. Then there is a gap in access to technology. Access to technology, because we are a poor country, we have very poor insurance coverage. So there is difficulty in arranging for insulin pumps and CGMs, which are actually required in managing type 1 diabetes properly. Then there is a gap in education and awareness on the part of the doctors, on the part of patients, on the part of the society. And that awareness about type 1 diabetes, that any diabetes, even if it's present in adulthood, may be type 1, that lack of awareness at the time of diagnosis of the patient is a major risk factor why it's diagnosed late. And obviously there is a psychosocial gap, because a patient who is diagnosed with type 1 diabetes has to accept and concede to the fact that he has to take insulin lifelong, and that is a big cause of concern for the patient as well as for the family. So this is a major psychological concern which we need to address, and we need to counsel the patient. So counseling is more important in type 1 as compared to type 2, because the patient as well as the family has to be counseled that insulin is the only treatment, and it's very difficult to convince somebody who is apparently healthy till today and he is counseled tomorrow that he has to stay with insulin throughout his life. So there is a big role of counseling in this. Staging in type 1, just to reminder that there are 3 major stages. Stage 1, where more than 2 antibodies are present antibodies against pancreatic cells are present there. However, they have not so much damaged the pancreatic beta cells at the moment, so the blood sugar levels is normal. Stage 2 is when the antibodies are slightly more active, there is some more pancreatic beta cell damage, so the insulin production goes down a little bit, but it somehow manages to maintain the sugar levels. So stage 1 and 2 are pre-symptomatic stages. Stage 3 is where the damage to pancreas is even more. There is reduced secretion of insulin to a larger extent, and it fails to maintain the normal blood sugar levels. So stage 3 is the actual symptomatic stage, and obviously there is a long-standing stage where ultimately there is a large amount of beta cell damage, almost entire beta cell mass is lost, and the patient is fully insulin dependent. Immunopathogenesis, we all know it's basically an autoimmune disease. The beta cells are destructed autoimmunely by T cells or by autoantibodies, notably the GAT65 autoantibody, the IA2 antibody, and the ZNT8 antibodies. These are the three major antibodies which are present. However, again, as we said, there is a large amount of clinical heterogeneity, and that's what is the biggest challenge in diagnosing type 1 diabetes. Type 1 can be lean, they can be overweight as well. There may be rapid progression, as is usually the classical case, but the progression may be very slow, so that the C-peptide is visible in the blood even after, say, 15-20 years of diagnosis. Insulin requirement is very variable. Many patients require less amount of insulin. So again, there is a confusion regarding diagnosis in those patients. Overlap with type 2 features is another factor, because patients may be overweight. We have a concept that type 1 have to be lean, has to be a child, but it may be picked up in adulthood, and the patient may be obese. Then patient may lack ketosis initially, beta cell destruction is low, and they respond partially to oral agents. That can also happen in type 1. So there is a large amount of heterogeneity, large amount of overlap with type 2. And that leads to this misdiagnosis that 40% of type 1 diabetic patients are actually misclassified as type 2, especially in India, where phenotypes overlapping is much more, and that is the biggest problem. There's a large spectrum of type 1 diabetes. It's not very black and white, and we have a large area of gray in between. So the classic type 1 is where there is a rapid beta cell loss, there is lack of insulin, and the patient becomes insulin dependent at a very early age. Then there is LADA, which is slower progressing, adult age of onset. It's initially insulin dependent. So LADA is type 2 initially and becomes type 1 later, if you can say in simplified language, whereas ketosis prone diabetes, which is flatbush diabetes, is type 1 initially and may turn into type 2 later. That is a simplistic mechanism to understand these two terms. And there is double diabetes, where autoimmune markers are present, as well as evidence of insulin resistance are present right from start. So you can see that is a large spectrum, and there is a large amount of gray area in between. So that leads to misdiagnosis in many of cases. To simplify this problem, ADA has given a guideline that is how there are certain factors which may suggest the diagnosis of type 1. If they cannot clinch it, they can only suggest it. That is age less than 35, glucose more than 660, rapid weight loss, osmotic symptoms, ketosis or decay, poor response to oral agents, rapid progression to insulin requirement in less than 3 years, personal or family history of autoimmune disease, glycemic instability, and lean phenotype. Though none of these are mandatory, these are just suggestive. So the ADA recommended stepwise testing is first test for GAT65 antibody. If it's negative, we can go for IA2 and ZNT8 antibodies. But there is a caveat that single low titer positivity may be false positive. So we need to reassess the patients. Role of C-peptide, yes, there is a definite role, but there are limitations as well. C-peptide, again, here is the black and white and gray colors again play a role here. C-peptide less than 200, we can presume that the patient to be of type 1 diabetes. C-peptide more than 600, we can classify safely that this patient is of type 2 diabetes. But unfortunately, most of the patients we come across in our clinics has a C-peptide between 200 and 600. And there comes again the role of the gray area. and we have to repeat the testing, we have to do some clinical correlation, and we need to follow up these patients longitudinally, see the subsequent values of C-peptide. So the biggest part is this new diagnostic paradigm in diabetes is that diabetes classification is not dynamic. You cannot, a patient who is type 1 today can be type 2 after 10 years, and both the diagnoses are correct. So there's no hard and fast rule. Diabetes classification is no more static, and a repeated reassessment is very much necessary. Phenotype changes with disease progression, and this is especially relevant for LADA, ketosis-prone diabetes, and obesity-associated autoimmune diabetes. So the practical diagnostic algorithm is we have to have a strong suspicion of, a clinical suspicion of type 1. Then early insulin should be initiated if we are in doubt. C-peptide plus antibody should be used where feasible, and we should never delay in initiating insulin in a patient. As suggested by ADA, the various differential diagnosis of type 1 can be LADA, can be MODY, it can be ketosis-prone diabetes, it can be pancreatic diabetes, or it can be fibrocalculous pancreatic diabetes. These are the main differential diagnoses. So how do we go about managing these patients? Obviously, the first goal is to achieve near normal glycemia, then prevent complications, macrovascular, prevent glycemia-linked complications like DKA and hypoglycemia, and ultimately the aim is to preserve quality of life. And to aid in this, we have this precision medicine in this date of 2026. Precision medicine plays a very big role in treating all diseases, more so in these lifestyle diseases. Individualized glycemic targets should be fixed in that patient. Personalized use of technology has to be advised. Phenotype-guided therapy is the ideal therapy, and risk-based management is needed in most of the patients. Insulin is the cornerstone of therapy. It's mandatory in type 1. Early initiation is definitely helpful. We should avoid trial of oral drugs, and from insulin replacement alone, if the treatment has moved to technology-enabled, person-centered precision care. And we should always initiate insulin. We all know that that minimizes the risk of decay and prevents beta cell loss, prevents hospitalization and morbidity. Insulin, the gold standard is continuous subcutaneous insulin infusion, the insulin pump therapy. That is the gold standard of treatment. But unfortunately, that's very expensive. So the next best option is basal bolus therapy, which we usually do in our patients, and suboptimal for very challenged patients or where there is difficulty in arranging and training the patient. Premix can be used in these patients in such resource-limited settings. We all know about the insulin types, the basal, bolus, and the ultra-rapid ones, and those calculations, so I won't go into this. Coming to technology in type 2, CGM is the gold standard in monitoring a type 1 patient. CGM, and we have been doing SMBG, the self-monitoring of blood glucose, for years together. If you compare CGM with SMBG, CGM is just like a video show of an event, whereas SMBG is like the snapshots which our photographer is taking. So it gives us fixed snapshots, whereas CGM shows a continuous profile, just like a video photograph. In CGM, we have to follow certain metrics. The time in range, that is where sugar stays between 70 to 180, should ideally be more than 70% of the 24 hours we have in a day. Time below range should be 4% of 24 hours. And time in hypoglycemia, time that is the sugar stays less than 54 milligram per deciliter, should be less than 1%. That is the optimum goal of CGM therapy. And if you can increase the TIR, that's even better. And the importance of glycemic variability has also come up ever since we have started doing CGM. So the benefits of insulin pumps, we all know. The control is far better. Reduced hypoglycemia is there, and the accompanying indications are recurrent hypos, Dawn phenomenon, and hybrid closed-loop systems are even better. We can use artificial pancreas technologies, which are coming up now with the modern advent of AI. We are seeing more and more research into this, and we have this predictive low glucose suspend therapy have been incorporated in the recent insulin pumps, where it judges the patient's sugar fluctuations and controls the insulin infusion based on that particular patient itself. So there is a personalization of the pump based upon AI and algorithms, and that definitely improves especially the overnight control and the lower hypoglycemia burden. However, the Indian reality is cost barriers are the biggest challenge for treating any disease in our country, more so in this type 1 diabetes, because here high technology and insulin pumps are ideally needed. Then there is limited insurance coverage, and there is a vast urban versus rural divide, both in availability of technology, availability of treatment, as well as in comprehending the disease among the patients and among the practitioners in the urban and the rural setups. There are certain non-insulin therapies which are also tried in type 1 diabetes, like metformin and GLP-1 and SGLT2 have been tried in type 1 diabetes, for especially in obese type 1 diabetes, though none of the guidelines till now advocate their use, but off-label use is definitely used. Pramlintide is the only non-insulin drug which is approved by FDA to use in type 1 diabetes. It's a injectable amylin analog, and that's the only non-insulin drug which is advocated. The disease change, there's a radical change in therapy of type 1 has come ever since teplizumab has come into the market. Is the anti-CD3 monoclonal antibody, which is approved for delaying the progression of stage 2 type 1 diabetes to stage 3. And it basically works through immune modulation, and it preserves the beta cells in the long run. And this probably represents the first true disease-modifying therapy in type 1 diabetes. So we may not be surprised if some new drug come up over the next few years, because very good research in going up in monoclonal antibodies for treatment of diabetes, and there are talks of reversing the beta cells which have been turned senescent by autoantibodies. So we will soon find more and more drugs in this area. There are certain special situations of caution which we need to take care of, like episodes of hypoglycemia. We should be cautious about that. Psychosocial aspects of the patient, as I said at the outset, very important in type 1. We have to convince the patient and the family that they have to live with insulin for life. Just half a minute. So they have to live with insulin for life, and that is a big cause of depression in a person who was otherwise normal till a day back, and today is being told that he has to take insulin for the rest of his life. So it's difficult to explain that. So counseling is a very important part of treating type 1 diabetes, much more than type 2. So psychosocial aspect is a very important factor. Obesity in type 1 is again a challenge. We have to treat both the diseases together. And then prevention of diabetic ketoacidosis, again, that's a factor. We have to train the patient for sick day rules, to monitor his insulin level, monitor his sugar levels when he is sick, when he has fever, when he has any other disease. So coming back to where we started, how do we close the management gap of type 1 diabetes? We have to improve the diagnostic accuracy. So for that, we have to have a high clinical suspicion of type 1. Even if an adult comes with diabetes in your clinic, you have to keep in mind that that person, even though he is an adult, even though he is presenting with diabetes at the age of say 40 or 45, he still can be a type 1 diabetic patient. We have to initiate insulin at the earliest point. There should be structured education program both for the patient and the family. Increased access to CGM and pumps is ideally required, but it's costly. Multidisciplinary care between using the doctor's help, the clinicians, the psychiatrists, psychological counseling, then dietitians help, all is a teamwork. So multidisciplinary care is needed. So what we need to know about type 1 is summarized, is that type 1 adult onset is very common, so we often miss it. 40% are initially misdiagnosed at type 2. Antibody negative type 1 do exist, so just absence of antibodies doesn't mean that that patient is not type 1 diabetes. C-peptide interpretation again is dynamic. It may be low, it may be high. So again, it has to be repeated, and because the level varies. Diabetes classification evolves over time. So person who is diagnosed at type 1 today may be diagnosed at type 2 after 10 years down the line, and both the diagnoses are correct. CGM is the standard of care. Automated insulin delivery is transforming the outcomes, but it's costly. Teplizumab marks the era of disease modification, and psychosocial care is integral to management of type 1 diabetes. Thank you for your patient listening.
Thank you, sir.
Thank you, Dr. Sewal, for nice deliberation of timely diagnosis of type 1 diabetes in adults, and early initiation of insulin can save the patient from the glucotoxicity and a lot of other complications. So Thank you again.
Thank
We
you,
will
sir.
keep the discussions at the end.
Thank you, sir, for that insightful and informative presentation. The therapeutic landscape of diabetes is rapidly evolving beyond conventional glucose lowering agents with newer modalities targeting multiple metabolic pathways simultaneously.
To discuss this emerging frontier in diabetology, I humbly invite Dr. Subhash Kumar sir for his insights on triple agonists, the next frontier. I'm sorry, there's a change. We invite Dr. R.K. Modi sir for his insights.
Thanks, organizers, for giving this great opportunity. Respected Chairperson, my topic is diabetic food management, and it has got two parts. First is evaluation of diabetic food, why we need an evaluation and what to be evaluated and how we evaluate. And second part is the treatment and prevention of diabetic food. So it is customary to describe one-line definition of diabetes, that is chronic metabolic disorder affecting nerves, eyes, kidney, blood vessels and heart. And diabetic food is the result of either neuropathy or vasculopathy or its combination. But I must say, we as a clinician and patients both are responsible, because it is the ignoropathy from our side that has made this issue a very, very important issue in terms of prognosis. Because if you have a diabetic foot, you are going to have trouble in your life. 75 to 90% of major foot problem in India is due to neuropathy. And it's a major cause of morbidity, mortality with great economic burden, and there is financial as well as functional loss. The global prevalence 1.5 to 16.6%, and in India the prevalence is 11.6%. So let us see the magnitude. Why we need to evaluate a case. Because inadequate management can end in amputation. It is the commonest cause of non-traumatic amputation, and in every 30 seconds we lose one limb somewhere in the world, and 50% of limb with a foot ulcer can be saved. This is an ADA report. So 50% of the limb with a foot ulcer is preventable. So very important, and 85% of all foot related problems are preventable. This is also important because we know prevention has a big aspect in the management of diabetic foot. And let us see few facts about amputation, that diabetic foot ulcer, they end in amputation, and 50% of the amputations are transfemoral and transtibial level. 50% of patients will have second amputation in less than 5 years, and 50% of them will die within 5 years. In the same way, there are few facts about foot ulcer, that 15% of diabetic patients will have a foot ulcer in their lifetime, and 15% of them will convert in osteomyelitis, and 15% will end in amputation. So we should know the risk factor, and we should ask these things in history. And we should observe also, smoking is very important. Diabetic peripheral neuropathy with lots of protective sensation and peripheral artery disease. Biomechanical factors are very important, like foot deformity, callus, corn, bunion, hamartose, Charcot joint. If there is a history of diabetic foot ulcer or imputation, again a big risk factor. Of course, poor glycemic control, visual impairment, retinopathy and nephropathy. In India, barefoot walking is also common, and that is important risk factor. We should ask in history about leg fatigue, wrist pain, rubor on dependency, and pallor on elevation, because these things can give rise to and are the result of peripheral artery disease. How diabetes affects foot? It is due to neuropathy, all forms, sensory, motor, autonomic. We have loss of protective sensation means we have distal sensory motor polyneuropathy, which is a large fiber function. Motor weakness leads to wasting of muscles, crowding of toes, cock of toes, hallux valgus, clowning of toes, all structural changes giving rise to functional anatomical deficit. I will show you in my next slide. There may be autonomic dysfunction, and vasculopathy leads to reduced oxygen supply, and nutrition, claudication, wrist pain, rubber-on dependency, and pallor-on elevation are the features of vasculopathy. Now, there is a complex interplay between neuropathy, peripheral artery disease, and deformity superadded with infection. Now let us see the spectrum. There may be subjective complaints, dysesthesia, that is unpleasant sensation, numbness, burning, pain, tingling. These are the complaints patient will tell us, and we should see the objective signs, which are maybe smaller non-ulcer foot lesion like dry skin. We can see here dry skin, we can see here blister, we can see here dermopytosis of the space, we can see the corn, we can see the callus. What is callus? Callus is the thickening of the skin over the bony prominence, and in corn it is painful on the bony prominence. These lesions, they are the result of increased plantar pressure, and you should know that a baby ulcer is sitting beneath this, so it is very important to do the treatment of such conditions. Now, there are other risk factors. This pre-ulcerative lesion can convert into the foot ulcer, and we can have dry gangrene, and it has to be differentiated from wet gangrene, because dry gangrene is due to arterial obstruction. We can see a line of demarcation, and there may be autoimputation. At the other hand, wet gangrene is due to venous obstruction, and it looks slough will come, and it has a bad prognosis. That we can see here the classical neuropathic fit of diabetes. We can see the tendons, we can see the wasting of the muscles, and that can result in functional anatomical deficit that will lead to this hammer toes and this bunion deformity. We can see here the necrotizing fasciitis, another very serious complication of diabetic foot. You know, the fascia in the lower limb is continuous, and it is ascending infection, very fastly, rapidly progressing, most probably due to, most of the time it is due to Staphylococcus aureus, and if not taken care in early, it may lead in amputation of the limb. This is again very classical foot, swollen foot. Any swollen foot with intact skin, think of Charcot. This is another high arch foot giving rise to the pressure point. This is again Charcot foot, and look at the X-ray. The normal convexity of the medial arch is lost, and it becomes convex, and there is abnormal pressure point generated to the fracture, and you can see the ulcer here. Any ulcer which is on the bony prominence is non-healing, go for an X-ray. You will have a report like this of destruction of the bone, so never miss such thing in your practice. So there is 15% risk in lifetime, and most common site is high pressure zone, especially in the forefoot, and it is caused by the bony prominence, ill-fitted footwear, foot deformity, and limited joint movement. Must do probing to rule out bony involvement, and do an X-ray to rule out osteomyelitis. This is a Wagner classification. It's very important to classify the diabetic wound. Grade 0, there is no ulcer, but the foot is high risk. In grade 1, there is superficial ulcer. In grade 2, there is deep ulcer. And in grade 3, we have osteomyelitis. Grade 4 is localized gangrene, and grade 5 is extensive gangrene. So here are a few deformities. Now, let us see the vulnerable points for friction. And these are the vulnerable points. This arrow are indicating the high pressure point, and that leads to pressure sore ulceration. And here we can see bunion deformity, flat foot, hammer toes, all are high pressure point that can give rise to a foot ulcer. Now this is very important, and it is important to understand that God's greatest test, it is the greatest gift to mankind is pain. And we should remember the painless disease of diabetes. That is very important to understand, because once we understand that disease is painless, we can understand it is real neuropathy. So how ulcer develops? In a normal food, when there is repetitive stress, there is inflammation, there is pain, and it goes to brain center, there is modification of the gait, healing process begins, there is repair of the tissue, and everything becomes normal. But what happens in diabetic food? Repeated stress or friction causes inflammation, but no pain. We remember that diabetes is a painless disease, so no response from brain, continuous use, and non-healing of the foot ulcer. So these are the few important slides that I have taken from my clinic. We can see in Namaz portion continuous repetitive fraction, and that has given rise to this callosity over the bony prominence. This is again, we can see during this palsy posture, touching of this malleoli to the ground, giving rise to right malleolar bursitis. You know the treatment is very easy. I ask my patient to put a cushion here and also avoid to sit this palsy posture. So this will solve the problem. So again, ill-fitting footwear can cause ulcer and blisters. We can see here. So avoid wearing this poor-fitting shoes, very tight. We can see the friction point, and this is again a show due to the blister due to the footwear. Shoe bite. This is Charcot foot. We can see any ulcer. If you get ulcer in the mid-foot, think of Charcot, because this is an unusual site. And if you get an X-ray done, we can see all this foot looks like a bag of broken bones. And because normal arch is being disrupted, and we can get an X-ray like this. So how to diagnose it? Very important. What you need, your will and 2 minutes time. We have to diagnose this small fiber function by simple pinprick, large fiber function by DTR, and protective sensation by 10 gram monofilament. So 2 tests confirm loss of protective sensation. One is monofilament, and any other test like reduction in the temperature, reduction in the pinprick, and reduction in the DTR. So these are the few gadgets that will help us to diagnose neuropathy. Vasculopathy dissection, very important. By simple palpation of the peripheral pulse, we can detect dorsalis pedis, posterior tibial. We have sophisticated infection hand Doppler that can measure the ankle brachial index. Examination of footwear is very important, because no evaluation is complete without examination of footwear. Impression on the insole and wearing out of the outsole points toward the high pressure area of the foot, and we can see here the wearing out of the outsole, that is indicating a pressure point here. Coming to the management, it is a teamwork. Multidisciplinary approach is required. Tight metabolic control is an essential factor, and we should know the principles of the management of diabetic foot. And it is applied to all wounds, all diabetic wounds. Global application. Number 1 is good metabolic control, appropriate antibiotic, extensive debridement, and offloading. And in few selected cases, there may be need of revascularization, especially in cases of ischemic ulcer. If you remember these 4 points, we are going to manage every diabetic foot, and it is acceptance is global. In all wound, you have to apply good metabolic control, appropriate antibiotic, extensive debridement, and offloading. So the first step is to classify whether it is non-limb threatening, or life-threatening. Non-limb threatening, limb is unaffected, maybe limited infection. In limb threatening, there is infection. In life threatening, with infection, there is metabolic instability and systemic toxicity. These are a few non-limb threatening conditions like callosity, cord, dermatophytosis, deformities, fissure and cracks, hypertrophic bursitis, mild infection, and the treatment is minor OPD procedure, antifungal drug, customized preventive footwear, moisturizing lotion, rest of the affected area, and empirical antibiotics like moxifloxacin, cephalexin, legionelate, and azithromycin. Limb-threatening and life-threatening conditions are important. They need indoor admission and help of a surgeon. Discuss regarding the correction of dehydration by appropriate intravenous fluid, insulin infusion, adequate nutrition, selection of empirical antibiotic in consideration to the renal status before the result of culture sensitivity comes. And always remember, the final choice of antibiotic depends on the result of culture sensitivity. And the material, it must be cured from the deep tissues, not from superficial tissues. So offloading is very important. It reduces the plantar pressure and shear force at the site of ulceration and redistribute weight bearing and improve circulation. This is few offloading devices. We can see here total contact cast, this ortho-wedge, this is anterior ortho-wedge for anterior ulcer from the anterior aspect of the foot, posterior wedge, rock or bottom for redistribution. We can give such type of hands out in our clinic. We can display poster like this. And finally, to conclude, prevention is the first and last weapon for the management of diabetic foot. Any new diabetic patient, when with his first interaction with physician, is being instructed about foot care. That is a preventive strategy, and even a serious complication occurs and ends in amputation of limb, he is again instructed to take care of unaffected remaining limb and care of the stem. So the journey begins with prevention and ends with prevention. So must touch feet of your diabetic patient, prevent them, must take blessing from them. Journey begins from prevention, ends in prevention. Thank you very much for your patient listening.
Thank you, sir, for very lucid presentations. We will take question answer in the last.
Thank you.
Thank you, sir, for that highly informative discussion. In the Indian setting, the gala of festivals and happiness of social eating patterns significantly influence glycemic variability and therapeutic compliance.
We humbly invite Dr. Kamran for his insights on glycemia management. We humbly invite Dr. Kamran for his insights on glycemia management in festivals.
Dr. Kamran, sir.
Good morning, everyone, and I am really thankful to RSSDI Bihar team for inviting me to speak on something which is slightly different, which is having a social component. And to start with, what's the glycemia management in festivals? We have so many festivals in our day-to-day life. Festivals are there, marriages are there, ceremonies are there. So finally it takes the toll of having a dysglycemic state all around. So what's the hidden challenge? That 40 to 70 feasting days a year for an average Indian with type 2 diabetes or type 1 diabetes, and it may exceed 80 to 100 days, especially for women, because they are more into these festivities, including the active families, festival, weddings, birthdays, religious gatherings, and so on. So how these days are coming from? Major festivals like Holi, Dasera, Diwali, Eid, 15 to 25 days a year. Family functions, shadi, 10 to 20, marriages, birthdays, community and religious fasts, feasts, 5 to 15 days a year, and social celebrations, 10 to 15 days a year. So we spend most of our time in feasting and not in fasting. So both the things are prohibited in diabetes, fasting as well as feasting, but we Indian are more into this. And that's why Dr. Ravi Modi in an earlier session told us that this ignoropathy. So diabetes complications are nothing but an ignoropathy. So what are the hidden impact? 50 festive days a year, that comprises of 14% of the year, of total days. We dwell in this glycemic state. And the complications are acute hyperglycemia due to high glycemic loads, carbohydrates, refined flour products, sweets and desserts, gulab jamun, and all ice creams and large portion size, ये सब चलता है. And then PPG excursions 50 to 150 milligram per deciliter above usual levels. We ignore it. चलो आज एक दिन खा लेते हैं फिर तो मौका नहीं मिलेगा. And that reflects in HbA1c increase as well as this glycemic variability, which is the main thing which causes damages to every organ, and this is totally disturbed. Weight gain is another issue. So we can call it intermittent celebratory overnutrition, which is not intermittent in our society, it is continuous. So what is the glycemic control? We all know about this, and we all know how this control can be achieved through different mechanisms. We have GLP-1 GIP pathways, we have glucagon counter regulations, HGO we have, and ADA standards of care says that even modest improvements in HbA1c 0.5 to 1% can reduce significantly many microvascular complications. So why festivals are high risk periods? Overeating is there due to many obligations, due to relationship with the patients, how they are related. अगर in-laws हैं तो उनको ज़बरदस्ती खिलाया जाता है. High GI festival foods. There are no festival in which a food corner is kept which is dedicated to diabetic patients. It is all common. Alcohol intake is there. I'll not take its name here because it's a dry state. Irregular meal timing, stress and sleep loss, रात भर जगना है, reduced activity. So we have many things which are there in the festivals. Gulab jamun, GI 75 and 400 calories per 100 gram. Then we have laddu, 450 calories per 100 milligram. दो तीन तो जाना ही है. Jalebi mithai, GI 85 and puris and naan 60 to 80 GIs and maida based. So this intake of this food causes huge postprandial excursion, and they may lead to reactive hypoglycemia even in some cases. So we have the stable pre-meal condition, and then sudden postprandial spike is there, hyperstimulation of beta cell is there, and then insulin surge may cause this this reactive hypoglycemia. So liquid fructose and refined carbohydrate bypass satiety signaling, so this should be used, and this is the fastest route to postprandial hyperglycemia. Then comes this CGM values. We have target of TIR 70%, more than 70%. But in these situations, in the festivals, you are seeing the totally deranged parameters of postprandial excursions, and not to say about TIR. So glycemic variability may be very harmful than persistent hyperglycemia in driving vascular complications. This GV is the main offender. We know all this. And this may be over-treated. What happens after overeating? Phase 1 response. This rapid preformed insulin release from beta cells granules, first defense against incoming glucose is the phase 1 insulin, which is blunted in type 2 diabetes. So it is there. Phase 2 response, which persists for 10 to 120 minutes, in which sustained insulin synthesis and secretion is there, and it maintains the blood sugar level. And then comes the pancreatic overload, which is quite active in this festive season with chronic hyperstimulation and emergency response stress in beta cells, and the pancreas cannot recover between meals, and the long-term irreversible capacity loss may be there. So this hyper ingestion of high carbohydrates loads can result into total derailment of the pancreatic response, and this may lead to many of the metabolic derailments like increased free fatty acid release, increased insulin resistance, and GLUT4 translocation getting reduced. So in this situation, glucose remains elevated and the damage keeps on getting done. So high-risk behaviors during celebrations, that is there, that buffet eating is there, mindful consumption is, mindless consumption is there, जितना है उतना उठा लो, पूरा प्लेट भर जाना है, alcohol intake, skipping medication, late night eating, sugar drinks are in plenty, and stress eating is also there. So any single behavior above can destabilize glycemic control. Combination during festivals compound risk exponentially. So dietary management, which is not possible in this festivals, which I have depicted here, that ADA plate method, half vegetables, quarter protein and quarter carbs, it is not there, but it should be there. So for standard type 2 diabetes, 40 to 60 gram per meal of carbohydrate should be there. And for tighter control, 30 to 45 milligram per meal should be there. But we are discussing this festival, so it is not feasible. And besides in normal situation, we must eat slowly. 20 minutes leads to satiety lag. And besides that, it should contain high fiber content to reduce the postprandial spikes. So what could be the smarter festival food choices? In place of gulab jamuns, we can have roasted almonds and walnuts. In place of jalebi, we can have makhana. For laddu and barfi, we may have chana, roasted chickpeas. Then paneer tikka for laddu and barfi and other fruit juices. And dark chocolates and shrikhand for white rice, naan and puris. I don't think anyone will go for the smart choices, even he is a frank diabetic and with HbA1c more than 9. So move more, hydrate better. There are some tips during festivals. Hydration should be adequate, sweetened beverages should not be taken, physical activity should be enhanced, beside yoga, dance and light aerobics. And we must be having a patch in our forearm. This is CGM reading, which we can be alerted when our sugar level gets very high, and we have to maintain TIR. So during festivals, it is advised to wear a CGM patch or have a CGM, so that you may not go run amok or berserk like a wild elephant eating everything which is coming in way. So we have to take care of this. We have to educate the patient about this. And in the era of ignoropathy, it is very difficult to educate the patient, and we don't have enough time for all these. And the scientific understanding as well as the honesty of the patient is in question, because most of the patients tend to lie that they have not eaten this and they have not eaten that, and that way we are misguided also. So it is a complex thing, but still we have to make it harder. We are from the organization of RSSDI, which is making awareness among the people that diabetes is a disease of discipline. Whatever discipline you are maintaining, it is going to reflect in your number of lives you are living in better quality. So pre-festival monitoring includes pre-meal assessment, post-meal assessment, bedtime check, post-activity check, and target range should be met, like fasting 80 to 130 and post-meal less than 180. So if reading is more 250, then we have to take the adequate measures. And never skip your therapy during festivals also. Oral medications like metformin, SGLT2 inhibitors, GLP-1, DPP-4 and sulfonylureas, they should be continued. And insulin therapy should be continued, whatever the situation is, whatever the social phobia or social inhibitions are there, you have to take insulin during festivals and social gatherings also. Never to self-discontinue any anti-diabetic medication. We tell this in type 1 patients also, that missed doses can lead to significant metabolic abnormality like HHS and DKA. And there should be phone alarms, pill organization and travel kit during the management in festivals. So insulin safely during festivals should be kept, and for that basal insulin is the best thing. And we can also have this basal and bolus combination for those people who are going to eat in any way. And self-correction dose protocol must be avoided in this situation because the eating pattern is very erratic. And hypoglycemia preparedness, especially the reactive hypoglycemia, when somebody eats too much to overstimulate the beta cells, then they should be counseled and educated well about this also. So all these precautions patient need to know all these during the festivals. And the elderly patients, type 1 patients, pregnancy and GDM patient needs extra precautions, as well as those who are having CKD or DKD, cardiovascular disease, children and pediatric type 1 diabetes. So altogether every patient except robust, healthy type 2 diabetic patient is spared here. Otherwise every patient needs to have a good extra caution during festivals. What are the emergencies related to festivals? Hypoglycemia is a major thing. Tremor, sweating, palpitation, confusion, loss of consciousness is, if it is all there, we all know the symptoms of hypoglycemia. Severe hypoglycemia may present like HHS or DK. Diabetic ketoacidosis and dehydration may be there. And if it is there, then one must be shifted from the festival site or marriage site to hospital. So guidelines, recommendations are there. ADA standards of care, we all know about that. That TIR should be maintained 70% of the time within 70 to 180. And preferred agents, GLP-1 agonists and SGLT2 inhibitors to protect CV and CKD things. Physical activity, we have IDF global guidelines which promotes more about SMBG, sick day rules and lifestyle first. And festival specific emergency kits should be kept in ready, pre-festival check should be done. And family involvement, it is very important that you educate the family members that if you are going to attend a festival or ceremony, then you must be aware that how you can keep your patients happy during all these things. So I don't think by diabetes survival, festival survival kits include this glucose tablets, this glucometer, pen, as well as CGM device. So celebrate safely, control confidently, stay active, personalized care. So thank you for patience listening. This is a mango from Bhagalpur, which is very famous for the dalu aam. So there is a question always that if mango eating is safe or not. Dr. Ravi Modi was discussing to me. Dr. Anup Mishra has recently have shared some studies regarding this. Sorry, keep it there. This slide, last slide. So he cited 2 studies, and study 1 pilot and study was 2 to 8 weeks RCT, and it was there in CME group of Dr. N.K. Singh sir, and CME India Pulse was there regarding this mango. I have taken it from there, and he says that no harm possible, benefit in glycemia for the mangoes like Safeda, Dasheri, Langla versus bread OTT plus 3 grams, and it was reflected in OTT plus 3 days CGM, as well as within prescribed diets, mangoes are not detrimental and may benefit glycemia only under nutritionist supervision with calorie limits. You can have some mango. We suggest 90 grams per day, but your HbA1c should be below 7. Thank you for patience listening.
Thank you, Dr. Kamran, for very nice description of dietary discipline, particularly during.
Yeah. भेज देंगे सर आते आते अभी तो actually it is a very delicious from Bhagalpur. Zardalu aam is a GI indexed aam without carbide. Thank you, sir. I think Dr. Sumit is.
Thank you, sir. Nutritional management remains fundamental to diabetes care, yet continues to be influenced by conflicting dietary trends, evolving evidence, and challenges in long-term adherence.
To discuss evidence-based individualized nutritional strategies, we have Dr. Sumit sir for his lecture on personalized nutrition myth versus reality.
Thank you, respected seniors and my dear colleagues and juniors. I am Dr. Sumit. I am from the furthermost part of the Bihar, that is West Champaran, Bettiah. And for the people behind the auditorium, अगर आपसे मैं ये पूछूं कि आप लोगों को सब किसी को ही केवल टी शर्ट एंड जीन्स पहनना है फॉर लाइफ लॉन्ग, या नॉर्थ कोरिया की तरह केवल एक तरह का ही हेयर स्टाइल रखना है, तो क्या ये एक सही बात होगी? तो जब हम लोग हेयर स्टाइल्स और क्लोथ्स में इतना या एम साइज शर्ट सबको पहनना है या टी शर्ट्स पहनना है, तो क्या जब हम लोग क्लोथ्स और हेयर स्टाइल्स में इतना चूजी है, तो फिर डायबिटीज में जो हम लोगों की या किसी भी चीज़ में हमारा जो न्यूट्रिशन है वो कैसा होना चाहिए, ये केवल वन साइज फिट्स ऑल वाले सिद्धांत पे क्यों चलना चाहिए? तो आज इसी को लेकर के आज हमारा पहला जो टॉक है, द पर्सनलाइज्ड न्यूट्रिशन मिथ वर्सेज रियलिटी. So, as you can see, this topic explores the emerging field of tailoring dietary advice to individual needs rather than relying on one-size-fits-all guidelines. It contrasts popular misconception with current scientific evidence, highlighting the promises, limitations and practical applications of personalized approaches. ये कोई मैजिक पिल नहीं है, या कोई मैजिक क्योर नहीं है, या कोई एक ऐसा चीज़ नहीं है जो कि आउट ऑफ द वर्ल्ड है. हम लोग के भारतीय परंपरा में इसको हम लोग बहुत पहले से करते आ रहे हैं, लेकिन हम सभी के डायबिटीज क्लिनिक पे एक चीनी का पर्चा रहता है जो कि हम लोग हर पेशेंट को देते हैं. लेकिन इन द कमिंग ईयर्स देयर विल बी द गैम्बल स्क्रीनिंग. द गैम्बल जी स्टैंड फॉर genetics, A for age and sex, M for the microbes of the gut, the B are the blood biomarkers, L is the lifestyles, and E for eating plans which are optimized for each and every individual. So the personalized nutrition also called as precision nutrition. ऐसा न्यूट्रिशन जो कि आपके लिए ही पर्सनलाइज्ड है, प्रिसाइज्ड है और आपके लिए ही हेल्प करता है. At the use of individual data such as genetics, microbiome, blood biomarkers, lifestyles, age, sex, and metabolic response to create an optimized eating plan. This contrasts with the traditional public health that recommendation, जैसे carbs are bad for everyone, protein are good for each and everyone, to apply broadly to the populations. Interest has surged due to advances in nutrigenomics. What is nutrigenomics? That how nutrients affect genes expression and how genes influences the nutrient responses, according with which you use affordable testing and apps. So in the before slides you can see there will be nutritionists which will assess all these records and then optimize your eating plans. The core message: while personalized nutrition holds real potential, many claims are overstated and it is not yet a magic bullet for everyone. It is not a magic bullet, but the scope is huge. आगे से आपका न्यूट्रिशनल काउंसलिंग में आपका जेनेटिक्स टेस्ट होगा, आपका ब्लड बायोमार्कर्स होगा, आपका लाइफस्टाइल पूछा जाएगा, आपका गट माइक्रोब का असेसमेंट होगा और उसके बाद आपके लिए ऑप्टिमाइज ईटिंग प्लान्स होगी. It will take a much precise approach. So, personalized nutrition, your unique path to the optimal health. As you can see, there are mobiles app which will track your nutrition. There will be continuous glucose monitoring, as Saibul Gua sir has quoted, the gut microbiome analysis, and there will be moving beyond one size fits all. The problem with generic advice is this. not everyone fits in the same criteria, and generic guidelines often miss individual needs. And there is raw data ko personalized profile banana, it is our main motto. The core inputs, what defines your unique profile, is the genetics, it's the microbiome, it's the biometrics, blood, and the lifestyle or diet. The 4 pillars which are being seen there. What are the benefits of the precision? It's an evidence-based result. There will be optimized metabolic health, sustainable weight management, improved long-term wellness. And so what will be the key takeaway? That will be unlock your potential. आपके जेनेटिक्स में कितनी ताकत है, आपके माइक्रोब्स में कितनी ताकत है, आपके ब्लड बायोमार्कर्स में कितना ऑप्टिमाइजेशन करके हम आपको बढ़िया से बढ़िया हेल्थ दे सकते हैं. दैट इज पर्सनलाइज्ड न्यूट्रिशन. द डेटा ड्राइव बेटर dietary advice choices and focus on individualized long-term health. And it shifts from the marketing buzz to evidence-based science. So मेरे से बहुत सारे लोग पर्सनल कुछ सवाल करते हैं जिसको मैंने एक साथ किया. इज पर्सनल न्यूट्रिशन जस्ट एन एक्सपेंसिव डीएनए टेस्टिंग फॉर वेट लॉस? केवल पैसा कमाने का एक टेक्निक है कि हाँ भाई डीएनए टेस्टिंग करा दिए? द आंसर इज एन एब्सोल्यूट नो. It is a premium fat, जो myth है, it is a premium fat diet service promising effortless fat loss through genetic reports. बिना कुछ मेहनत किए, just like Ozempic, आपको weight loss हो जाएगा, इसके लिए ये एक gene testing होती है. No. It is broader than the genetics alone and not a primarily a weight loss tool. It is not primarily weight loss होता है, no doubt, लेकिन एक optimized weight loss तक जाते हैं, उसके बाद आपका weight loss नहीं होगा. Personalized plan aim for an optimal health, disease prevention, better energy, gut health and metabolic balance. Genetic test with nutrigenetics जो हम लोग करते हैं, provide insights. ये अभी काफ़ी costly है, लेकिन in the coming years we hope that it will be in affordable range. Provide insights such as variation in the FTO gene linked to appetite and fat metabolism or lactose intolerance gene. So there is a study called Food for Me project. और ह्यूमन जीनोम प्रोजेक्ट से भी इसका लिंक है. सो आई वाज स्टडी लाइक फूड फॉर मी प्रोजेक्ट शोज दैट कंबाइनिंग फिनोटिपिक, दैट इज ब्लड बायोमार्कर्स एंड जीनोटिपिक डेटा यील्ड्स बेटर डाइटरी इम्प्लीमेंटेशंस एंड इम्प्रूवमेंट देन जनरल एडवाइस. बट वेट लॉस रिजल्ट में वेरी. मैनी पीपल रीच अ हेल्दी सेट पॉइंट, एक 50 किलो 70 किलो जहाँ तक आप हेल्दी सेट पॉइंट है, एंड देयर दे स्टॉप. देयर इज नॉट अ ड्रामेटिक वेट लॉस. कॉस्ट इज डिक्रीजिंग विथ एक्सेसिबल एप्स. आजकल एप्स आ गया है, सब कुछ प्ले स्टोर से कर सकते हैं. एंड एट होम किट्स लाइक CGM एंड ब्लड मॉनिटरिंग किट्स एंड बेसिक पर्सनलाइजेशन कैन स्टार्ट विद अ सिंपल ट्रैकिंग ऑफ पर्सनल रिस्पॉन्सेज टू मील्स लाइक CGM. इट इज नॉट एक्सक्लूसिवली एक्सपेंसिव और लिमिटेड टू DNA. सो क्वेश्चन 2, डज वन साइज फिट्स ऑल डाइट वर्क्स फॉर एवरीवन? एक ग्लूकोज चीनी कम खाने का चार्ट क्या सबके लिए बराबर है? सो यूनिवर्सल रिकमेंडेशन लाइक कार्ब्स आर बैड्स एंड एवरीवन शुड डू कीटो या प्रोटीन बहुत ज़्यादा खाना चाहिए, ये डज नॉट सफाइस. इवन आइडेंटिकल ट्विंस को भी हम लोगों ने सेम डाइट देख करके प्रैक्टिस इसके लिए किया है, और इस पर स्टडीज है दैट आइडेंटिकल ट्विंस कैन रिस्पॉन्ड डिफरेंटली टू द सेम फूड्स ड्यू टू माइक्रोबायोम, लाइफस्टाइल एंड सर्टेन जेनेटिक डिफरेंसेज. Personal nutrition accounts for this variability. Evidence from studies show superior outcome in diet, quality, cholesterol, mood, and heart risk marker advice it teller. लेकिन कुछ है जो कि हम लोगों को करना है. But some foundation principles like eating more plants, fewer ultra processed foods like maida, and balancing calorie remains universal. ये सब तक रखना ही है. इसके अलावा कुछ पर्सनलाइजेशन हम लोगों को करना है. The question 3 or the myth 3 that genetic determine everything. Many assume that a genetic DNA testing dictates your preferred perfect diet forever. In reality, genetics explain only a part of the picture. Epigenetics, that how diet and lifestyle influence gene expression, the gut microbiome, sleep, stress, exercise, environment play major roles. Nutrigenomics, so nutrient can turn genes on or off, but results are probabilistic, not deterministic. 100% sure नहीं है कि nutrients can turn off a gene or not in each and every individual. So the Academy of Nutrition and Dietetics has started at that genetic-based personalized nutrition is not yet ready for routine practices. Small studies and limited cost effect proof. हो सकता है 4-5 साल बाद इस पे और सारे स्टडीज हो, इसी फोरम में हम लोग इस पर और डिटेल में बात कर पाए. Question 4 सबसे पहले eat personalized nutrition है fad with no science, एक बिना बेस पर का फ्लैट टाइप थ्योरी टाइप की चीज है. नो. Fields like nutrigenomics have roots in the human genome project जो हमारे अभी भी चल रहा है कि हम लोग सारे ह्यूमन जीनोम्स की ट्रैकिंग करके एक हम लोग ह्यूमन जीनोम का पूरा सीक्वेंस बनाएंगे. Randomized trials like Food for Me demonstrate that personalized advice leads to better adherence and outcomes. Machine learning models now predict post-meal blood sugar responses using microbiomes or other data. Many direct-to-consumer products promise more than they deliver. Along them, इसीलिए हमेशा प्रोडक्ट बेस पे जो डिलीवरी है आप अपना CGM से चेक कर लीजिए कि भाई इतना खाने पे मेरे पास मेरा कंटिन्यूअस ग्लूकोज मॉनिटरिंग कुछ अच्छा हुआ है कि नहीं हुआ. And that men and women had identical needs? No. Sex hormones, age and lifestyle matter significantly. Women may have different iron, calcium and omega-3 needs due to menstruation and pregnancy. Other adults require more protein for muscle preservation. So in conclusion, what works today? The evidence-based applications, metabolic testing, CGMs, reveal food responses, helping stabilizing energy, microbiome analysis, emerging data links gut bacteria to the nutrient processing and inflammation, integrated approaches, combining self-tracking biomarkers, genetic and coaching yields sustainable changes, practical starts, no test needed tracking as per symptom, energy, digestion after meals, can easily assess your response to the diet, adjust based to the results. Focus on whole foods, variety and consistency. What are the challenges and the ethical considerations? Limitations include high cost for comprehensive testing, data privacy, unequal access, and risk of misinformation. Over-reliance on unproven tests can lead to unnecessary restriction and anxiety. Strong emphasis on the consulting registered dietitians का इसमें बहुत बड़ा रोल है, and prioritizing sustainable habits over trend. In conclusion, balance optimism हमेशा बहुत ज़्यादा हम लोग enthusiastic भी नहीं होना है, बहुत ज़्यादा negative भी नहीं रहना है. Personalized nutrition represents a shift from population averages to individual reality. It is not fully mature yet. Myths arise from marketing type and hype, while reality lies in integrating science with practical and holistic lifestyle changes. Future direction includes better AI integration, larger trials, and accessible tools. The key takeaways: start with fundamentals, balanced diet and activity, layer on personalization where evidence supports it, and remain skeptical for miracle claims. There is no miracle cure for weight loss. I am the example for that. And also there is no miracle for any chronic disease like diabetes and hypertension. It should be always conveyed in the public. Personalization empowers informed choice rather than dictating rigid rules. This approach can reduce chronic disease risk more effectively than generic advice for many people, but it requires patience, critical thinking, and professional guidelines. So thank you for your patient hearing. Being a Bania, I have saved 2 minutes of the time of the audience, so that will suffice.
Thank you, Dr. Sumit, for clearing lots of myth regarding very debatable subjects. We will take question answer in the last and move to the next talk.
Thank you, sir, for that insightful and informative presentation. The therapeutic landscape of diabetes is rapidly evolving beyond conventional glucose lowering agents, with newer modalities targeting multiple metabolic pathways simultaneously.
To discuss these newer modalities as an emerging frontier in diabetology, we humbly invite Dr. Subhash Kumar sir for his insights on triple agonists, the next frontier.
Good afternoon, everyone. Respected seniors, national EC members are here, RSSDI. It's a great opportunity. Dr. N.K. Singh sir, V.K. Singh sir, and all senior colleagues. Dear friends of this medical college, first of all, it's a great honor for me to be here because this is my birthland. हम यहीं से हैं, डेहरी ऑन मेरा जगह है. So I am in my hometown, you can say. I have stayed less time here, and my father is also in the audience. So it's a great opportunity for me. You know, the management of obesity, as Dr. Sumit was talking, is not easy, but then the management of obesity and diabetes has come to an era of transformation. And this is going to be an era where the whole guidelines are going to be ruled by incretin-based therapy. After the advent of incretin-based therapy, particularly GLP-based therapy, GLP-GIP combination, the whole research has shifted towards the goal to achieve this incretin-based therapy. And in that, the new drug which is going to be a blockbuster, I can say, are going to change the big scenario of management of metabolic disorders are triple agonist. These are also known as triagonist, which work at 3 metabolic parameters. So with one molecule, we can target 3 different metabolic pathways, which can give you a very robust glycemic control, a very strong weight reduction, I can say, and also all other metabolic related disorders like cardiovascular issues, renal and MSALDs, and all other related issues of metabolic disorders. So we have a country, now you can look at worldwide also, obesity is going to be one of the biggest challenge for all healthcare population, and including in India. Half of the obese people are diabetic, 1 billion worldwide, and 537 million adults globally are diabetic, and the crisis is added by MASLD and cardiometabolic complications. So the evolution of incretin-based therapy is to target that particular part of defect. We have advent of GLPs, 1 receptor agonist. It came as a liraglutide, and which showed over a period of time. Initially, we all were hesitant, and when we learned first time when it was launched in 2005, I still remember it was taken as a drug which can cause some type of malignancy or something else, because it used to reduce the hunger and appetite, and there was a decrease in peristalsis. So it was a big problem for people to take and understand, and particularly people to use it. Now from GLP receptor agonist, now it is off patent, so we have generic cheaper versions also. Dual agonist like GLP and GIP is doing very great because it shows better weight reduction. I'll talk a little bit about it. And now we have triagonist, where we are going to have a single molecule which can target 3 metabolic pathways. And by using it, what we can achieve? We can achieve a metabolic arrangement, metabolic correction as good as bariatric surgery. So now we are going to enter a medical bariatric era where we have to have this triple agonist. Triple agonists represent GLP-1 receptor agonist, GIP, which we understand physiologically that these are incretin hormones which are secreted from K and L cells of intestine, and now we are going to add it with glucagon receptor agonist to these 2 agents. These unified approach target multiple pathways which can have a future integrated therapy in metabolic disease. So we know GLP-1 physiology very well now, because we know it stimulates beta cell. We have this in our physiology days from Perley and Kipling's theory, which you can see in your Guyton book as well now, that these hormones used to be chemical signals from these K and L cells to the beta cells, to the pancreatic tissue, which stimulates insulin secretion and which is glucose dependent. So it stimulates beta cells, and also it minimizes hypoglycemia, because the insulin will be stimulated only when the glucose is high, and on top of it, it is going to have a benefit of appetite and weight reduction, because it suppresses appetite, it targets the arcuate nucleus at hypothalamus, which is our appetite center, and also it delays the gastric emptying, promotes weight reduction, and deliver cardiovascular protection, which is very important. So we have GIP also to add to it. Initially we thought GIP is not effective because we used to use GIP separately on animal models. But once we got a drug which has a target on both together, which is more physiological, it shows that it has a synergistic effect. It not only improves the glycemic parameter but also improves the adiposity targets and blood flow to the adipose tissue, and also improves adipose tissue metabolism. So it works via insulinogenic axis pathway. Now when we talk about glucagon physiology, we have not used it, but used to have only for those type 1 patient used to have hypoglycemia. We don't have shots of glucagon in India yet, but when we combine the three, it improves the energy expenditure, which is very important, and thermogenesis. So glucagon increases basal metabolic rate and promotes the thermogenesis in adipose tissue and liver. So now we have another agent which are going to work at hepatocyte level, which are going to increase the gluconeogenesis. So we have which stimulates breakdown and store of fat and enhance hepatic fat oxidation. So the target also has been very focused to the hepatic tissues now, which what will cause? Will cause liver fat reduction. So MSAID part is also very well taken. So now we have these triple agonists because they all have synergistic effect and they are going to help in terms of appetite and insulin regulation. And combining this, we can have a insulin response, adipose tissue, adipose regulation. Dysfunctional adipose tissues are very well targeted with this molecule and has a synergistic effect. Now what drug we have under trial? Still we are not having this molecule. This is under trial. We have phase 3 trial which has been conducted and it is on floor now, though it is not published, but I have got this data. The number one contender of triagonist is retatrutide, which is Eli Lilly's leading candidate, and it has already shown some very promising result, which is as good as bariatric surgery in terms of weight regulation and in terms of glycemic control. We also have another drug from Hanmi Pharmaceuticals, which are efoxipeptide, and we have Sanofi's SAR 41255 under trial, which is on phase 2. So phase 3 is the retatrutide, which is already in a almost approval mode, and it has shown the effect of GLP, GIP and glucagon receptor agonism in a single molecule. So first in class therapy, which is demonstrated a very promising result. If you look at the trial, it's called Transcendent Type 2 Diabetes trial, where they have included type 2 population in phase 3 trial, and the primary endpoints were HbA1c reduction, secondary endpoints were weight reduction, fasting and metabolic outcomes, and they have results which are as good as like 2% in terms of A1c, which makes it one of the robust drug to have glycemic control. Weight loss was up to 16 to 17%. And significant fasting and other parameter with no early plateau in terms of weight reduction. So this was the type 2 diabetes trial. So we have A1C under 2% control. Now why Transcend matters? Because it exceeds the expectation in type 2 diabetes in terms of typically it achieves weight loss, and the non-diabetic individual also when retatrutide deliver unprecedented result. So it is one of the drug which is having a disease modifying potential because it targets, as I said, glucagon was also there, MSLD and cardiometabolic risk simultaneously. Now this Triumph trial of retatrutide, which suggested only, this was for weight loss trial, phase 3 global clinical trial program, which focuses on long-term weight loss, and outcome of almost 60 weeks are there, and safety across the different population. If you look at average weight loss was 28.3%, better than GLP-GIP combination, and 45% of people achieve more than 30% weight loss. So imagine a drug which can have a weight loss which is 30%. So I think Dr. Sumit is very happy now because something has come which will divert people to get bariatric surgery and can get benefit of 30% weight loss in an oral drug. And it is a non-ceiling effect. So further weight can be there because the trial which has shown which is having non-ceiling effect. So what we can achieve a better lipid profile, in better inflammation, and also blood pressure regulation. In TRIUMPH 2 trial of retatrutide, they added sleep apnea also because individually it is seen that the drug has some extra benefit in terms of sleep apnea. So all those cases with OSAs, they are also getting benefit. However, we have seen the same benefit with GLP-GIP combination as well. But this is again, they are trying and they are very promising result. So triple agonist is going to be a blockbuster in terms of metabolic care. We are shifting our therapy from only having a glycemic parameter to all other parameters which are complicating these problems. So if you look at MASLD, ongoing fibrosis results suggest potential for diabetes modification in MASLD and target level metabolic therapy. GLP is also approved for up to MASLD therapy along with one or two more agents. So glucagon is going to improve the fat oxidation and metabolic flexibility, and also which is going to have a cardiovascular outcome trial which is undergoing. I think we'll get the result and we'll also confirm that. Safety is issue where we have to look at the GI efficacy and surveillance has to be there. Body composition, there can be a muscle loss, so we need to target these things where only lean mass loss is a concern for this patient, and we need to improve the exercise tolerability, and also the nutritional part as a fat protein intake should be increased. So sarcopenia and protective strategies are there. If comparison with bariatric surgery, I think with this, most of the cases will not require bariatric surgery because you can get 35% weight loss with that. And also we have other agonists which are under trial, which I am not going to discuss, but just to name them that these are there, they are working on it, and they also have shown a beneficial effect similarly as shown by retatrutide. So we have a combination also working with the triple agonist with SGLT2 inhibitor and myostatin inhibitors. So precision obesity medicine is on way. Now as precision diet was there, we can have a drug which can be targeted to a phenotype guided therapy where we can have intervention with patient with unique metabolic features. And India is also a country where we are thin fat Indian, we need such a drug. And if at all it is available, we are going to get best across the world because our adipose tissue, adiposity based problem is much higher than what the Western world has. So the key question which we are looking for, long-term safety with this drug, CV superiority and weight durability. Because in my practice, GLP and GLP-GIP combination, we are seeing that if we continue the drug, we are going to get the weight loss, but how long we have to use and how we have to taper off, what are the ways which we are still working on, and we need to understand that the weight durability is also there, and these drugs have shown no ceiling effect, so you can have a weight loss for longer also. So this is a future of therapy, and we will be using it in coming days because all the trials are going to get completed by end of this year, and we get the result and maybe approval is coming. The cost and the expense will be the only barrier, and I think we are going to have something very exciting and something very useful to treat our people. Thank you.
So thank you, Dr. Subhas, for very nice description about the triple agonist drug and that is likely to come in future. So thank you. So I would like to invite questions on this session from the audiences.
Very exciting talk, and I think this molecule is still which will coming up. I think in next 2 years maybe it will be very exciting. The only problem, or more in the most of conferences, they ask with this molecule, what the glucagon is doing in this combination, because it is a paradox.
Yes.
So how can you explain that?
Yes, there is a concern of hypoglycemia. Sir has rightly pointed out that normally this causes. So that's why we need a combination GLP, GIP. When this class of drug has developed, we used only GLP because we got a GLP from Gila monster, if you remember, the saliva of, and it was tested that it is causing hypoglycemia, but without it is reducing the glycemic parameter, because Gila monster it itself takes a very less food and stays without food for a long time. So this is how the thing has come. But when we used it, we only had GLP and we didn't have GIP. GIP separately was not showing any benefit. But when we combine, which is more physiological, we got some benefit. Similarly, when we combine glucagon, so we have a balance of it, because we improve the hepatic fat metabolism. We also improve the insulin secretion from the beta cell, and we also have a higher center effect on arcuate nucleus. So we have three different pathways which are working simultaneously. If you give separately any one, you won't get, and glucagon may also be causing hypoglycemia. So Sir was very rightly said that.
Nice, yeah, this is nice answer. So you are doing more thrombogenesis, more fat oxidation,
exactly,
more energy expenditure,
yes,
and also more anorexia effect. So that's the way this is doing. So this is really good. More Dr. Kamran.
Yes, sir.
So how much mango should we take a diabetic?
As per the normal, whatever the studies have recommended, 90 grams of dried mango or mango pulp you can have, but you can select the mango which is not having a higher GI, like Langda and Malda, they have GI values very high, glycemic index is very high. So average this Safeda or Zardali you can have 90 gram per day. But I don't think that if we allow the patient to 90 gram, it will get raised to 250 or 400 grams. Yeah.
So you want that we should also have some idea about the glycemic index of different types of mango.
Yeah, yeah,
that is not practically possible.
Practically not feasible.
Yeah.
Actually, mango is being regarded as something very precious in this zone in Bihar also, because lot of mangoes are produced, and as we were discussing the festivals and diabetes and ceremonies, so mangoes are included. आम का सीजन है, साल में एक बार आता है, खाना जरूरी है, ये पेशेंट का वर्षन होता है.
सही है.
तो उसमें they will escape this order, your whatever you suggest, he may skip this instructions clearly.
No, I have a different answer.
Yeah.
On a lighter note.
Yeah.
How much Kamran sir provide to all of us? We should consider.
I'll send it to Bihar RSSDI team.
Thank you.
One question I was asking from Dr. Subhas, one side effect of this triple agonist is there, this increase in heart rate. So far as the cardiac safety is concerned, do you have enough data regarding the CV outcomes, CV benefits of this molecule particular, because it is acting on both GLP, GIP as well as glucagon receptor. So as Dr. Singh said that it is a paradox for glucagon. So some way the studies have found that some gastrointestinal side effects are there, and as well as this tachycardia due to this molecule, which is still under evaluation, this retatrutide. So CV outcome will be an interesting thing for this molecule.
Definitely, though we don't have still this under trial, but definitely one thing is very clear that obesity is it's an inflammatory disorder, as we know. And I have shown that all the incretin based therapy so far, GIP, GLP, GIP or now triple agonist, all the three drugs, they reduce the inflammation. So there is benefit in terms of other factors. However, the data and the trial, once it comes, we can always confirm the benefits. So Supriya sir is here, so welcome sir.
I think really surprised that you talked in a very, very important topic of the genetic makeup and precise nutrition. This is a very, very in the futuristic talk, but at a place like Betia, how do you manage such a, suppose a patient comes to you, is it possible to give a advice for going for a genetic makeup genetic mapping, and then we have to give a precise advice for the nutrition. So how to balance that?
Gut microbiology by sigmoidoscopy. We have to go genetic testing, which starts from 18,000 rupees per se. And there is also, like I said, we have to hire a dietitian. For a small place like Betia, it is not possible yet. But even but because it will take around 50 to 55,000 just to assess the personal need of the patient. But as sir has said that this triple agonists are going to come in the next 2 years. So I will suggest that in the next 4 to 5 years, it will be a routine that a dietitian will be doing such and such cases. Like we are doing HbA1c routinely, we'll do this genetic profiling and this gut microbiome testing routinely in each and every diabetic patient, and then we'll do this cost per age. Then one of my counter question to Saibal Gua sir is, you have talked about type 1 diabetes mellitus. There's an emerging concept coming like 1.5 diabetes mellitus. Can you enlighten us with that, sir? No, because some of the Google
1.5 double diabetes. These are the various terms we have been talking about, and they are all about the spectrum, which I said. Because now, as I said, the diagnosis of diabetes has become dynamic. A person who is diagnosed as type 1 today may be reassessed and diagnosed as type 2 10 years down the line. So it's a wide spectrum, as I mentioned. On one hand, we have classical type 1, where beta cell destruction is very fast. Patient becomes insulin dependent right from start. The other spectrum, as I said, which is the term is double diabetes, where markers of autoimmune antibodies as well as insulin resistance are there right from the start. And there is LADA, where it's initially type 2, patient is responds to OHA, later becomes insulin dependent. There's flatbush diabetic, where initially type 1 features are there, patient dependent, later may respond to OHAs. So it's basically a spectrum. So this 1.5 double diabetes are all various terms given to different stages of diabetes of different spectrum. So it's still a gray area and a spectrum, not a fixed diagnosis as per.
Like I was saying that a 26-year-old male came to my OPD with diabetes, and he asked me that, sir, whether I have type 1 diabetes or type 2 diabetes, but Googled or whether I have type 1.5 diabetes. So what should I say, or what diagnosis? If you what else is it? Sir.
I can answer your first question. There is 1.5 diabetes, no? You asked about. Actually, this is the diabetes. We detect type 1 diabetes, we detect in adult. That Dr. Saibal told. Actually, it is nothing but LADA. Latent autoimmunity diabetes in adult. That is LADA. See, it has got a wide spectrum, lady to LADA. Even in young, we can have double diabetes. Features of type 2 in a case we assume type 1 in younger patient. So that is one spectrum. But if there is autoimmunity, gradually there is reduction in the beta cells, and finally totally C-peptide will become absent because of non-secretion of insulin. So, and there is presence of autoantibody. So gradually slowly developing diabetes with, due to autoimmunity, presenting in adult is 1.5 diabetes.
In simplified terms, your question was, what we do say to your patient, right? So in layman's terms, we can just, what I mentioned in my first 2 or 3 slides, that you have to explain to him that 40% of type 1 diabetics present in adulthood. Not present, I would say diagnosed in adulthood, because and then you have also mentioned that there is a large subset of type 1 diabetics patients who have the C-peptides which for few decades, because they have very slow progression of the disease. So it's very difficult to just classify whether you have type 1 or type 2 or 1.5. It's you have diabetes and you have to get treated. We will see whether you respond to oral drugs or you need insulin. So it's right. Exactly.
So, we can start and we can see the response, and then we can give to
It all depends on what antibody profile you get, whether there is autoantibodies are present or not. More than 2 autoantibodies are needed for classifying it as type 1. That is one thing we have to see, and we have to see the markers of insulin resistance as well. So that will decide, along with the clinical history, family history of autoimmune diseases in the past, age of onset, right, body weight. So all these are factors. As I mentioned, the ADA guidelines, they suggest that it could be type 1, but they are not necessarily so. None of them will clinch the diagnosis of type 1 or type 2 for that matter. So we have, it's basically a clinical conundrum, along with presence of autoantibodies for pancreatic beta cells, along with presence of insulin resistance, markers of insulin resistance. So we have to see all of them.
Thank you. Very importantly,
when we have doubt, we should always initiate with insulin.
Thank you, Dr.
Always give insulin, because if it is type 1, it is going to help him.
Thank you. The session is closed now. Thank you.
We are glad to say that we conclude our session with a decibel as ripe as Indian mangoes. Thank you to the reputed speakers and our honorable chairpersons. We request the volunteers to escort the speakers and chairpersons for felicitation outside. Thank you.
Now we'll start with session 3 in few minutes. Thank you.
Now we will begin with session number 3, Emerging Science, Gut and Beyond. This session promises an engaging scientific journey through some of the latest advances in diabetes care, cardiovascular risk assessment, and the evolving role of gut microbiota in metabolic health. To guide us through this enriching academic session, I would like to respectfully invite our esteemed chairperson, Dr. Shabal Guha sir, Dr. Subhash Kumar sir. I would like to invite Dr. Atul Kumar sir on the stage. Thank you, sir. We are honored to have you with us.
With the permission of our esteemed chairperson, we shall now commence the scientific proceedings of the session. It is our privilege to invite Dr. M.K. Singh sir to deliver the first talk of the session on diabetic macular edema.
Thank you. Thank you, Honorable Chairperson of this session, distinguished guests, and dear friends. I am going to speak on the diabetic macular edema. I am an ophthalmologist speaking among the diabetologists. So I would like to express my feelings in very simple words so it can be understood by you people who are basically a physician and diabetologist. And it is an important component of the diabetic retinopathy. It is a severe ocular complication of diabetes mellitus, which is characterized by an abnormal accumulation of extracellular fluid within the macula, which is the central portion of the retina. The macula is responsible, as you all know, for high resolution, sharp and straight ahead vision. Hyperglycemia alters blood vessel homeostasis initiating capillary microaneurysm, that is the outpouching of the capillaries, which leaks fluid and plasma lipids into the surrounding tissue layers. If untreated, persistent fluid buildup causes irreversible damage to the structural photoreceptors, leading to the central vision loss. As far as the epidemiology is concerned, it is the main cause of blindness in diabetes. It affects 10% persons who are suffer from the diabetic, and 1/3 population suffering from the diabetic retinopathy they are prone to develop this macular edema. It may occur at any stage of diabetic retinopathy. As we all know that diabetic retinopathy is divided into many stages, but it can occur at any stage. As far as the pathogenesis is concerned, the diabetes induces, you all know, microangiopathy besides macroangiopathy, but macroangiopathy basically affects the arterioles and capillaries of the retina. Two key mechanisms are involved in this mechanism. That is, one is the increased permeability, and second is the closure of the capillaries. Loss of pericytes in the capillary wall and breakdown of the inner blood retinal barrier leads to increased capillary permeability and leakage of fluid and other blood components in the surrounding tissues. The capillary closure occurs due to the changes in the capillary wall, that is the thickening of the basement membrane, and changes in the nature of the blood, that is increased viscosity and hyperaggregation of the blood cells. Closure leads to ischemia, and the ischemia triggers release of the vascular endothelial growth factors, which induces hyperpermeability and other inflammatory changes in the retina. Major clinical risk factors, there are several key systemic variables which we have already listened by very prominent speakers, which increases the patient's risk of developing the diabetes macular edema. It includes the higher HbA1c, which is strongly correlated with the microvascular deterioration, elevated hydrostatic pressure inside the retinal capillaries, they promote the fluid exudation, and hyperlipidemia promotes hard lipid exudates formation in the macular layers. The types of DM is very important. It has been divided on the basis of the clinical observation, on the basis of the definition of the ETDRS. Clinically, we found that the thickening of the retina and the presence of hard exudates in the defined macular area, that is within 500 micron from the center of the fovea. Other things are also described, but I am not going into the details of that. And second classification is based on the OCT based classification. Nowadays, the OCT, optical coherence tomography, is an important tool for diagnosis of the macular edema, which takes the view of the picture of the fundus. On this basis, it has been divided into the center involving diabetic macular edema, where the central 1 millimeter subfield is involved, and the non-center involving diabetic macular edema. It has been divided because the treatment and the prognosis of the diabetic macular edema depends on the type of the macular edema on this basis. The clinical presentation and visual symptoms, the early diabetic macular edema goes asymptomatic, but as swelling encroaches the foveal center, many patients complain of the metamorphopsia, that is the straight line looks wavy, bent or distorted. There is central scotoma, means when you place some object in the central visual field of the person will not be able to recognize or will achieve any visual signal from that. Then the color desaturation also is present, where the colors appears dull or the contrast sensitivity is very much reduced. It also visual fluctuation will be noticed by the persons, which varies with the glycemic level of the patient. The diagnosis is made by several techniques, which includes the slit lamp biomicroscopic fundus examination with +78 or +90 diopter lens. Ophthalmoscopy is a very simple procedure by direct or indirect ophthalmoscope. The fundus photography is done, which can be taken as a record. The fluorescent angiography, which for the visualization of the capillary leakage and to decide the area of the foveal avascular zone. Then optical coherence tomography, which is known as the OCT, is very important for diagnosis of the macular edema and other pathology of the retina. Now the OCT angiography has come, which is non-invasive technique, which photographs the vascular flow into the capillaries of the retina. Optical coherence tomography, as I already told, is a very diagnostic standard. It's quantifying the retinal thickening. It serves as a non-invasive optical biopsy of the macula producing micro-resolution horizontal slices to display the retinal anatomy. It is the in vivo cross-sectional anatomy of the retina which can be given by the optical coherence tomography. You can very well see the retinal picture which is centrally elevated, having the fluid collection in the center. So retinal thickness can be measured by the optical coherence tomography, and depending on that we can start the treatment and we can think of what treatment should be given to the patient. At the same time, it also decides the place of the presence of the fluid, whether it is the intraretinal or the subretinal, and we treat accordingly. These are the various photographs which have been obtained by the optical coherence tomography, which is showing in this picture. Treatment include both ocular and systemic. The ocular treatment depends on the type of DME the patient is having. As I have told you, there is non-center involving diabetic macular edema. In this case, the laser photocoagulation is applied at the leaking site. This laser photocoagulation creates intense burn which seals the leaking vessels. The lasers may be focal or grid depending on the type of leakage. Whether it is the focal or it is the diffuse leakage. Center involving macular edema is very important because they have the poor prognostic value from the vision point of view. It is mainly treated by the intravitreal anti-VEGF injections. It can be in combination with the lasers if the leakage has been identified in a particular area. Intravitreal injections of angioprotein inhibitors are also being tried along with the anti-VEGF. The anti-VEGF agents which are being used in the ophthalmology include the Eblipercept, Ranibizumab. Abemacizumab is the off-label because it has been not recommended for use in ophthalmology, but it is being used as intravitreal injection, which is very cost-effective. Recently, the faricimab has come, which has got the dual effect, act as anti-VEGF and angioprotein 2 inhibitor also. It drastically reduces the vascular permeability, dries the macular fluid, and promotes visual acuity recovery. Intravenous injections of corticosteroids, that is dexamethasone or triamcinolone, is being tried in cases of the refractory or non-responding cases. The steroids are also recommended in the ischemic diabetic macular edema. The steroid-containing devices are implanted in the vitreous cavity and they release the drug in a very less quantity, less amount of blood is regulated intermittently, which can have a long-term effect on the macular edema. The treatment schedule is very important because it is a lot of cost is involved in its treatment. The anti-VEGF therapy is very important because you will not get the beneficial effect unless and until you use the anti-VEGF for the center involving macular edema. To start with, we give the monthly intravitreal injection for 3 to 4 months for stabilization of the central subfield thickness. The cost is very much because for one injection you may require some 15,000 to 25,000 like that. So you have to invest that much money. Now, after 4 months or 3 months, you can increase the interval between the subsequent injections by 1 to 2 weeks, which is known as the treat and extend protocol. So if you follow that technique, roughly 7 to 8 injections are required annually. On each visit, you have to monitor the response by observing the patient on optical coherence tomography and the best corrected visual acuity improvement. This is the parameter on which we decide whether the patient is responding to the anti-VEGF treatment or not. Along with this, systemic therapy optimization, we have already talked so much about the systemic value parameters for optimization. So systemic therapy optimization is foundational for DME management, which include the good glycemic control, better management of hypertension, good lipid profile management, and lifestyle modification. It should be emphasized here that the patient with good systemic control achieve better diabetic macular edema outcomes even with less intensive ocular therapy, and conversely, poor systemic control may lead to treatment failure despite aggressive anti-VEGF therapy. I have not included any take-home message in my slides because people have already spoken. I was expecting that many people will speak on the take-home message, so I have not included in that because you have to manage the diabetes in a better way than anything else. So thank you for your patience hearing. Thank you.
Thank you, sir, for the lucid presentation. We'll move to the next session now.
Thank you, Dr. M.K. Singh, sir, for that insightful and informative presentation.
We are now delighted to invite Dr. B.K. Singh, sir, to share his thoughts on epigenetics of type 2 diabetes mellitus in Indians.
Should I start, chairpersons? Thank you. Respected chairpersons and distinguished guests, and I am thankful to the organizing committee, especially scientific chairman Dr. Atul and the organizing team for inviting me for this topic on this prestigious midterm conference of RSSDI. Epigenetics and diabetes. How many student knows about the epigenetics? Anyone? No problem. So you all know the genes or genetics. But the study of heritable and reversible changes in DNA expression without changes in the genetic code is epigenetic. Suppose there is few rooms in this auditorium, and the electric current is going on. This electric current is your genetics, but the switch which either lit off or lit on is the epigenetics. There is no change in the electricity current, but you can bulb को जला सकते हैं, बुझा सकते हैं by this switch mechanism, that is the epigenetics. So study of heritable and reversible changes in DNA expression without changes in the genetic code is epigenetics. And beauty of this epigenetic is this epigenetic mediated differential gene expression can explain the heterogeneous function of different cell types in body despite them all carrying the same genetic information. Means that if you have 2 or 3 rooms or 2 or 3 lights in your room, आप एक ही लाइट भी जला सकते हैं, आप 2 लाइट भी जला सकते हैं, आप 3 लाइट भी जला सकते हैं, दूसरे रूम की भी लाइट जला सकते हैं, दूसरे रूम की लाइट बुझा सकते हैं. Means differential expression. If you want to express the gene on the liver, you can do it. You can want to express the gene in the muscles, you can do it. So differential gene expression can explain the heterogeneous function of different cell types in the body despite them all carrying the same genetic information. So genetic information is not changed. It is the expression which is either in your hand to change this genetic expression. So what is the importance? Epigenetics plays an important role in the transmission of type 2 diabetes mellitus from one generation to another. Epigenetics can be heritable in nature. Epigenetic changes are also implicated in basic pathogenic mechanism of type 2 diabetes mellitus. Hyperglycemia-induced permanent genetic modification of expression of DNA are responsible for the phenomena of metabolic memory. You all know metabolic memory persists, and this persistence of metabolic memory, either due to the bad effect, glucotoxicity or glucose positivity, can be prolonged through this metabolic memory. And epigenetic influences the development of micro and macrovascular complication, and they can also be used as a biomarker in the prediction of this complication. So epigenetics can be used as a biomarker for the prediction and the treatment of type 2 diabetes mellitus or any diabetes mellitus. Epigenetics can expand our understanding of the action of existing drugs such as different type of metformin and development of other newer therapeutic targets. So huge scope of epigenetics in the future of diabetic management. So what is this? If you can see that this diagram is genetic information to protein translation, it takes two steps. One is transcription and another is translation. In transcription, there is a messenger RNA formation. And this messenger RNA leaves the nucleus, goes to the cell, and it settles down in the ribosome and leads to the translation, that is a copy, through this translation mechanism. This is the two steps. One is transcription and another is translation. And this translation in lower side of figure is coded with the protein molecules and they form the protein. This is the simplest way of very complex mechanism of transcription and translation. So classification of epigenetic changes, that is the direct epigenetics or maybe indirect epigenetics, that is intrauterine changes and the inherited form from the ancestors. So I have already said that the transcription and translation. In transcription, two important parts is there. One is the methylation of DNA and another is the histone modification. You all know that the DNA is double helical structure having the nitrogenous base, the deoxyribose glucose and the phosphate bond. And this methylation happens to at CPG part, cytosine guanosine phosphate part. This is the weakest part of any DNA codons. And histone modification, this DNA is wrapped around a histone protein, just like जैसे अंटी रहता है ना, धागा लपेटते हैं. This is like a histone is an anti, and this is wrapped around this histone, this DNA molecule. And the regulation through the microRNA. So just see the first diagram, the DNA methylation. See, the DNA is methylated. If there is a hypermethylation, hypermethylation leads to the gene silencing. If the DNA is methylated, it means there is a silencing, means no messenger RNA will be formed. In spite of that, the messenger RNA in spite of that, the code is there, genetic information is there, but this methylation may lead to the silencing of gene. So once methylation is the function, second is the histone modification is there, and third is the non-coding RNA. DNA methylation, one factor which can silence the, if there is a demethylation, that leads to the messenger RNA formation. And similarly, histone modification. Modify the histone protein that DNA wraps around through this acetylation, methylation, phosphorylation, and ubiquitination. Means that if that gene which is वो धागे में अंटी के समान रुके हुए हैं, अगर that is loose, that may lead to the more aggressive transcription. If it is tightly packed, the transcription doesn't happen. So histone modification and non-coding RNA, I will explain it. You can see that the DNA methylation acts as a localized volume knob silencing specific gene. So unmethylated DNA allow RNA polymerase to bind easily and transcription is active. If there is a methylation, there is no RNA polymerase activation and lead to gene silencing. So this is DNA methylation. And similarly, this histone modification, you can see that there is a closed, the whole DNA is around this histone protein, around the histone protein, closely packed, so there is a suppressed transcription. If it is loosely bound around the histone, there is a transcription is active. So transcription active means there is a increased protein formation of specific type, or if the transcription, or if there is a not open closed, it is leads to the transcription suppressions. So two mechanisms at the transcription level, one is the DNA methylation and another is the histone modification. Similarly, the role of microRNA, you can see that the microRNA, if the this transfer RNA inside the cytosol, if this small RNA get attached, this messenger RNA will not be attached to the ribosome, leading to the silencing. So you can silence this messenger RNA at the translation level by binding this microRNA to the messenger RNA. So pathogenesis, you can note that the environmental sensor corrupt normal genetic overbase. So this input means the obesity, hyperglycemia, oxidative stress, smoking, inflammation, toxin, aging, malnutrition, that all can affect environmental filter to this through this epigenetic process, leading to the either DNA modification or methylation or the microRNA formation. So this base is the epigenetic modification, there is altered gene and the systemic disease. So this obesity or how oxidative stress or the inflammation or environmental filter add to your human body and leading to the disease is through this epigenetic mechanism. So type 2 diabetes manifests across the distinct epidemiologic background like the pancreatic beta cell dysfunction, insulin resistant, and another is the chronic inflammation. That Subhas has said the inflammation is the most important now pathogenetic mechanism regarding the diabetes mellitus, and it is this epigenetic remodeling that traps the immune system in continuous low-grade systemic elevation can be modified by those epigenetic mechanism. So glucotoxicity, you all know the hyperglycemia physically suppress the gene essential for the insulin secretions, and results is the PDX1 gene critical for insulin production become hypermethylated and silenced, creeping the beta cells. So glucotoxicity, if there is a glucotoxicity leading to the decreased insulin secretion through the PDX gene hypermethylation. Similarly, inflammatory mediators alter histone modification to block the cellular glucose uptake. Means that the epigenetic inflammatory mediator force the suppression of critical insulin signaling gene in muscle and liver, leading to decreased cellular glucose uptake and elevated blood sugar, leading to type 2 diabetes mellitus. Similarly, the inflammation, systemic inflammation, create a self-sustaining epigenetic feedback loop. This adipose tissue leading to inflammation, inflammation leads to the epigenetic remodeling, epigenetic remodeling leads to the raising blood sugar, again it causes increased free fatty acids, leads to increased adipose tissue and leading to the same vicious circle will be created. You all know that the endothelial is crucial and important component in the development of all vascular complications of diabetes, because mainly due to oxidative stress, increased AGE, advanced glycated end products, and the activation of inflammatory and fibritic mechanism. Endothelin causes vasoconstriction and increased fibrosis due to methylation defect, and similarly the hyperglycemia affects demethylation, leading to increased expression of MMP9, leading to mitochondrial dysfunction and cell death. This already explained that how metabolic memory, this epigenetic prior glucose spikes leaves a persistent epigenetic shadow in this beta cells, leading to the continued silencing of insulin production from the beta cells through this epigenetic mechanism, leading to the metabolic memory. So DOA fetal programming, maternal and environmental, 1 or 2 minutes. Thank you. So maternal environment dictates long-term maternal dystrophy, maternal obesity, gestational diabetes, protein deficiency, or leads to affect the pancreas, brain, and adipose tissue, leading to the formation of diabetes mellitus. So there is a study showing that increased prevalence of diabetes in adulthood when there is a history of poor maternal nutrition or diabetes in the mother during the gestation. And the thrifty phenotype hypothesis, when these children are potentially exposed to the abundance of nutrition, they are risk of developing type 2 diabetes mellitus and obesity and metabolic syndrome. And Yagnik described that Indian babies are born with low birth weight but are found to have higher visceral fat than their English counterpart and are predisposed to insulin resistance and type 2 diabetes later type 2. And these are through this epigenetic mechanism, that is the metabolic memory, which incorporated during the fetal life intrauterine development of the baby. So missing link is that the epigenetic overlay, the missing link between the environment and genetic destiny. So methylation, histone modification, and non-coding RNA, that is the microRNA, are the very important part in the disease expression, like insulin secretion, signaling, and inflammatory effect. So you all know that the epigenetic biomarkers are very important and can predict the complication, personalized resection, and early diagnosis. And this is very important, which is coming, the epigenetic therapy, the HDAC inhibitors, DNA methylase inhibitors, micro-waste therapy, and nutritional epigenetics, folate, vitamin D, and polyphenol influencing the methylations. And similarly, the lifestyle intervention like exercise, weight loss, shows partial reversibility of diabetes-related epigenetic markers. So epigenetic and therapeutic, understanding epigenetic health lead to the possibility of using epigenetic changes as biomarker and predict the developing of type 2 diabetes mellitus. Many microRNA level been used in biomarkers. One selective BET protein inhibitor, a new drug, the abiraterone, acts by blocking the histone interaction with the DNA, and this has been shown to prevent the rise of inflammatory protein, leading to the decreased complication of type 2 diabetes. So microRNA inhibitor can be used to suppress the overexpression of pathogenic microRNA, and microRNA mimics can be used for overcoming the underexpression pathology. To conclude is that there is a substantial evidence to support the role of epigenetics in the pathogenesis and complication. Epigenetic modification starts early in the intrauterine environment and continued throughout the individual's life, and also it is heritable. Adverse environmental condition, sedentary lifestyle modification, maternal malnutrition, and maternal obesity interact with the individual genome, leading to the various disease state like type 2. Research is being conducted to develop epigenetic biomarker and newer drugs to correct this epigenetic dysregulation, and future diabetic care may include epigenetic diagnostic and the personalized therapy for the betterment of the society and diabetic patient. Thank you very much for your patient hearing.
Thank you, Dr. B.K. Singh, sir, for a wonderful presentation on in a simplified form on such a difficult topic. We will take the questions at the last, sir. You may take your seat.
Thank you, Dr. B.K. Singh, sir, for shedding light on the fascinating role of epigenetics in diabetes and its relevance in Indian population.
It gives us immense pleasure to invite Dr. N.K. Singh, sir, to deliver his talk on gut microbiota, the new endocrine organ.
Everybody here knows Dr. N.K. Singh, but to those who are uninitiated, he is one of nation-famed orator and researcher and founder of CME India, the one-of-its-kind online platform of doctors. Over to you, sir.
Yeah, I think good afternoon. Basically, I live at Dhanbad. Chairpersons are here, both close friend to me. I belong to Bihar, Jirade, you know, from the Siwan. I will finish in 15 minutes, sir. May take 1 or 2 minutes more. It is always a pleasure here, and Dr. B.K. Singh somehow told me that you have to come, so when he guides me, I have to come here. So it is really a pleasure. So today, the scientific committee has given this talk, redefining the microbiota in clinical practice, the gut microbiota, the endocrine organ. I think this topic was first given, I think, 2 or 3 years back for the national RSSDI. Then we worked on this subject. We did a meta-analysis also that is under publication at present. मेरे ख्याल से ये चीज़ जो है कि गट माइक्रोबायोटा एक बहुत ज़रूरी चीज़ है, बहुत इम्पोर्टेंट है. मैं देखता हूँ कि साइंस में अगर आप अभी इफ़ यू सर्च द नेट, द मैक्सिमम नंबर ऑफ रिसर्च इज गोइंग ऑन द गट माइक्रोबायोटा. बट दिस इज रियली अ वेरी अमेजिंग थिंग कि हिप्पोक्रेटस इन 400 BC told, death sits in the bowel, a bad digestion is the root of all evil. और ये हम लोग जब बचपन में थे तो दादी माँ कहा करती थी कि पेट से ही सब बीमारी होती है. और कुछ दिन तक जब हम लोग MBBS और MD कर रहे थे तो लगता था कि कितना दकियानूसी विचार है कि पेट से सब बीमारी कैसे हो जाएगा. लेकिन टुडे इन 2026 साइंस इज टेलिंग यू कि रियली ऑल डिजीज बिगिन विद द गट. यू कैन सी हियर. इससे भी अमेजिंग है कि 5000 साल पहले जाइए या 10,000 साल पहले इन अवर Sanatan and Vedic civilization, they also had lots of shlokas in Ayurveda, in our Vedas, and they knew it very well. The gut is so important. So what is gut microbiota? It is the complex and distinct population of microorganisms that comprise the gut microbiota. You can see here this is important, this one, ki today when I am here and you are here, and I am not knowing that in my body and your body, at least 1.5 and 2 kg microbiota is there, and we are not knowing about it. We are not aware about that. So, and this picture itself is very important. You can see कि क्या खाते हैं तो ये रेड हो जाता है और क्या खाते हो तो ये ग्रीन हो जाता है. This is the final picture I will say you, if you can see that. That is the reason that today the people are sampling their own feces, because the transplantation of feces are going on in India too. For the purpose of the science, they are taking probiotics, eating lots of yogurt and so many things. The science is exploding, and we are just in the early stages of making some sense of it. This is very important. Whatever I am going to tell you, that is a bit of the science today. Maybe after 1 decade, the things will be different. But I told you, okay, you can see the whole spectrum of disease in your body. Your pneumonia, the metabolism, even the skin condition, heart failure, atherosclerosis, neurodegenerative disorders, psychiatric disorders, OSA, lung cancer, everything is happening. Today we have got evidence that somewhere the gut microbiota is involved. So this is such an important part. In very short, you must know that at least the 4 types you must remember. One is the Firmicutes, that is a 60 to 80%, Bacteroides, that is 20 to 30%, Actinobacteria 10%, and Proteobacteria less than 1%. And what is happening, one type of bacteria found in the gut may contribute to some disease, well, why? And if the other type of bacteria you have got, it will save you. So this is the thing we must know. So gut microbiota and how they differ in homeostasis via the dysbiosis is the question. So this here, but here he has given the topic about the endocrine organ. You can see here the concept that the gut microbiota serves as a virtual endocrine organ also. This arises from its metabolic capacity to produce and regulate multiple compounds that reach the circulation. It is a huge science, the metabolic signaling to neuroactive compounds, but you see, just I will give you here, but I think in simple way, you must remember 3 or 4 things if you are thinking about the gut microbiota. One is the short chain fatty acid, that is the acetate, propionate, and butyrate. Then the secondary bile acids, indole derivatives, and some neurotransmitters like GABA, serotonin. You can see that so many precursors are there, how the microbial process is going on, what are the host receptors and systemic effects. We have not time to discuss all day, but still I will tell you, just remember the LPS, the lipopolysaccharides, short chain fatty acids, and bile acids, then our understanding will improve at all. In the endocrine interface, we have lots of mechanisms, like it is a very complex science, the TGR5, the FFAR2 intracellular mechanisms, that is not very interesting, but ultimately all pathway leading to how the secondary bile acids, the short fatty acids, you can see there. And even your dietary pattern, if you're taking some dietary tryptophan, you can see here how this microbial regulation, the microbial regulation going to indoles and 5-HT and other things. And neural routing is also there, the traffic flow is there, the sensory function is there, and causal markers are there. Like if you can see that lactobacillus ingestion alters the emotional behavior and central GABA receptors expression in mice. There are lots of research is there. And this gut can also set the hypothalamic pituitary adrenal tone. You can see here by this slide. And meta-organismal pathways of cardiovascular risk can be modulated also by, if suppose you have taken red meat or egg, then leading to how this gut microbial factory to intermediate products, then go to liver, FMO3, and final products like TMO is very important, TMAO, and arterial cross section. So all they are interlinked. And there is energy harvest and metabolic endotoxemia. That is also a part of this endocrine organ the gut is doing. And we have got the co-founder evaluation of the disease versus drugs in nature. I'm not going in detail for that. I will give you a simple way to understand that as many treatment options target the microbiota, there is a bidirectional relationship between the diabetes or the obesity or the metabolic disorders and the gut microbiota can be observed. So what is the, just see here the red one, here this gut type of gut microbiota, if you have more and more and more, and if the lactobacillus or bifidobacterium, these are less, there happens a condition known as gut dysbiosis. Then the lipopolysaccharides increase, causing the metabolic endotoxemia, inflammation, and insulin resistance and type 2 diabetes. So this is in a simple way you can understand. So I told you the gut affects the short chain fatty acids, lipopolysaccharides, altered bile acid production, and with that, with this chemical modulation, the insulin sensitivity decreases, insulin resistance is there, and ultimately leading to permeability of the bacterial transient to the LP polysaccharides, and metabolic endotoxemia. So this is how this is working, you can see here. This shows how this microbiota influence the glucose homeostasis. There is a long chain here. Suppose if there is increase in short chain fatty acids, the GLP-1 will increase, the FFA will concentration will decrease, PNS activity will increase. In the same way, from the gut mucosa, the branched amino acids, there are lots of things doing, ultimately leading to this glucose homeostasis disarrangements. But enhanced intestinal lipopolysaccharide permeability in the gut seems to play a central role in the chronic inflammation and contributing to reduced insulin sensitivity. This is the take-home message. And this is definitely altered in type 2 diabetes and metabolic disorders. What are the challenges? It's very difficult to, I will not go in detail of that, but it is very difficult to say because the gut pattern of the gut microbiota in our population, in European population and some other population, it differs. So it is very difficult to give you a data in this, because in the European population, some type of gut microbiota is causing some sort of disease process. Is it valid for Indians or not? Because lots of challenges are there. So I'm not discussing that. I will go in the next slide. Now the last part is in the 4 minutes or 5 minutes. What is the implication of this knowledge in today? The composition of the gut microbiota continues to shift based on what you are taking as a diet, genetics, your whatever medicines you are taking. So many studies have shown today that the diets, if you are taking plant-based, high fat and low fat, they change the microbiota composition very significantly. And this Mediterranean diet, we have got a study that this, I told you that even the animal-based foods, if you are taking, lead to adaptation of the gut microbial function towards improved catabolic process like the degradation of glycans and amino acids. And definitely the supplementation of prebiotics, this was found to be reversed in the plant-derived food groups. This study shows you the effect of dietary fiber. If you are taking plenty of dietary fibers, you can see here that from the dysbiosis, you can go to the homeostasis. In the same way, the organ transplantation you can see is happening. That is a new era of organ transplant is coming up. That is the FMT, that is the fecal microbiota transplant. It is not new. That was dates back 1,000 years to the Chinese practitioners and was first published in the Modern Therapeutic Intervention in 1958. In the process by which a fecal sample from a healthy individual you transplant into the gut via enema, nasogastric tube or colonoscopy or of a diseased patient. And the fecal microbiota transplant from the lean healthy donors has also been found to be successful in improving the insulin sensitivity in the main and metabolic syndrome. I think the AIG Hyderabad and some other centers are already started doing this FMT. We have got a plethora of research on the FMT, and the very possible observations from the individuals tolerating to the oral formulations and the fecal microbiota transplant therapy done so far and the challenges observed in the intestinal microbiome seem very promising and revolutionary. You can see here the HbA1c improves, the BMI improves after the FMT. So we have got the evidence. In the same way, if you are doing a regular exercise, must be know that by doing a regular exercise, you can alter the pattern of the gut microbiota. We have plenty of papers on that. Even the drugs we are giving in the diabetes, like metformin, AGI or GLP-1RA or DP4 inhibitors, some like metformin increases some sort of gut microbiota or decreases also some sort of that. So that by that also many of the drugs in the diabetes are working through the gut microbiota. So how to know that your gut microbiota is okay or it is bad? I will take only 2 minutes. So the enabling the tools to interrogate the microbial dark matter, today we have got, this is available to your part, even at Patna or anywhere you can online can book today. The decode biome or super gut 10,000 around, and this gives you a score. If it is less than 0, you are unhealthy. 0 score is balanced microbial profile, and more than 0 is healthy gut score. So just by collecting the fecal sample, they can tell you your biome score is what is your biome score. But remember, if you ask me whether it is validated, none a single recommendation is there from the reputed guidelines, but it's coming up. In the same way, they just take a blood sample of, and you just measure the TMAO. And if the level is not good, then we know that gut microbiome is not healthy. Now last part is what you can do. So we can do dietary modifications, treatment with the probiotics and prebiotics and the postbiotics, and fecal transplantation. So these are the things which we can do today itself. Even the cooking methods, if you suppose switching to the almond milk for made-fried desserts, or if you are switching into the whole grains like millets, if you are switching just for the millets and brown rice, if you are taking more of the extra virgin olive oil, it is possible that you can change from dysbiosis to homeostasis of the gut microbiota, and most of the disease you can prevent and you can cure also. Because see the healthier profile and profile at risk. So these what foods are good and what bad you are showing there. So last point I will tell you that the gut microbiota is now best viewed as the distributed endocrine organ. Its endocrine language is metabolic based, metabolite based. Short chain fatty acids are the classic hormones of the microbiome. The bile acids are no longer only digestive detergents. Remember, microbial conversion of primary to secondary bile acids changes FXR and TGR5 signaling, thereby they influencing the glucose metabolism, lipid metabolism, and GLP-1 secretion, energy expenditure, and inflammation. And the microbiome directly talks to endocrine cells. In type 2 diabetes, dysbiosis is understood as functional, not just as a taxonomic. And gut-derived inflammation links microbiota to insulin resistance. This also intersects with the thyroid, PCOS, obesity, and reproductive hormones. Personalized microbiome therapy is very promising, but not at routine endocrinology. And so clinical message is crystal clear. I will end here with saying that the understanding of the microbiome and its influence on human health is really in its early stages. And at present, one must be cautious that applying one intervention such as probiotics, which claim to influence the disease and outcomes, finally it will be vital to recognize the human as a whole and understand that manipulations of any factor in one direction can have implications to the another. This is the last slide, but it is a big, good slide, I will tell you. Just to improve your gut microbiota, just bring back the traditional Indian physical activities and just bring back the traditional Indian food, and this will tell you everything. I also invite you for the Wisdom Conference, the World Declaration of Spirituality and Divine Orientation in Medicine. For the first time, from the CM India Group, 19th to 20th of December, AIMS Rishikesh, Bharat. Dr. B.K. Singh is here. He is also our coordinator for the East Zone. Thank you very much.
Thank you, sir. It was wonderful to hear that gut microbiome is such an important endocrine organ. I think it is one of the largest organ we have, and we have more gut microbiome than the whole cell. So we represent our own microbiota, our own bacteria than our own cells, and it has several implications. You explained very well. So thank you, sir. Thank you. So we have a next talk now.
Thank you, Dr. N.K. Singh, sir, for that thoughtful, provoking presentation.
We now invite Dr. Supriyo Mukherjee, sir, to speak on cardiovascular risk stratification in diabetes care.
My apologies, I didn't introduce Dr. N.K. Singh, sir, as Vice President of National RSSDI, and I would like to introduce Dr. Supriyo Mukherjee as the immediate past chairman of RSSDI Bihar chapter. Over to you, sir.
Thank you very much, Team RSSDI, for inviting me in this August gathering. I especially congratulate Dr. Atul Kumar and his team for a great scientific session. I abide by your point that you told that it should be a scientific, there must be a scientific question structures. I try to structure my topic as a clinical question. Like, to start with, my topic is cardiovascular risk stratification, diabetes and diabetes care. Disclosure, I don't have any. So, to start with this question, why cardiovascular risk stratification is important? Why I'm delivering this talk? First of all, because the burden is enormous. The risk is heterogeneous, and the early identification allows timely and targeted prevention. The right treatment begins with the right estimated risk, and precision prevention demands precision risk stratification. Despite the growing burden of cardiodiabetes, cardiometabolic disorder, India lacks a widely validated diabetes-specific cardiovascular risk prediction tool and calculator developed exclusively for its diverse population, not only for urban population, but the diverse diaspora, Indian diaspora. Existing efforts such as RSSDI risk assessment framework and CARS Restore are there, but significant opportunities remains for the refinement, validation, and broader implementation. That we have to understand this. In using borrowed Western tool has huge limitations. And building our own with the essential ingredient which I have here at this point of time, with a methodology that we may discuss later after this discussion. So, is diabetes still a cardiovascular risk equivalent? No, it is not universally a cardiovascular risk equivalent. So, there are two questions comes out from this. From where I got this research question, is diabetes still a cardiovascular risk equivalent? The Steve Hafner, his seminal paper in 1998, presented this epigrammatic line that diabetes is a risk, cardiovascular risk equivalent, was highly quoted and variously interpreted and ignited many, many debates. And finally, what happened? We have two very important evidence that I'm going to say that when all major cardiovascular risk factors are treated to within the target ranges, people with type 2 diabetes have risk of death, MI, stroke, similar to that of general population. That is Alsani, that is a Swedish scientist, published in NEJM. And second was that Wang et al., whether diabetes should not be viewed as a universal cardiovascular risk equivalent, that was largely came after a very big, around 12 million people with diabetes with cardiovascular risk factor meta-analysis. So the most, and we Indians, because of frequent clustering of obesity, hypertension, dyslipidemia, CKD, and metabolic dysfunction, many Indians may reach a cardiovascular risk equivalent state earlier and more often than a Western population. So what is then the relationship of cardiovascular disease and diabetes? Because this is a spectrum disease. This is a spectrum relation, say with a lower risk to the higher risk. So Indian phenotype, we must not. Recognizing Indian phenotype is essential for accurate risk assessment, early intervention, reducing the growing burden of cardiovascular disease. If we miss, rather we miss generally, so with the use of global model, we miss many, we underestimate or overestimate the risk. And so, to start with, what is cardiovascular risk stratification? It is all in a question-answer format, Secretarian method that I wanted to tell you, and our committee, our scientific committee also suggested for that. A structured process to estimate 10-year risk of major cardiovascular risk based on clinical factor, this is age, sex, blood pressure, smoking, family history, biochemical markers like A1C, ACR, lipid and creatinine. Then imaging, there's a CAC score, ABI, CRP, common risk categories like moderate risk, high risk, very high risk, and lifetime risk and residual risk. And then integrates diabetes-specific factors and use validated tools. Why it matters? Because very clear, we clinician must enable ourselves to personalize prevention strategies, set appropriate LDL cholesterol and blood pressure target, optimize cost effectiveness, avoid and overutilization or over-treatment, and promote shared decision making. Then severe risk assessment system, considering there are many one, and there are few important one that I wanted to tell you. That is, I will discuss only few, 4 or 5. That is, first of all, is SCORE, ESC 23 guideline. There is a SCORE risk assessment, SCORE 2 diabetes, to estimate 10-year risk of fatal and non-fatal ASCVD. Consider duration of diabetes, age, risk factors, CKD, and organ damage, and established ASCVD. What does it do? It this categorize like moderate, high, and very high. And if it is moderate, then LDL cholesterol goal would be less than 100. If it is high, then it's less than 70. And if it is very high, it is less than 55. So this is one. Second is ADA. What did they do? The CKM-based, cardiac, kidney, and metabolic-based patient-centered approach for risk assessment and management. It is not very valid for Indian conditions and all, I tell you. But NICE, UK, of QS3 that we use, that I use specifically, that is wonderful in that way that it happens, it includes a specific ethnic coefficient of Southeast Asians, reflecting higher baseline cardiovascular risk, and the key variables are age, sex, ethnicity, BMI, blood pressure, and it took some important and very peculiar conditions like rheumatoid arthritis, that is inflammatory condition which may cause cardiovascular disease and it increases the cardiovascular disease. It may increase the cardiovascular disease in diabetes, rheumatoid arthritis, steroid use, SLE, severe mental illness. These are the, and they put Townsend deprivation index also. So that is very important for Indians. Like simple example, I tell you, for a 45-year-old Indian man with type 2 diabetes may have more than 10% of 10-year cardiovascular risk, even in the absence of ASCVD. Sometimes it overestimate our conditions in our setup. So it is useful in urban NCDs clinics and EMR-linked settings. WHO, it is good for low and middle income countries like India. And WHO 2019 CRB risk charts provide a practical and equitable approach to identify individual risk and guide prevention, intervention in diverse communities. It has got two things, lab-based chart and non-lab-based charts, that you can very easily find it out. I have given you the website. Then comes the RSSDI guidelines. The key principle is a blanket statement. All person living with diabetes have at least very high risk, have a high risk. So this is slightly, a blanket statement for that matter. And even newly diagnosed, even without additional risk factor, takes into consideration is a high risk. And very high risk, type 2 diabetes, two major risk factors are any organ damage, retinopathy, and CKD. How we approach a person who comes across a table, we clinically assess him with age, sex, diabetes duration, and blood pressure, BMI, waist circumference, and all, smoking status, and all. Laboratory evaluation we do, general laboratory evaluation which we do day to day, and then detect target organ. Retinopathy, nephropathy, and neuropathy. Then count major risk factors like hypertension, dyslipidemia, smoking, obesity, and macrovascular diseases. If you get two or more, then it progresses to very high. And then apply risk estimator like UKPDS risk engine, and final risk stratification. Get an example from me at this point. That 54-year-old type 2 diabetes with 6 years with a smoker, HbA1c of 8.1, ACR is 110, is very high risk. So with a car risk, this is a first risk code derived from validated Indian and Southeastern population, Southeast Asian population, from Center for Cardiometabolic Risk Reduction in South Asia. There's Nikhil Tandon, Dr. Nikhil Tandon, Dr. V. Mohan, and all. This is basically a risk consortium. They have put more than 20,000 patients. But there's a one limitation. It is for the urban population. Then we go for a Lipid Association of India 2030 guideline. Dr. BK Singh is probably our Bihar chapter's president, that we have a risk stratification tier. It's 3, high risk, very high risk, and extreme high risk. LDL cholesterol is high risk, is 70, 55, and 50. It is probably the best risk score stratification in India at least, because because we emphasize on Southeastern focus with low HDL, high triglyceride, and elevated lipoprotein little a. So this is a comparative global Indian guideline. I have just made it for you. You can keep it inside your tabletop, glass top. You can put it like that. Otherwise, and this is an Indian-specific cardiovascular risk assessment tool. And this is a clinical case, 2 cases, and 45 seconds each. There is 52-year-old male, type 2 diabetes, 8-year hypertension and smoker, sedentary lifestyle, with an HbA1c of 8.2, HDL cholesterol is 130, HDL is 38, triglycerides is 220, urine ACR is 120 gram per gram, mg per gram. So risk stratification, if you go with a QRIS calculator, you will get 32. It is slightly up, overestimates. ACVD estimated is 27 to 30, because we don't have our own. And risk stratification is a blanket from RSSDI, you go with a very high risk. And ASD, that is from ESC in 2023, very high risk, LI, extremely high risk. Management, high intensity statin, AC inhibitor, SGLT or GLP receptor, depending upon the condition of the person, with a cardiovascular benefit. Clinical case 2, the 45-year-old female, newly diagnosed type 2 diabetes, no hypertension, non-smoker, A1C is 6.9, HDL-C 92, HDL 52, and triglyceride is 120. No albuminuria, no retinopathy, physically active. Will you give statin here? Yes, because every diabetes is basically you have to start with a moderate statin. So this is very important message which I wanted to tell you. And finally, the conclusion is, to cut the long story short, is that we Indians have higher burden, earlier onset, unique phenotype, unique risk factor. Global models underestimate our risk, overestimate our risk. India must not just adopt risk models, we must build our own them. Thank you so very much for patient hearing.
Thank you, sir, for elaborating the risk, and particularly those Q risk and other risk which you have explained, and it was really useful to have these in our clinical practice, because whatever drug we use, what the doses we use in terms of prevention, we should have a clear risk before we start. So thank you, sir. So we move to the next session. The question answer maybe next time.
Thank you, Dr. Supriyo Mukherjee, sir, for an excellent and clinically relevant discussion.
It is our privilege to invite Dr. Ashutosh Kumar, sir, to present on SGLT2 inhibitors, the real game changer.
Good afternoon, respected chairperson, sir, senior faculty members, esteemed colleagues, and dear students. I'm feeling privileged to present this topic on this prestigious platform. Thank you, scientific committee, for giving me this opportunity. In next 15 minutes, I will convince you that the SGLT2 inhibitor has earned the title the real game changer with some evidence inputs and a general physician perspective ideas. The roadmap of this presentation is that we will cover the problem. Why do we need a new paradigm in the type 2 diabetes mellitus? The mechanism, just overview, insulin-independent glycosuria and plethoric benefit of this class drug. CV outcome, covering the landmark trials like IMPARIS, CANVAS, DECLARE TME 58. Its usefulness in heart failure beyond the diabetes, covering the all range of ejection fraction, renal thresholds, renal cell usefulness backed by the CREDENCE trial, DAPA CKD, IMPA kidney, some safety issues on the clinical guidelines and the Indian perspective, some future of this class drug. The unmet need, why standard therapy was not enough. The traditional goal was HbA1 reduction only. No CV or renal endpoints were defined. Hypoglycemia risk, there was a hypoglycemia risk with sulfonylurea and the insulin. Type 2 diabetes patients dies of the CV events and the CKD. 50% have that CKD at the diagnosis. Heart failure is more than 2 to 4 times common in the type 2 diabetes mellitus. The gap in the care. In the pre-SGLT2 inhibitor era, there were no oral drugs that was used to reduce the CV death or slowing the CKD. Metformin had no CV outcomes data. SGLT2 inhibitors changed this. The class 1 evidence is the cardiovascular mortality reduction, heart failure hospitalization reduction in both segment, reduced ejection fraction and the preserved ejection fraction. The CKD progression was slowed in all cases of having estimated GFR more than 20, and this action was insulin independent. So though there was very less chance of hypoglycemia. So how SGLT2 inhibitors work? Step-by-step flow. Glucose is filtered. More than 180 grams per day glucose filtered by the glomerulus. SGLT2 reabsorb more than 90% located in the PCT. And SGLT2 inhibitors competitively inhibit this protein and causes the glycosuria, and that clinical effects come by lowering the glucose, lowering the BP, weight reduction, also the lowering the uric acids. So the insulin independent mechanism means efficacy is maintained even in the advanced beta cell failure or severe insulin resistance cases. Hemodynamic effect with there is some osmotic diuresis. It decreases preload, decreases nativitis decreases BP by 3 to 5 mmHg, reduction in the sympathetic activations, and it decreases the arterial stiffness. In the metabolic segments, weight loss nearly 1.5 to 3 kg. It reduces the uric acid production, shift to ketone body metabolism, and reduces the epicardial adipose tissue. Cardiorenal segments, it increases the intraglomerular pressures, decreases albuminuria, have the antifibrotic actions, and also it decreases the oxidative stress. So the SGLT2 inhibitor class drug, one drug, and have the 4 targets: type 2 diabetes mellitus, heart failure, chronic kidney disease, and obesity related metabolic related disease. So it significantly reduces HbA1c by 0.5 to 1%, and this action is insulin independent. There is very less chance of hypoglycemia. Useful in both reduced ejection fraction and the preserved ejection fraction segments, reduces the hospitalization for the heart failure, reduces the cardiovascular death, it decreases proteinuria, it decreases eGFR declines, and has the very usefulness in the end-stage renal disease prevention. The weight loss is day 2, 1.5 to 3 kg, not significant, but certain BP reduction, decreases uric acid, and the decreases epicardial fat. So no other single drug class achieve benefit across all 4 domains simultaneously. Some landmark trials that change the paradigm, IMPA-RAGE outcomes, conducted in 2015, including taking the drugs empagliflozin. 38% reduction in the CV death was noted. 35% reduction in the heart failure hospitalization. The 3-point MACE was less than 14%. There was a 39% reduction in the renal complications. In the CANVAS trial, taking the canagliflozin in 2017, the MACE reduction was 14%. There was a 33% reduction in the hospitalization for the heart failure. The renal progress was less than 27%. However, there was a signal for the amputation, especially linked to this canagliflozin. In DECLARE TIMI 58 trial conducted in 2019, the CV death and the heart failure reduction were observed less than 27%. Renal complication was also observed less than 47%. There was no significant 3-point MACE, and the heart failure alone was the less than around the 17%. The rapid divergence of curve at the 3 months was observed in the IMPA-RAGE outcomes. This CANVAS program was the first to show the CV benefit in primary prevention populations, and DECLARE TIMI 58 confirmed heart failure and the renal benefits even without prior CVD. All these trials together show that SGLT2 inhibitor will achieve durable CV and the renal protections, and that independent of glucose lowering magnitude. SGLT2 inhibitor across the full spectrum of heart failure. For the first time in history, a diabetes drug earned a class 1 recommendation for heart failure. In all the segments, ejection fractions less than 40%, 41 to 49%, and the heart failure with preserved ejection fraction that is more than 50%, and that backed by the DAPA heart failure. A trial conducted in 2019, Impera reduced trial in 2020, Deliver trial in 2022, and the Impera Preserve trial in 2021. How SGLT2 protect the kidney, mechanism to evidence. SGLT2 inhibitors blocks the sodium chloride reabsorption in the proximal convoluted tubules, and it increases delivery to macula densa that correct the tubuloglobulin feedback derangement, and it activates it. It causes the afferent arterial constriction, and this reduces the glomerular filtration pressure. This decreases the glomerular hypertension. This is the primary driver for the diabetic nephropathy, and in this way reduces the albuminuria and reduces the eGFR decline. This mechanism is distinct from and complementary to ACE inhibitor ARB. The Credence trials conducted in 2019 show the reduction in the stage renal disease 34%, along with the renal death and creatinine rise, DAPA CKD backed by the DAPA CKD trial and the IMPACT kidney trial. But along with this beneficial effect of the SGLT2 inhibitor, there is some khamia bhi hai. It causes genital mycotic infections. However, it is manageable and common, especially in the women's. Polyuria nocturia, due to the transient osmotic diuresis, and that resolve 1 to 2 weeks. Dosing should be, the medicine should be taken in the morning. Volume depletion, especially in the elderly, in the CKD patients, and those taking the loop diuretics. UTI, especially the uncomplicated UTIs, and the rare, but some rare and the serious complications are euglycemic CKD. It's occurred in the normal or near normal glucose, but have high ketones and the acidosis. We should hold 3-day any surgery and follow the 6-day rules. Some cases have been seen the Fournier's gangrenes, the necrotizing fasciitis of the genitoperineum, very rare. Special to the Kana folliculogen in the Canvas trials, limb amputation signals were noted, and some rare cases, acute kidney injury may be noted. So at what eGFR can we use SGLT2 inhibitors, and for what? In all range, with more than 20, we can use SGLT2 inhibitors. For full glycemics and cardiorenal benefits, up to 30%, in between the 20 to 29% for the cardiorenal effects. So glycemic benefits require eGFR more than 45. Cardiorenal benefits, eGFR more than 20. And some 10 to 50% dip in the eGFR is expected. We should not use in cases with less than GFR less than 20. Here is a comparison of the dapagliflozin with the IMPA, GANA. These all have the class effects. The declared TIMI were were used by dapagliflozins, empagliflozins, and the CANVAS program taken the canagliflozins. Heart failure reduction were seen in all. Amputation signals were only noted in the few cases of canagliflozin. These are the landmark trials.
Can you conclude the slide? Time is over now.
Why should the general physician also prescribe SGLT2 inhibitors? SGLT2 inhibitors offer life-changing benefits, but for a window of the maximum impact is often missed if prescribing is deferred. The general physician is uniquely placed to identify the high-risk patients early and initiate this therapy. A cardiologist lens prescribe the heart failure with reduced ejection fraction, preserved ejection fraction in post-MI cases, but the patients may reach a cardiologist until organ damage is advanced. In general physician, the general physician has a unique role, see the whole patients, managing diabetes, hypertension, CKD, heart disease holistically, often the first to identify high-risk patients before significant organ damage occurs, can initiate SGLT2 inhibitor therapy early when the protective benefits are more profound, bridges the gap between the specialists, ensuring the timely intervention across the care pathway. General physician is the primary specialist for the chronic conditions like our countries, so don't wait for a referral. The evidence for the SGLT2 inhibitor in your hands, ready for transform a patient's outcome. Thank you.
Thank you, Dr. Ashutosh. You may please take your seat. We'll have the questions at the last. Session so, this was the last talk of the session, so we may take questions if there are any for any of the speakers. Dr. M.K. Singh, Dr. B.K. Singh, Dr.
Can I talk one with Dr. Ashutosh?
N.K. Singh.
Dr. Ashutosh, where is? नहीं है क्या वो? अच्छा, actually this was always a very, I think, talk on these SGLT2 inhibitors. In your clinical settings, just tell your experience. What is the prevalence or incidence of the GTI, the urinary tract infection, and the GTI, genitourinary tract infection? So how do you get? Less common, I think. Dr. B.K. Singh, can you tell your experience? Yeah. So I think this is sometimes it is a very big problem, I will tell you.
Yes, definitely.
Because recently, because I am able to tell you, because we recently, for the first time in India, we did the largest study of the India, of the world, of the real world study. I was the principal investigator for that, known as Genius study. Just it got published in the month of May 2026 in the Nature group of endocrine practice. So our study gives you a pan-Indian snapshot of what is happening. Although it is different in different states in the east, west, and we have to also going to a study why it is happening, what are the factors that someone in Maharashtra is getting more or at Delhi why less, and why Goa it is again more. So I think UTI, regarding the UTI, the genital infections, that like vulvovaginitis or vaginitis, it is quite common. It is around no issue at all, it is 10 to 12% if you take an average. Only problem with the UTI, because lots of data is there, and really we had a great debate with the Dr. A.K. Singh also many times. He also always says that there is no UTI at all. But our real world study says that it is also 3 to 4%. And then there was a debate. He told he will write a letter to the editor. Wherever you write, the data is here. Because I have not done alone. There are 42 centers, pan-Indian, the big researchers. So there is also UTI. We did a retrospective study. But to tell you the more and more, we need a prospective study. That is the problem. But even it is a big data. That is what the reason that the nature group affected it. Because it is around more than 15,000, although we collected 22,000 patient data, after cleaning we had got around 15,000 data. And if you combine genitourinary, it is something around in the tune of 10 to 11%. So that is genius data, not is available on net. So see for that and think you go for looking for that. Many of times the patients coming to you, a lady patient, not telling you that she has got a features of the vaginitis because she is going to some gynec. So that happens quite time. So you have to ask some questions, and we have given also the genital hygiene.
That's why I mentioned the older ladies.
Yeah. The older is, yeah, that is true. Sometimes, yeah, that is.
Yeah, actually,
It is what you said is absolutely right, sir. All of us, I think, would agree to that, and that it is underdiagnosed and underreported. That's the reason, and there comes the role of the physician that one should explain about UTI right at the time of prescribing, that this may happen, and what preemptive measures the patient can take to minimize the chances. Thank you, sir. Thanks for your input.
That brings us to the conclusion of this session. We express our heartfelt thanks to our esteemed chairpersons and faculty for their invaluable contribution. We request our volunteers to escort the chairpersons and speakers for the felicitation area. We now request all the faculty members and delegates to proceed for lunch. The next session will commence at 12:15 p.m. 2:15 p.m.
Sir, can we start? Our first talk explores a promising therapeutic target beyond glycemic control. May I invite Dr. Sanjay Kumar sir to speak on GLP-1 receptor agonists in respiratory diseases, a promising novel target.
A very good afternoon. First, I would like to thank the organizing team to inviting me for addressing this august gathering. And I'm thankful to them to allow me to speak on a topic which is mostly unexplored, that is GLP-1 receptor agonist in respiratory diseases. First, I would like to give you an anecdotal view of a very famous book, Future Shock by Alvin Toffler, published almost 50 years back. And he has given the view that in the post-industrialization era, there is advanced or accelerated advancement of the technology. And this will lead to information overload in time to come. And this information overload will put the society in shattering shock. And it is true so far so the drugs are concerned. GLP-1 receptor analogs are one of them. Most of its properties are being exploited not only for the glycemic control, but other commercially viable obesity control. But we will have to explore the other properties of GLP-1 receptor agonist. Why to explore in the respiratory medicine? Well, it has been shown in the studies that GLP receptors are expressed in the lung as well, and it may have the potential role in managing the airway inflammation. So it may reduce airway inflammation, tracheal hyperresponsiveness, and respiratory exacerbations, so that there may be a fewer asthma attack and reduced COPD exacerbations. So beyond the glycemic controls, we may have the multidimensional approach linking metabolic and respiratory disease management. At this stage, I would just like to recapitulate the GLP-1 physiology and mechanistic foundation. Suffice here to say that GLP is an incretin hormone secreted by L cells of the small intestine in response to the nutrient intake. Upon being released, it acts on the pancreatic B cells and multiple extra pancreatic sites as well. So far so the pancreas are concerned, it increases the intracellular cyclic AMP so that glucose dependent insulin secretions are increased, but there are extra pancreatic sites also where it may work. Just by giving the delayed gastric emptying and early satiety satisfaction, filling, so that the appetite and the food intake is reduced and ultimately weight is reduced. As we see that GLP receptors are widely distributed in the immune cells and most of the organs, not only in pancreas, but most of the organs, and lung is one of them. And so they have their roles in the corresponding organs. The available GLP-1 receptor analogs have multiple pleiotropic outcomes, and it has been discussed in the earlier lectures as well, that it has they have the role not only in the liver, but the CNS and the cardiovascular system, in the kidney, and the respiratory system is also one of them. These pleiotropic effects, how they come out? There are multiple mechanisms. The most important are anti-inflammatory effect, immunomodulatory effect, and reduction of oxidative stress. The anti-inflammatory effect is both way, the systemic anti-inflammatory effect and the local anti-inflammatory effect in the airways, so that the inflammatory cytokines are reduced and the airway smooth muscle cell proliferations are also being inhibited, so that the inflammation in the airways are being controlled. Immunomodulatory effect is also very important, that modulate the immunity, so that the inflammatory phenotype of the inflammatory phenotypes of the Th1 cells has been transferred to anti-inflammatory phenotypes, so that the inflammation is again being taken care of. And reduction of the oxidative stress lead to improving of the endothelial function and reinforce the antioxidant effects. So far so the lungs are concerned, the GLP-1 receptors are expressed at multiple sites, right from the airway smooth muscles, epithelium, pulmonary vasculature, and type 2 alveolar cells. And upon activation, it leads to bronchodilation and airway smooth muscle relaxations. In the experimental models, it has been shown that the epithelial integrity is being maintained, so that airway inflammation is reduced, mucus hypersecretion is reduced, and NF-kappa B mediated inflammatory signaling all are being reduced. Thus, this had been postulated that these drugs may have the relevance in certain phenotypes of the patient, like obesity-associated asthma, steroid-resistant asthma, where metabolic dysfunction amplifies the airway inflammation. How this pulmonary mechanism takes place? it has been proposed that there is both it is the direct mechanism as well as the indirect mechanism. Directly, it suppresses the anti-inflammatory effects by suppression of the cytokines and the inflammatory mediators. And the bronchodilator effects has been brought about by cyclic AMP-mediated airway smooth muscle relaxation. And airway structural effects are being maintained by the proper maintenance of the airway epithelium so that the mucus production is reduced, preservation of surfactant activities is better, and all lead to potential improvement in the lung mechanics. Indirectly, the metabolic airway interactions lead to take place due to weight reduction and decreased neutrophilic inflammation and restoration of the nitric oxide signaling. So it is not only the obstructive airway diseases that where the GLP-1 receptor agonists are supposed to have the novel target, but there are other respiratory conditions also where it may work. In a meta-analysis of more than 77,000 participants, demonstrated that GLP-1 receptor agonist therapy was associated with decreased overall risk of the respiratory diseases versus placebo or other anti-hyperglycemic therapies. And if you see further, that this effect is basically appears to be a class effect because benefits appeared consistent irrespective of the comparator therapy, that is semaglutide, dulaglutide or liraglutide. Not only that, the study has also shown that GLP-1 receptor agonists significantly reduce the risk of pulmonary edema and bronchitis. So a plethora of the pulmonary diseases, right from the pneumonia to obstructive airway diseases to OSA, say to pulmonary edema and bronchitis, all may have the beneficial effect through the GLP-1 receptor agonist. COPD is another obstructive airway disease where it has been shown in the studies that it may help both as a direct airway pathway through targeted receptor activation, cellular signal suppression, chemokine regulation, as well as indirect metabolic pathway like mechanical unloading by weight loss, thus improving the respiratory system pressure and increasing the lung volume, systemic anti-inflammation leading to general improvement, and better glycemic control leading to better host defense. All these factors may help in the reduction in the COPD exacerbation. So in a study just published this year, it has been shown that GLP-1 receptor agonist lowered moderate to severe COPD episode versus insulin, sulfonylurea, and DPP-4 inhibitors. And not only that, it has been shown that it decreased the severe COPD exacerbation by 30% and moderate events by 37%. On the further analysis, it has been found that it reduced the respiratory infection by 6% and pulmonary fibrosis by 8%. But there is a caveat. All these are based on entirely on the retrospective observational data with residual confounding and missing spirometric metrics. There is one study in the obstructive sleep apnea that effect of liraglutide 3 mg in individuals with obesity and moderate or severe obstructive sleep apnea. It was done to investigate whether liraglutide 3 mg reduces OSA severity compared with placebo, and the study was published 10 years back in 2016. And the result was very encouraging. The liraglutide had shown to decrease the AHI more than placebo after 32 weeks. So it has been concluded that this drug may be used an adjunct to diet and exercise to reduce the OSA in moderate or severe obesity related OSA. This study have a very important clinical impact that GLP-1 receptor agonists may improve OSA via weight loss and by decreasing the systemic inflammation. And in 2024, all of us know that FDA has approved tirzepatide for moderate to severe OSA in obesity, along with calorie restriction and increased physical activity. Obesity hypoventilation syndrome is another area where this drug is likely to have good effects at GLP-1 receptor agonists may improve respiratory mechanics via weight loss and reduce leptin resistance. So preclinical and cohort studies demonstrate improved lung function with GLP-1 receptor agonist therapy. Pulmonary hypertension is a very big issue, and this drug has the potential to help in the pulmonary hypertension by reducing the chronic systemic inflammation, suppressing pro-inflammatory cytokines, improving the endothelial function, and enhance endothelial-dependent pulmonary vasodilation, reduce oxidative stress, and reverse the endothelial dysfunction and lower pulmonary vascular resistance. It has been found that GLP-1 users have less more reduction of pulmonary hypertension than others. ARDS and acute lung injury is another area where in the clinical studies it has been demonstrated that 40% reduction in incident pneumonia and severe sepsis among GLP-1 receptor agonist users suggests potential translational relevance. Interstitial lung disease is nowadays becoming more and more diagnosed, and it has been found in a study that semaglutide reduced bleomycin-induced fibrosis and ECM deposition markers in vivo. And there are evidences that remain hypothesis generating that fibrosis-specific clinical endpoints are currently lacking, and GLP-1 receptor agonist attenuated TGF-beta and other fibrogenic signalings. So, in nutshell, lung function and weight reduction have broader respiratory impact. GLP-1 weight loss reduces respiratory mechanics loading and improve lung function, reduce systemic inflammation, may lower respiratory risk exacerbation, improve glycemic control, may enhance lung function and host defense. Respiratory benefits likely reflect combined metabolic and direct airway effects. So GLP-1 receptor agonists may directly reduce airway inflammation and bronchial hyperresponsiveness. So there is a paradigm shift in this era of precision medicine that phenotype and endotype identification enables targeted asthma and COPD therapy, and GLP-1 receptor agonist is on the top of exemplifying emerging metabolic therapeutics in pulmonary medicine. But the limitation is that all the data are either observational or retrospective. We will have to have more prospective studies. There is one study just going on, that is double-blind placebo-controlled single-site RCT GATA-3 study at Tennessee. This study aims to assess asthma symptoms, quality of life, and airway function to evaluate the effect of semaglutide on asthma control. And the patients recruited in this study all are non-diabetics. So what we know, that GLP-1 receptor agonists consistently associate with fewer asthma and COPD exacerbation in observational cohorts, particularly in obese and or diabetic population. Weight loss and improved metabolic control likely contributes substantially with additional direct and anti-inflammatory inflammatory and airway effects. Safety profile is well characterized, and major new respiratory safety concerns have not emerged to date. Although GLP-1 receptor agonists are not yet a primary lung drugs, but we must actively address obesity and diabetes in asthma and COPD clinics. Consider GLP-1 receptor agonists were indicated for cardiometabolic regions. But we need to have more and more registry, more and more trials to help clarify causal effect and optimal patient selection. Thank you.
Thank you, sir, for enlightening us on the role of GLP-1 RA in respiratory disease. We will now move to the next session.
Thank you, sir, for your expert deliberation. As diabetes technology continues to evolve, improving precision, convenience, and adherence has become central to modern insulin delivery strategies.
From innovation to implementation, our next talk addresses an important practical challenge in diabetes care. I invite Dr. Kunal, sir, to deliver his talk on smart pens versus conventional delivery systems.
Thank you, everyone. Thank you, RSSDI Bihar chapter, distinguished seniors, and my dear friends. A very good afternoon. So, after so many wonderful talks, my talk is on technology part of the diabetes, and it's rather simple talk. And we have been doing this, giving insulin by common pens and all syringes. But there are newer technologies for insulin delivery system, and we'll be giving some light on that. So what are the ways of taking your insulin? We know that there are syringe and vials that has been in the use for very long period, and even in the rural part of India, the syringe is widely used. And how it works, we draw the insulin from the syringe and then we give it to the patient, and it is very easy. So what are the pros? It is very less expensive, does not need much of a skill, and very cheap and can be available anywhere. What are the cons? It has got two different markings, that 40 IU and 100 IU sometimes make it confusional what syringe should be taken. Harder to read, and you have to carry the vial and the syringe. Sometimes it is very inconvenient. Then comes the insulin pen, which is rather more better than the syringe part, and in this pen the pre-filled insulin is there, and the pros are that it has got fewer steps, more accurate and more discreet. Cons are that it's more expensive, you cannot mix insulin, it needs pen needle, and not all the insulin is in the pen form, and sometime in the rural areas you cannot find these pens. Then coming to the smart pen, which is not available in this part of the world, but it is widely used in the Western world, and it is a pen which is connected to your smart devices. And how it works, it is a pen with tracked doses and the syncs with an app. What are the pros? That it tracks and logs the doses, then it gives reminder to you whether you have missed the dose and whatever the doses you have taken, though it actually gives you the feedback of dose on the telephone, and then gives you an insight of how to track your insulin. The cons are that it can be expensive, needs app or tech, and if you are not very tech savvy, it's difficult for you, and you need a smartphone at least for this. Then it needs pen and needle, and not all insulin are compatible with this. Then finally, the insulin pump, which is there in India, those who are type 1 patients, who they are taking insulin pumps, and continuously insulin is being given with the insulin pump. The pros are continuous delivery, more flexibility, and can improve blood sugar control with the less pricks. Con, it is very expensive and requires training, and the site changes and maintenance is one of the important thing that can be sometimes difficult for the patient. So we need to decide what is the right for the patient depending on the budget, insurance coverage, health goals, preference for the injection over pumps, and then we need to individualize the pen according to the need for the patient. So coming to the roadmap to the smart insulin pens, initially the regular pens were there, the regular vials or syringe, which was the stage 0 of the legacy insulin delivery system. And here the vial and syringe is there, and traditional insulin pens are there, and no tracking decisions or supports was there. Just you have to keep a note of it. Then came the tracking insulin pens. The stage 1 was tracking insulin pen, where the retrospective or accurate dose data were taken care of. Later on came the real-time tracking insulin pens, which actually does the real-time tracking with the insulin required dose and the reminder with the cloud connectivity. Then integrated tracking insulin pen with the third stage, and the integrated diabetes management reports in insulin doses, carbohydrate and glucose requirement or the load on the patient. Finally, the smart insulin pens with the dose calculator, and it calculates the dose automatically. Then prime detection and individualized settings depending on the sensitivity or the target blood glucose levels or the dose dumping things. These were taken care of. And stage 5, the insulin smart pens with advanced decision support, which is actually featuring weight-based setup, based titration and clinical variable, and educational modules, and the coachings were associated with those smart pens. What are the challenges with the conventional insulin therapy? So suboptimal insulin use is widespread across the people with diabetes, and so many different aspects are there. People do miss insulin doses, and it's causing the suboptimal proportion of patient with diabetes reporting missing insulin doses in the real world practice. Also, the missed time insulin dose is very common, and patient with diabetes identify taking insulin at the prescribed time and taking insulin with meals every day as a key difficulties. Insulin dosing errors are there. Over and under dosing is reported to occur in studies investigating dosing errors. And also the insulin dosing miscalculation. So adjustment of insulin dose is highlighted as a considerable management challenge by the patient with diabetes. So coming to the comparison between the smart insulin pen over conventional insulin delivery system. So when you see a smart insulin pen, which is connected with a smart device, the phone or the laptop or your tablet, here it gets connected with NFC or Bluetooth with your phone, and you actually have more knowledge about what doses you are taking, so it's more visible. The smart dosing supports guidance and reminders, keeps you on the track, so you do know that you are missing insulin or the time of the taking insulin is there. Accurate dose delivery is there. So every time you take the dose, it tells you what dose has been injected or whether it has been injected properly or it has not been injected properly. So that track is also there. And these data actually helps to track the diseases, helps you to track the insulin delivery, and if your sugar is not controlled, whether the insulin delivery is faulty or you need different kind of insulin. With these data, you can consult your doctor and you can find out the solution for it. On the other hand, the conventional insulin delivery system, less visibility. Actually, you do not get any idea. Just you rotate the pen and you take the insulin. That's the thing. You do not have any track of the insulin. You have to note it down. Higher risk of errors are there, mostly with the elderly patients or younger patients. Dose calculation is always a problem, and sometimes it is whether the wrong dose or mismatched doses are there. Uncertain delivery. Sometimes you find that your patient tells that they have been taking insulin, but the sugars are not getting controlled, maybe because the insulin is not being delivered properly with these pens, and there is no data connection with any of the devices, so you do not know actually whether the insulin has been delivered throughout the time or not. So difference is clear. Smart pen provides visibility, right doses at right time, fewer errors with more confidence, integrated data with better decision making and better management of the diabetes and better life. Okay, so benefits of using smart pen, you get a better A1C control. When you give insulin with the smart pen, eventually the A1C gets controlled. Most of the time, the patient is in time and range with these smart devices, because when you give insulin with all those smart devices, your proper dosing, proper timing, everything is corrected, and you can up titrate or down titrate accordingly, and you can keep yourself in range. Insulin dosing also, sometimes with correct dosing and the sugar gets corrected, you can actually reduce the dose. You can actually reduce the dose of the insulin with all these insulin dosing. Then the patient reported outcomes. So all these devices, the smart devices, when given to the patient, the delivery system was so convenient and they could track the insulin delivery. The outcomes were very good, and they were also very satisfied with the insulin delivery system, so their diabetes could be better controlled. Economic outcome is definitely the insulin smart pens are expensive, and generally it is being used in the Western country with the insurance coverage. Later on in India also it can come with a lesser price, because when in India it can be given to a lot of people, so exclusivity will be gone and it can be catered at a lesser price range. Now coming to the bridging the gap, what is connected insulin pen? So connected insulin pen is actually a gap between the regular pens and the automated pumps. So these pens have got Bluetooth or NFC devices which can give data to the phone, and you can actually track your insulin doses, timing, or missed doses, whatever you can want, you can get the details, and you can share with your doctor in the real time as well, or you can get a graph out of it. So where the insulin regular pumps are very primitive kind of pen, just deliver the insulin, and the insulin pump being very expensive and very exclusive, cannot be afforded by all. This is a bridge between, you can just get a NFC enabled cap on the insulin pen, which get connected with the phone, and you can get all these datas. Okay, the real world impact of NovoPen 6, which is actually a smart pen. The real-life multi-center observational prospective study in Sweden done on over 94 people with type 1 diabetes using CGM or FGM. During the follow-up, we could find that those patients who were on NovoPen 6, they have got better time in range, they have got lesser time above range, they have less time below range, glycemic variability was less, and the missed insulin bolus doses were 43% reduced. So NovoPen 6 significantly improved glycemic control and reduced missed insulin boluses in people with type 1 diabetes. Now coming to one of the studies that shining the spotlight of the multiple daily insulin therapy, the real world evidence in the in-pen smart insulin devices, and the aim was to real world finding that in-pen smart insulin pen paired with the CGM used by the person in type 1 diabetes and type 2 diabetes, and method were retrospective cohort analysis was conducted with the real world data, almost 3,700 with type 1 patients and 552 with type 2 patients were there, and 808 unidentified. So outcome, diabetes management, that is the missed and the missed time insulin dosing, mismatched food intake and correction of dose delivery and glycemic outcome were assessed. And in the result, we found that overall type 1 population and a dosing frequency of more than 3 doses per day and the missed doses frequency of less than 20% was associated with improved glycemia. And in adult with type 2 diabetes, missing then less than 20% of dose was significant factor determining the improved glycemia. Also in the conclusion, we could find that integrating data from the smart insulin pen and CGM provide insights into the impact of dosing behavior and glycemic outcome. So it forms a counseling strategies for the diabetic care team through the technologically advanced insulin management for those using multi-dose insulin therapy. Now the smart pens, the bolus calculator, data tracking, dose history, onboard tracking, reminder of missed dose, insulin pump monitoring, and coordinate with the CGM data. These all can be done just on the smartphone, and we can share the data with the doctor, or we can keep the data for later on also. Now the diagnostic framework, smart pen versus smart pumps, where we can compare those. The smart insulin pen MDI and small insulin pump. The cost of smart insulin pen is much lesser than the pump, and it is much less invasive as compared to the pump. Function as assist manual injection and tracks dose data automatically, and here we have a closed loop with the CGM. And ideal patient profile actually who prefers simplicity, currently on regular pens and want digital tracking without a pump. All those who are on type 1 or needs more insulin, wants to be more precise and can spend more, they can be on insulin pump. So insulin pump now it's a device as a size of a pager. Initially it was a very big device, and first insulin pump was developed by Dr. Arnold Kaddish in 1963, and it was actually a chemotherapy pump which was converted to insulin pump, and it was like a prototype pump, and was found out that it has been doing a good job to control the diabetes. So insulin pump, types of insulin pump, tethered pump have a length of flexible tubing between the pump itself and cannula. The pump is to be tucked into the pocket, and some may be durable or BG monitor. So it's a very common pump that has been there in India for long. Patch pump is there, which is rather more concise, and it actually get patched on the skin and you get the data. Implant insulin pump, you get implanted inside your body, and it is more complex. It is not there in it in India. And closed loop insulin pump is just like an artificial pancreas. The CGM gets the data and sends the data to the pump, and you get the delivery of the insulin through the pump depending on what glucose levels you are having. So insulin pumps, issues with the classic pumps. Carb and correction bolus is calculated by the user, underestimating carb in meal with inaccurate boluses, no carb entry or database, bolus is easy to forget, no direct BG entry, and no exercise component is there. So the take home message is that digital insulin delivery system improve glycemic control by increasing time in range and reducing glucose variability. Smart insulin pen reduces missed dose and dosing errors through automated dose capture and reminders. Insulin pumps provide precise programmable insulin delivery, enabling better personalization of diabetes management. Connected devices simplify diabetes self-management by automatically recording and sharing the treatment data. And real-time insight from smart pens and pumps support informed clinical decisions and more proactive patient care. So this is, in short, we discussed about the conventional insulin devices and the smart devices, and we could learn that smart devices is the future of the insulin delivery system, although it is expensive right now, but can be cheaper when we give it to a large number of population. And probably one of the most important innovation in terms of insulin delivery system, because it gives a very accurate track of your insulin delivery and diabetes control. So with this note, I thank you very much for patient listening.
You have nicely narrated the whole thing, Dr. Kundan. Very good.
Thank you, sir.
You nicely. Any question from the audience?
Thank you, sir.
Okay, we will take it up later on.
Thank you, sir, for those valuable insights into optimizing insulin delivery.
True precision medicine lies not merely in obtaining lab values, but in interpreting them with the complexities of real-world clinical practice. I now invite Dr. Amit Kumar Das, sir, for his scientific discourse on interpreting HbA1c results, pros and cons.
Thank you, chairpersons, for the invite, and I am blessed to be at Aurangabad in front of dignitaries of RSSDI. Yes, sorry, it's Sasaram. I believe that I am in the district of Dr. B.K. Singh, so that's it's Aurangabad. So I'm so sorry, but I beg my apology. But that also tells that the public is not sleeping. Thank you very much, Sanjay Boss, for making the audience revive. It's a post-lunch session, so people have the habit of going into long naps. तो आप लोग सब जागे हैं ना? The topic is very boring. So HbA1c, where do we stand today? This is me, and not to go into details, I bring greetings from the land of lychees, but I bring only greetings this time, no lychees. That's because these lychees are now non-vegetarians. They are no more vegetarians because they have, with passage of time they start developing worms inside the lychees, so it's not worth taking. So that's why I didn't want to give you a vegetarian lychee, non-vegetarian lychee. So sorry for this. Greetings from Lychee City, and greetings from the stalwarts of Muzaffarpur, Dr. Professor Kamlesh Tiwari and Dr. Professor B.B. Thakur. Well, the setting is large and big. I'm sure you must be knowing the flag here. It's an Iranian flag, and the person on the next to the flag is Samuel Rahbar. Now, he is the person who started the concept of using glycosylated hemoglobin, or rather say glycated hemoglobin. In 1960, he identified that during electrophoresis of hemoglobin, you don't need to see the slides, I'm sufficient. During electrophoresis of 1200 blood samples, he discovered an abnormal fast-moving hemoglobin fraction which was loaded with some amount of glucose. So he later termed it as HbA1c. And this came into the scientific purview from here on, 1960s, and from 1980s during the famous DCCT and UK PDS, it was well established that people who had large amount of this fraction of hemoglobin were having more complications. So HbA1c or glycated hemoglobin then came as an understanding of measurement of complications of diabetes. So this is the historical aspect of HbA1c, and in generally we understand that HbA1c is equivalent to complications. So let's come into some of the basics. I think there are some medical students for a change here. They are here. How many medical students are there? So they are here for a change. Glycated hemoglobin is now accepted as the international standard method for assessing glycemic control in diabetes, as it reflects the average blood glucose over a period of weeks or months. Now, during hyperglycemia, there is non-enzymatic covalent attachment of glucose to the hemoglobin, which is called glycation, which increases the proportion in the HbA1 related to the non-glycated adult hemoglobin. And this rate of formation of HbA1c is directly proportional to the ambient blood glucose. Now there is a caveat that although the HbA concentration reflects the integrated blood glucose control over the lifespan of RBC, which is typically 120 days, HbA1c is most sensitive to changes in the glycemic control occurring in the month before measurement. It's better predictive of control over the last 30 days as compared to 120 days. Now the question is, what is the difference between glycosylated hemoglobin and glycated hemoglobin? Now in glycosylated hemoglobin is an enzymatic or enzyme induced attachment of glucose to the hemoglobin, whereas the glycated hemoglobin is non-enzymatic covalent bonding. So it directly reflects to the amount of increase of blood sugar above a certain level. So the correct terminology is glycated hemoglobin, and I'm sure this slide will run or not. Yeah, just to add fun to this. So this is the way the hemoglobin of RBC gets attached to the glucose and forms the HbA1c. And you have measurements of how you convert HbA1c to estimated average glucose, which can be converted into milligram per deciliter or millimole per liter. And these are the values which are giving at par of HbA1c to the estimated average glucose levels. Now the utility of HbA1c is basically of diagnosis, in monitoring purpose, and prognostication of a HbA1c. Now we know in 2026 still that pre-diabetes and diabetes is diagnosed when the HbA1c is 5.7 to 6.4% for pre-diabetes, and diabetes it's more than 6.5. And this comes from the reading of the DCCT trial, where the HbA1c to a certain level started increasing the microvascular complications, especially in retinopathy. So the monitoring, so that was the diagnostic part. The monitoring part was, it's basically individualized, and general target is less than 7%, stricter target is less than 6.5% for younger patients with a short duration of diabetes, or those with high risk of, with very low risk of hypoglycemia, less stringent for older individuals or patients with severe comorbidities, and very frail or end to life, the HbA1c target could be 8 to 9%. These are all understood and known facts, which is of not much use to the consultants, but it would be useful for the young people. Now, the prognostication, we have come to understand the importance of HbA1c from its prognostic value only. We understand that HbA1c is directly related to the complications. So we also understand that if we control the blood sugar, we'll be preventing complications. So there is a parameter that for every 1% reduction in HbA1c, you can reduce these huge complications. So you can reduce the risk of dying by 21%. You can reduce the microvascular, the triopathic complications by 37%. You can reduce the risk of amputations and peripheral artery disease by 43%. So improving your HbA1c to less than 7% is important. So HbA1c also has importance of prognostic value. So diagnostic, monitoring and prognostic value HbA1c. And this is the latest ADA guidelines, and here also you can very well say on the extreme left hand side, individuals who are at higher risk of higher hyperglycemia, you need to add very potent drugs. So these potencies of drugs are also decided on HbA1c values. So the power of a drug to reduce HbA1c decides the potency, and the drugs have been classified as patients drugs which have very high potent. This is dulaglutide, semaglutide and tirzepatide, which Dr. Sanjay sir was just talking about. And high potency was again metformin, pioglitazone, SGLT2. So this potency is also decided by HbA1c values also. So drug selection also depends upon the HbA1c. So it's always nice, everything is nice. सब कुछ अच्छा है, but चांद में भी तो दाग है. So what are the flip sides of HbA1c? Now HbA1c is basically an RBC plus glucose. So where there is defect in the RBC, you will get defects in the HbA1c values. So you will get inappropriate low HbA1c in individuals who are having hemolysis, certain hemoglobinopathies, recent blood transfusions, acute blood loss, hypertriglyceridemia, certain drugs which I will be just telling you, and chronic liver disease. Inappropriately high HbA1c where you are seeing vitamin B12 deficiency, iron deficiency, alcoholism, uremia, hyperbilirubinemia and drugs. And unpredictable HbA1c could be seen in the patients who have high fetal hemoglobin concentration, in patients who have methemoglobinemia and other certain hemoglobinopathies. Now these are some of the, these parameters are where the HbA1c fails to correctly be utilized where it is supposed to be, and I have already labeled some and told some of them, but in this slide I'll let you know that in certain physiological and metabolic status HbA1c may go wrong, like pregnancy, chronic kidney disease and liver disease. I had a presentation last week where I was telling that the HbA1c of a patient was suddenly 6.2 and the patient presented with hypoglycemia. So it was like patient was good. No, going HbA1c suddenly dipping in certain group of patients, and patient going into hypoglycemia is a red flag sign indicating of either a metabolic complications, liver or a kidney disease. That particular patient was suffering from decompensation of cirrhosis, and that caused decreased HbA1c. So physiological, pregnancy, chronic liver disease and kidney disease could be wrongly interpreted if you see HbA1c only. Then drugs like hydroxyurea, dapsone, which is not frequently used by physicians but are always used by dermatologists, and hydroxyurea by hemato-oncologists. Antiretroviral drugs, especially the stavudine class of drug. Vitamin E supplementation, which you are frequently giving these days, and medical conditions like hypothyroidism or hyperthyroidism, acute inflammatory states, acute blood glucose fluctuations. So these are some of the parameters where HbA1c may not correctly tell you the impact real glucose status or glycemic status. So and I'll let you know, in a usual patient there is a term called the blind spot of HbA1c. Now if a patient, say one single patient, spends half a day at a dangerous high level of 250 and you give him a shot of insulin and the sugar goes down to 50 milligram, your mathematical average for that patient would be 150. 250 to 150. So average is 150. And your HbA1c would be 6.8%. So this is the blind spot of HbA1c, and that's why the glucose spikes or stabilities are not often predicted by HbA1c, and hence we need to see beyond HbA1c in majority of our patients. This is the spikes and glycemic variability, which this slide is trying to tell you is not seen by HbA1c. It's an average, so it doesn't see the fluctuations every day. Intraday or interday fluctuations are not objectively observed by HbA1c. Now there are other parameters also, like you can get a blood glucose, so you compare it with RBS, everyday RBS, you need to have multiple pricks. And you can also compare it with the latest, what we call as continuous glucose monitoring. Now continuous glucose monitoring will also give you an average, what is called an estimated average glucose, and HbA1c in CGM is also calculated by this, which is called as glucose management indicator. Now CGM is a device which is put in your body in the interstitial space, and the blood glucose is sensed from here. So where does CGM device place? So HbA1c and EAG by calculation by HbA1c and calculation by the CGM devices have been compared, and time in range is the term which is used frequently. And now we have the terminology that every 10% increase in time in range leads to 0.5 to 8% decrease in HbA1c, which is corroborating with complications. So now we have a terminology, now we have a term, now we have a measurement which can replace HbA1c in predicting complications. So HbA1c may be getting obsolete, and these are the major diagnostic warnings. I already told you of the anemia trap red flag in the HbA1c. And now let me tell you that this is the latest in 2026. The New Zealand Diabetes Association has recently changed the HbA1c standards. So from 50, diabetes is now diagnosed in New Zealand at 48 millimoles per mole. Pre-diabetes has been again brought down to 42 to 47, and no diabetes less than 42. Now this is because they want to diagnose it early. Now moreover, the other flip side of HbA1c is that now we have moved from glucose-centric management to complication or metabolic control, and hence talking only of glucose control would not be sufficient. Intraday or inter-day variability also comes into glycemic management, and HbA1c is not fully satisfied, fully well placed in answering these variabilities. So we need to integrate HbA1c with time in range and CGM co-dependence. And moreover, we have an age-adjusted risk stratification which is also overlooked by HbA1c. So HbA1c in New Zealand has already been taken care of, and American Diabetes Association and the American Clinical Endocrinologist now say that CGM is preferred over standard blood glucose monitoring, the finger sticks. Time in range must complement HbA1c. We need to de-emphasize HbA1c because of the known inaccuracies of HbA1c, and expanding CGM into non-intensive basal therapy is the new fora, a new era, a new area which is to be looked on. So CGM is preferred in patients who are having no risk of hypoglycemia, especially nocturnal and hypoglycemia unawareness. The goal of target today is HbA1c, not HbA1c, rather time in range of more than 70%, with time below range less than 4%. De-emphasizing because we know the fallacies of HbA1c. We need to we need not to be 100% relying on HbA1c. Expanding the CGM, we need to promote CGM in all our patients, even patients who are stable, so that early diagnosis of complications, early diagnosis of hypoglycemia can be taken care of. This is the consistent timeline of daily glycemic targets. So with all limitations, despite all limitations, HbA1c still holds its validity in field conditions and serves larger populations of diabetic patients in diagnosis, monitoring and prognostication. Hence, I say that it will hold its place as a major tool in glycemic management in the next 4 to 5 years till the CGM finds its way in the general population. Thank you very much.
A very nice talk. A very nice talk on a very practical problem.
Thank you for the practice-changing discussion, sir.
Managing diabetes often means navigating complex therapeutic decisions. To discuss practical approaches in treating obesity and diabetes, I invite Dr. Pushparaj Anand sir to deliver his talk on exercise prescription in diabetes.
Good afternoon, everybody. I would like to thank RSSDI Bihar chapter for providing me this opportunity. Daily, we have a lot of diabetes patients coming to our OPDs. We counsel them, we give them OHAs, we give them insulins. But the one thing all of us say is lifestyle management. What is this lifestyle management that we want our patients to do? Exercise, walking, running, jogging, or lightweight meditations, yogas and all. So today, we'll discuss what should be the exercise prescription that we should mention in this diabetes. So what exactly is diabetes? Coming to the history of diabetes, the term was coined by Ethan Sims in 1973, and it describes the close pathophysiological link between obesity and type 2 DM. More than 85% of the adults with type 2 DM are either overweight and obese. Hence, it highlights that the obesity is a major driver of diabetes. The visceral adiposity is the major cause of lipotoxicity, causes chronic low-grade inflammation, and hence insulin resistance. So what is the clinical significance of this? The clinical significance is this, that the obesity and type 2 DM share interconnected metabolic pathway and hence often coexist. So what is the global diabetes epidemic? 1 in 9 adults globally are currently living with diabetes as of 2024. The global diabetes health expenditure surpassed around $1 trillion for the first time in 2024. So low and middle income countries account for over 75% of the global burden, where obesity growth tracks with the economic transition. Talking about India, the national diabetes burden, the ICMR India 2023 landmark multi-state study estimated that India's national diabetes prevalence currently is at 11.4%. That is 101 million adults are suffering from diabetes, and around 39.5% at overall BMIs, causing accelerated cardiovascular risk. So when we prescribe the drugs, we give the patients these informations about the exercise. So this exercise is a primary modality. Why? Because it is an anti-inflammatory action. The skeletal muscles acts as an endocrine organ. They release the myokines like interleukin-6 during the exercises, which promote the anti-inflammatory interleukins-10 and inhibit TNF-alphas. They also are insulin independent. The muscle contraction activates the AMPK, which triggers GLUT4 translocation to the cell membrane, completely independent of the insulin. And lipotoxicity reversal. The regular exercise drives mitochondrial biogenesis and fat oxidation, hence rapidly clearing the intramyocellular lipids. So what is the aerobic versus resistance training? The aerobic exercises increases the VO2 max. It increases the fat oxidation and also increases the insulin sensitivity. Whereas the resistance training increases the muscle mass, increases the glucose uptake, and increases the insulin sensitivity. But when combined, both aerobic exercises and resistance training, when done together, they are the best HbA1c reduction, as they have a synergistic effect and hence a superior glycemic control. Here in this image, we see a meta-analysis result showing main changes in HbA1c percentage across different exercise interventions in patients with type 2 DM. When we see the control, there's a reduction of 0.05%. In resistance training only, there's a reduction of 0.38%. In aerobic training, there's a reduction of 0.51%, but when combined, there's a reduction of 0.82% only by exercise. The exercises can be either moderate continuous or high intensity interval training. The moderate continuous are exercises which have a traditional approach, and they have exercises of 150 to 300 minutes per week at 45 to 65% of VO2 max. They have a proven safety profile, but it requires a significant time commitment, which we all generally lack. But in high intensity intervals, it involves brief bursts of intense exercise that is greater than 85% of VO2 max. The meta-analysis proves that high intensity interval trainings deliver superior improvements in the VO2 max and hence insulin sensitivity. It thus promotes rapid GLUT4 upregulation and glycogen depletion. So ectopic fat deposition and exercises, how are they related? When exercise is done on a continuous basis, they independently reduces the intrahepatic lipid level by 20 to 30%. The visceral adiposity is mobilized preferentially due to its rich vascularity and high density of lipolytic beta adrenergic receptors. The lipotoxic reversal is also taken place due to this exercise and clears cardiac and pancreatic fat, preventing organ failures. This figure shows mean visceral fat area reduction over a 24-period progressive exercise. Like from the baseline, from week 6, week 12, week 18 and week 24, the visceral fat has gradually reduced. So what are the muscle metabolic adaptations? The mitochondrial biogenesis takes place, that is, there is an upregulation of PGC1 alpha, and there is a capillary recruitment. The exercise-induced VEGF expression drives a neoangiogenesis. So higher muscle capillarization shortens the transit pathway of the insulin. So when we talk about exercise timing and how its relation with glycemia, it is already indicated that the skeletal muscles, when they act as an endocrine organ, they release certain interleukins and inhibit the TNF alphas. So coming to the most important topic, how do we prescribe these exercises? There's basically when any patient comes to us with type 2 DM, all the patients with diabetes should undergo structured pre-screening. Diabetologist must assess for any cardiorespiratory disease, any myocardial ischemia or microvascular limitations. A ECG stress test should be done before initiating any vigorous intensity training in the patients. There's a FIT principle which suggests that the frequency should be 3 to 5 days per week. The intensity should be 40 to 60%. The time duration should be 150 to 300 minutes per week, and the type should be rhythmic and large muscle groups should be involved. Whereas in resistance training, the FIT principle states that the frequency should be 2 to 3 days only. The intensity should be higher of 50 to 70%. The time should be of 2 to 4 sets, and each set should include 8 to 12 reps, and the type should be progressive resistance. So the high intensity interval training and its protocol should only be prescribed to once baseline conditioning is established. Initially, 4 to 6 weeks of moderate intensity training is recommended first, and then you hit on to the high intensity training. 1 minute high effort followed by 1 minute active recovery is what is suggested. Medical screening is a very strict priority which should be always done. Can we control peripheral neuropathy? Yes. Loss of protective sensation in patients with severe DPN, diabetic peripheral neuropathy, increases silent ulceration, tissue damage with Charcot neuropathy risks. Not weight bearing training should be done, pivot towards low or non-weight bearing exercises like swimming, stationary cycling or chair workouts. A daily foot inspection should be done, mandate rigorous pre and post exercise examinations, checking for erythema and blister formation should be regularly done. Diabetic retinopathy precautions. We should tell the patients to avoid intraocular pressure spikes. The patients with severe non-proliferative NPDR or active PDRs must strictly avoid activities that spike the blood pressure. They should avoid the Valsalva maneuver like isometric heavy exercises, resistance training, and breath holding increases the risk of vitreous hemorrhage or tractional retinal detachment. They should limit jarring or head movement. They should ban high impact running exercises or aggressive jumping and head down positions. There is a hypoglycemia risk mitigation. The insulin and sulfonylureas, they cause high danger of hypoglycemia during and after exercises. Hence, we should reduce rapid acting insulin dose by 30 to 50% if exercise occurs within 2 hours of the injection. Coming to SGLT2 and GLP-1, very low direct hypoglycemia risk and when used as a monotherapy. However, dual therapies with insulin still mandate for the careful dosing. This is a picture showing 12-week exercise progression. In the first 2 weeks, there is a light aerobic exercises like 10 to 15 minutes walking, and the patient should focus more on safety and routine adherence. Weeks 3 to 6 should focus on volume expansion, that is increase aerobic time to 30 minutes, time should be increased to 4 days per week, and introduce light resistance bands. For the 7th to 10 weeks, the resistance integration should be done. That is structured machine-based resistance training should be included, 2 to 3 sessions of each should be done, and around 60 to 70% of one resistance exercise should be done. For weeks 11 and 12, intensity optimization should be included. So exercise and diabetes remission shows that we can have remission of HbA1c when we have good exercise in patients. But what are the barriers to this exercise adherence? We prescribe adherence to all the we prescribe exercise to all the patients, but why the patients are not adherent to that? Because they have a lack of time or work commitments, joint pain or orthopedic limits, fear of hypoglycemia or injury, and low motivation. So we have to give some behavioral support strategies like insulin independent, lipotoxicity reversal, and anti-inflammatory. This we have to explain to the patients. There are certain sedentary breaks versus exercises like sitting diseases which increase, the power of snacking on exercise, and maximizing non-exercise activity thermogenesis via standing desk or stairs drives metabolic health improvements. Prescribing in older adults, the sarcopenic diabeticity, the dangerous intersection of age-induced skeletal muscle loss, sarcopenia, and progressive adipose expansion leading to severe physical disability. There is anabolic resistance, that is aging muscle requires higher resistance loads, and synchronized dietary protein ingestion to trigger muscle protein synthesis. We have to balance priority, like include progression balance training 2 to 3 times per week. Exercise and gut microbiomes are also related. Anti-inflammatory microbiota shifts. Cardiorespiratory training increases the ratio of bacteroids to firmicutes. And gut barrier optimization is also favorable in cases where exercise promotes the growth of butyrate producing taxa, which reinforces the intestinal tight junctions. Lifestyle medicines in consensus. Physical activity should be considered an essential part of the clinical management of the diabetes. It has a powerful disease modifying effect that no single pharmacological agent can fully replicate. The joint consensus statements and ADA and EASD states this only. So what are the key clinical takeaways? That the prescriptions should be structured in such a way that patients have perfect guidelines what to do and what not to do, how much to walk and what exercises should be done, what exercises should be avoided. And safety should be first, always pre-screening high-risk patients, implement strict microvascular foot care, and retinopathy specific size limitations should be done. Thank you.
Thank you.
Thank you, sir, for enriching us with your clinical insight.
Now, our final speaker will address an important complication increasingly encountered in clinical practice. I would like to invite Dr. Abhishek sir to speak on non-invasive assessment of liver fibrosis.
Good afternoon, everyone. So, when this topic was given to me, my first question was, why is this topic given to me? Like, it's not, like all diabetes, insulin, and sugar control and obesity, what we have heard till now. And then I was like, why is topic of किसी gastroenterologist या किसी radiologist को क्यों नहीं दे देते? But then it was told that okay, this topic is for you. So I prepared slides on this, and a very interesting topic. How is it important? Why should we speak on this? See, in India, what we have patients हमारे पास आते हैं, बोलते हैं, सर हम तो कुछ खाते ही नहीं है, वजन कम नहीं रहा है, वजन बढ़ ही जा रहा है. तो BMI भी बहुत बार हमने चेक किया है, BMI भी नॉर्मल है, मगर सेंट्रल ओबिसिटी है, Everybody has got a waste ratio, which is more than what it should be. So we have something known as, we have a carbohydrate-rich diet in our, we have a carbohydrate-rich diet in our country. So it is very important to take care of all this. And why आजकल के मतलब जितना भी नए रेडियोलॉजिस्ट भी फर्स्ट ईयर एमडी भी खत्म करके आते हैं, फर्स्ट डायग्नोसिस विच दे गिव इन अल्ट्रासाउंड इज grade 1 फैटी लिवर, एंड एवरीबडी इज कंसर्न, सर मेरे लिवर में सूजन हो गया है, कैसे ठीक करें, लिवर में सूजन हो गया. आई थिंक इवन in peripheries, practitioners are even treating them. I don't know with medication, but they are treating it. Even liver का सूजन का इलाज किया जा रहा है. So coming to why this is important, what happens actually? So what is hepatic fibrosis? So it is a response to chronic liver injury, some repeated insults to our liver, whether it may be due to alcohol or hepatitis or gaining weight, obesity, fat accumulation. So there is a response to chronic liver injury. There is collapse of the hepatic lobules, formation of fibrous septa, and then starts the hepatocyte regeneration. But this hepatocyte regeneration is not like a normal hepatocyte. It starts with nodule formation. And there is a mismatch between the production and accumulation. The extracellular matrix components which accumulate, and there is an imbalance in production, deposition, and degradation. So most commonly used staging techniques, there are many staging techniques, but the most commonly which we use is the Metavir score technique, and it is most commonly used histologic scoring system, where F0 stands for no fibrosis, F1 for portal fibrosis without septa, F2 is few septa formations, F3 numerous septa without cirrhosis, and F4 of course with cirrhosis. So then yes, why should we keep a track of this? Why should we check for fibrosis? Of course, which patient should we screen for fibrosis? What is this APRI score, the aspart aminotransferase platelet ratio, the NAFLD fibrosis score, the serologic tests which we have, the transient elastography, and the shear wave elastography. So non-invasive tests. Everybody wants a test which is non-invasive. किसी को भी पसंद नहीं है कि आप उनको सुई भोंकते रहिए या और कुछ तंग करिए, जो सबसे cheapest test हो. So non-invasive tests coming. They identify the risk among individuals with risk for metabolic syndrome, metabolic risk. Identify worse prognosis in a secondary or a tertiary care center, somebody with obesity, NASH. Monitor disease progression. Predict response to therapeutic intervention, somebody who is on a treatment for hepatitis B or hepatitis C or hepatitis E, predicting the response to therapeutic interventions. And of course, the gold standard test which we have for liver fibrosis is of course liver biopsy. But then liver biopsy cannot be done in everybody. You know, it's a painful process. It has its own set of complications. Convincing somebody for liver fibrosis and then discussing with the pathologist. And when you do a liver fibrosis, do you actually go to the site? The whole liver may not be affected, a part of the liver may be affected, and the pathologist will report only the part from which the biopsy has been taken. So it is again a difficult part to correlate with. So coming to the non-invasive test, this is where the role of non-invasive tests come in. So there are alternative ways to determine the degree of fibrosis. It helps in monitoring the disease, safe and simple way. It is more cost effective opposed to biopsy. It helps to assess fibrosis, absence or presence of fibrosis, and of course, in those patients who are at a higher risk of fibrosis, to monitor their progression to cirrhosis. Sequential tests. So coming to the latest guidelines, which we have by the American Association for Study of Liver Diseases, there has been a significant increase in developing clinical prediction rules and non-invasive biomarkers for identifying steatohepatitis, and increasing evidence of prognostic value in non-invasive tests. So coming to the recent guidelines, category A, fibrosis is the most important prognostic factor for NAFLD, and we have biomarkers which come with evidence, grade A, B, C, and D biomarkers with fibrosis scores, transient elastography, acceptable non-invasive procedures, then the biomarkers, plus there is a big gray zone. When we do non-invasive tests, there is a big gray zone. Those which have a low score, finally we can 90% we can rule out fibrosis. Those who have a high score, fine, we can rule, fine, they are having fibrosis. But those indeterminate, the middle ones, are the ones in which we have to correlate. We have to add on some other tests to assess fibrosis. Then to monitor fibrosis progression, identification of advanced fibrosis by serum biomarker scores. In selected patients with high risk of liver disease, we have to monitor the progression. And of course, where we predict that they have a high risk of fibrosis, we have to go for liver biopsy. So, for assessing liver fibrosis, we have the class 2 biomarkers, the class 1 biomarkers, and of course the imaging techniques. So I will be discussing the few serologic markers which we have, and of course all the radiologic methods which we have. So this has come to the short slide which shows the fibrosis progression. Most non-invasive methods currently have a good accuracy to identify advanced stages of fibrosis. We have the class 1 biomarkers, then we have the class 2 biomarkers, stellate cell activation, mild fibrosis, F1 stage which we call, and then the significant advanced fibrosis, that is the F2, F3, and then of course cirrhosis. In near future, it will be possible to use genetic and metabolic profiles to allow us to identify liver fibrosis at very early stages. So commonly used non-invasive techniques which we have the simple scoring systems like the NFS scoring system, the FIB4 scoring system, the APRI, the aspartate aminotransferase platelet ratio index. Of course, when patients come to us, all of us, mostly we do a LFT and we do a CBC, so we get a platelet value and we get a LFT value. So calculating the APRI score is not a big deal. It is like a non-invasive test to them. Like already blood test has been done, so you just have to calculate it. Nothing extra has to be done. And then we have the proprietary test, of course, FibroSure and FibroTest. FibroTest is in US and FibroSure outside. Advanced liver fibrosis. And of course, coming to the imaging techniques, हम लोग जो बोलते हैं FibroScan जिसको बोलते हैं transient elastography, the shear wave elastography, and of course the MRE, magnetic resonance elastography. It is still an area of active research, and it is still continuing to evolve. So what is when do we assess for fibrosis? When patients come to us, those whom do we exclude? Those who are with obesity, type 2 diabetes, metabolic syndrome. We look at the risk factors, we look for evidence of fat accumulation, and then we go for other tests. Those with fibrosis, F criteria greater than equal to 3, we use others. Like what I said, those who are on the moderate criteria, we have to correlate with other tests. Those who are at a lower score, we can safely rule out. Those who are at a lower risk, we can safely rule out. Those who are at a higher risk, of course, they have fibrosis. We can go for liver biopsy. But then you see the middle part, what we are showing, those who are at the intermediate risk category. In those, we need other tests to confirm liver fibrosis and to monitor. Coming to the AST, aspartate aminotransferase to platelet ratio index. So they have 2 cutoff values to distinguish different liver fibrosis. A high cutoff is used for diagnosing patients with significant advanced fibrosis or cirrhosis, and a low cutoff is used for excluding or for minimal fibrosis. So it is very easy to calculate. As I told, the values are already with us when the patient comes, and we just need to calculate. And instead of wasting time, we have many calculators online. We can use it from our app store, and we have something MD Calc, which we can just put in the values and it will calculate. So coming to those with a lower score, sensitivity is 90%, we can rule out fibrosis. Those with a higher score, more 0.84, of course, presence of higher advanced fibrosis. But then the mid zone, the gray zone, is the indeterminate zone, which we have to look into. So this graph shows, I think this slide, the graph is not showing up on the slides, but then when this was compared with liver fibrosis to see mortality rates, death and liver transplantation, it was shown to APRI had a similar curve compared to liver biopsy. And those with a low score, we could rule out fibrosis, and those with a high score, we can rule in, but with the indeterminate one, we needed further studies. And this shows the comparison of APRI across different studies, and it shows again the area under the curve for those between 8 and all. Those with lower and those with higher are fine, but for indeterminate ones, we need further studies and correlation. Performance of APRI for identification of fibrosis, the recent analysis, although APRI has been recommended as a perfect non-invasive model to evaluate liver fibrosis, but still many studies are still needed. All the studies which have been done have been shown to be accurate in hepatitis B patients, related fibrosis. Coming to the next one, NAFLD fibrosis score. of course, how this is different from the previous score. This takes in more consideration, like it considers the age, the BMI, the glucose levels, the AST, ALT, platelet, and the albumin count. Now you see both these things, the NFLD and the previous what we were talking about, the AST, the APRI method. In both, they are considering platelet values, LFT values, albumin values. So if a patient is suffering from any chronic disease or any other disease which can affect the platelet count or the albumin levels, we can have a bias in our results. So that is how we have to be careful. So how again in this also we have the lower values which we can rule out. Sensitivity is 89%, and the higher values specificity is 89%, but the indeterminate one, the cutoff values, accuracy, this is where we have to relate with other tests. So this again, this graph shows comparison with liver biopsy, and this is what it is trying to show, that the lower and the higher cutoffs are okay, but in the yellow line, the intermediate ones are which we have to look into. So what are the limitations of serologic tests? Of course, they typically reflect the matrix turnover, not the deposition. They tend to be more elevated in those with high, where there is inflammatory activity is high. Of course, with hepatitis, other diseases, many are not liver specific, and concurrent sites of inflammation or fibrosis may contribute to increased levels. Lyrics are also affected by clearance rate and may be impaired due to sinusoidal endothelial dysfunction, impaired biliary clearance, and many of them are surrogates, not actually true biomarkers. Coming to the elastography, the most commonly which we prescribe, it estimates liver stiffness by applying mechanical waves and measuring their propagation speed through tissue using imaging. And using the same ultrasound, we have different techniques like ultrasound-based techniques which have transient elastography or our fibroscan, the acoustic radiation, AR-FI imaging, the 2D shear wave elastography, and of course our magnetic resonance in elastography. So coming to transient elastography, this is the device which is used. It is not a common probe which is available in all ultrasound devices. It is a separate probe which has to be used, and it is a man behind the machine. So the person who is doing the test, he has to know how to do the test, and so that's how it affects the reporting also. So we have to be careful with the results, and that's why it is not done at all centers. So the stiffness is computed through the waves, and the values are calculated. Those with less than 7.9 fine, those with greater than 9.6 fine presence of advanced fibrosis, specificity 92%, and sensitivity for those less than 7.9 is 91% fine. Imaging techniques evaluates both fibrosis and steatosis. So coming to the gray area, the most thing is that the failure to obtain readings is more likely in patients with high BMI, in obese patients, those with ascites, and those with ascites and high BMI obese patients, the values can be different, and there can be overestimation and underestimation. So this graph again compares it with the transient elastography score, compares it with liver biopsy, the same gray area where we have to be careful. Coming to shear wave elastography, this technique is also done using the ultrasound mode, but it is slightly different from transient elastography because more readings are taken. It is not taken from one site. Many other areas are also evaluated, and a 2D image picture of the liver is made. So we can actually see which part of the liver we need to assess. Can use to evaluate liver stiffness, and result of liver cirrhosis could be correlated to esophageal varices. And this is the area under the curve. It shows it is highly specific diagnostic performance according to AURs of a good and excellent for the diagnosis of significant fibrosis, and excellent in the diagnosis of severe fibrosis and cirrhosis. So coming to one of my last slides, what is the management algorithm? When a patient comes to us, we begin with the ultrasound elastography result. Those with less than F2, we follow up clinically with APRI and elastography. When elastography is greater than F2, we go for biopsy, or we monitor biopsy for basic, somebody suffering with hepatitis or any diseases, we keep on monitoring, and we follow up, and then if needed, we go for biopsy. Thank you.
Thank you, sir. Now, we may have any questions from the audience.
Thank you, sir, for an excellent overview of modern approaches to liver fibrosis assessment.
As guided by the chairpersons, the floor is open for questions and comments.
हेलो, नींद से जगा दिया जाए। डॉक्टर साहब, आपके स्लाइड में ना VO2 मैक्स लिखा हुआ था कि VO2 मैक्स, वो कैसे कैलकुलेट करते हैं?
सर VO2 मैक्स का सर VO2 मैक्स बेसिकली है कि मैक्सिमम ऑक्सीजन रिक्वायरमेंट ड्यूरिंग इंटेंस ट्रेनिंग के लिए होता है। सर देयर आर मशीन्स रिक्वायर्ड फॉर दैट व्हेन वी लाइक जो एथलीट्स होते हैं सर, या फिर जो स्पेसिफाइड ट्रेनर्स ले होते हैं, उसमें सर वो बेसिकली वो जैसे सर हम लोग SpO2 कैलकुलेट करते हैं या बेसिकली सर वैसे ही रहते हैं, तो वो आपको सर स्क्रीन पे शो करता है सर। तो सर ये ऐसे कुछ सेटिंग्स रहते हैं। यस सर, बेसिकली जो आपका हाईएस्ट ऑक्सीजन रिक्वायरमेंट रहेगा सर व्हेन यू आर डूइंग एन इंटेंस ट्रेनिंग, उस समय सर जो अगर हम लोग सर दो तरह की एक्सरसाइज जैसे वी हैव डिस्कस्ड, एक होता है सर मॉडरेट, एक होता है हाई इंटेंस। तो सर जब मॉडरेट करेंगे सर तो ये जो हमारा VO2 मैक्स रहेगा, दिस शुड बी सर लेस देन अराउंड 60, मतलब सर 45 to 50% ऐसे करके। बट व्हेन वी डू एन इंटेंस ट्रेनिंग दैट वुड बी आउटबर्स्ट ऑफ दैट, बट फॉर अ लेसर पीरियड ऑफ टाइम। तो सर ये होता है कि जोर ज़्यादा लगाएंगे बट कम देर के लिए लगाएंगे। मेजरमेंट का तो ऐसा यस ऐसा नॉर्मली सर अगर हम लोग सिर्फ पेशेंट को अगर कॉमन लैंग्वेज में बताना सकें तो मेजरमेंट सर ऑब्वियस सी बात है सर, हम लोग कॉमन मतलब डेज में या फिर अपना OPD में सर ये तो बता पाना थोड़ा मुश्किल है। तो सर हम लोग ऑफ योर मैक्सिमम लिमिट करके बता सकते हैं कि जहाँ पर आप ओवर एग्जर्ट ना करें, आपका हार्ट बीट ऐसा ना हो कि आप मतलब बहुत ज़्यादा आपको टैकीकार्डिया एक्सेसिव। SpO2 से नहीं करता है सर। SpO2 इज मतलब नॉर्मल रेस्पिरेशन में आपका SpO2 कितना है, VO2 मैक्स इज आप कितना तक जा सकते हैं। यस सर, यस।
Thank you, sir. With this, we conclude this interesting and very informative session. Now, I request volunteers to take our respected chairperson and speakers for felicitation. Thank you. We will continue with the next session.
We now move forward to the next session, session number 5, special focus tracks, where we will explore some of the most relevant and emerging aspects of diabetes care. To guide this academic session, I would like to invite our esteemed chairperson to kindly take the seats on the dais, Dr. Sujit Kumar sir and Dr. Manish sir. May I Dr. Sujit Kumar sir and Dr. Manish sir. May I request our respected chairperson to please join us on the stage.
Thank you, sir. With the permission of our respected chairpersons, we shall begin the scientific proceedings. Our first speaker for the session is Dr. P.K. Sinha, sir, who will be speaking on the topic low carb versus keto, the evidence-based. May I request Dr. P.K. Sinha, sir, to kindly deliver this talk.
So very, very good afternoon, everyone. After having so many lectures on different subjects related to diabetes, looking for the precision gap, we are here now to look for how the diet should be managed. We always talk of lifestyle modification. Of course, it includes changing dietary habit and, of course, adding proper exercises, which already been taken on. Next page. So, on the slide, please. Yes, thank you very much for presenting the slides. First, ladies and gentlemen, let us begin with low carb versus keto. Well, a healthy diet is important for a healthy life. As stated by the old saying, you are what you eat. Well, friends, this is even more important in today's world where diabetes and obesity is a pandemic. According to the International Diabetic Federation AIDS Diabetes Atlas, about 425 million people worldwide have diabetes, and if the current trends continue, 629 million of people aged 20 to 79 will have diabetes by 2045. Well, nutrition is the key for preventing type 2 diabetes and obesity, but there are no evidence-based data defining the best dietary approach to prevent and treat these conditions. The evidence are there. Well, friends, in the last decades, low-carb and ketogenic diets got popular among clinicians and patients, but the appropriateness of the reducing carbohydrates intake in obese patients and in patients with diabetes is still debated. The studies in the literature are indeed controversial, possibly because these diets are generally poorly defined. This, together with the intrinsic complexity of dietary intervention, makes it difficult to compare results from different studies. Despite the evidence that reducing carbohydrates intake lowers body weight and in patients with type 2 diabetes improves glucose control, few data are available about sustainability, safety, and efficacy in the long term. Well, friends, by the end of this presentation, participants will be able to differentiate low carbohydrate and ketogenic diets, understand underlying metabolic mechanisms, review evidence in obesity, diabetes, MSA-LD, and cardiovascular disease, evaluate cardiovascular benefits and risks, and identify appropriate patient selection, and of course, apply evidence-based dietary recommendations. Friends, why this topic matters? Well, friends, the cardiometabolic epidemic, 1 billion individuals worldwide affected by obesity, rising prevalence of type 2 diabetes, metabolic dysfunction associated steatotic liver disease affecting 30% of adults, residual cardiovascular risk despite pharmacotherapy. Well, friends, so what is the central question? Can carbohydrate restriction provide additional cardiometabolic benefits beyond the drug therapy? Well, friends, then let us start with the definition. A standard diet which contains 45 to 65% calories from carbohydrate. Moderate low carb, 100 to 130 grams per day of carbohydrate. Low carb, 50 to 100 grams of carbohydrate per day. Very low carb, less than 50 grams of carbohydrate per day. And ketogenic diet, 20 to 50 grams per day. So friends, key point is that ketogenic diet represents the extreme end of carbohydrate restriction. Well, friends, low carb versus keto, if you take the low carb is carbohydrate 50 to 130 grams per day, where keto has got 20 to 50 grams per day of carbohydrate. Ketosis is usually absent in low carb, where it is present in the keto diet. Protein is moderate to high in the low carb, whereas in keto diet it is moderate amount. Fat is variable in low carb, it is very high in keto diet. Sustainability is better in the low carb, whereas keto it is lower. And clinical supervision requires a moderate supervision in low carb, but often required very high monitoring in keto diets. Well, friends, in general, keto diet means very low carbohydrate with high protein, moderate protein, and high fat, whereas low carb diet means a low carb with moderate to high protein and moderate amount of fat. Well, friends, it is a metabolic continuation, progressive carbohydrate restriction, normal diet to low carb to very low carb to ketogenic diet and nutritional ketosis. And metabolic changes corresponding is, as you go from this metabolic continuum, insulin decreases, glycemic variability decreases, lipolysis decreases, fat increases, fat oxidation increases, and ketogenesis is the result. So improved metabolic flexibility. So low carb ketogenic diet means increased lipolysis, increased fat oxidation, and so ketone production by the liver. Well, friends, ketosis is typically defined by beta hydroxybutyrate 0.5 to 3 millimole per liter. Major effects are reduced insulin secretion, increased fatty acid oxidation, increased ketone body production, appetite suppression, and alternative cerebral fuel utilizations. Well, friends, proposed mechanisms, the glucose pathway, carbohydrate intake when decreased, postprandial glucose is decreased, so insulin exposure is decreased, leading to increased lipolysis and decreased visceral adiposity. In liver, de novo lipogenesis is reduced, so hepatic fat is reduced, and vascular, on the vascular aspect, inflammation is reduced, oxidative stress is reduced, and endothelial dysfunction is reduced. Well, friends, coming to evidence in obesity, meta-analysis evidence, Bino et al. In 2013, greater weight loss with ketogenic diets. Mansoor et al. In 2016, it improves HDL and reduces triglycerides. Well, key messages are, ketogenic diets often produce superior short-term weight loss, but long-term difference diminishes as adherence declines. In type 2 diabetes, major benefits: reduced HbA1c, lower fasting glucose, reduced insulin requirements, and potential diabetes remissions. Well, friends, BMJ meta-analysis says higher diabetes remission rate only at 6 months, significant glycemic improvement. Well, the clinical implication is dietary carbohydrate restriction should be considered as a therapeutic option in type 2 diabetes. So impact on cardiovascular risk factors, as you could say, well, in the low carb or in the keto, both the weight, HbA1c, and triglyceride goes down, with better reduction with keto diets. HDL-C increases with low carb and better increase in keto, but blood pressure decreases, CRP decreases with low carb and also with the keto. So somehow or other, everything runs in the similar line, with slightly more with keto diets. My friends, the LDL controversial remains. The potential concern, some individuals experience significant LDL-C elevation in keto diets. There is ApoB increase in keto diets and increased LDL particle number. When you lean mass hyper-responders, phenotype characterized by lean body habitus, markedly elevated LDL-C, high HDL-C, and low triglycerides. Well, friends, the clinical question remains, does HDL elevation negate metabolic benefits? Still under investigation. Well, friends, impact on atherosclerosis, the current evidence, favorable changes in favor of benefiting the atherosclerosis are, it lowers triglycerides, increases HDL-C, reduces insulin resistance, and reduces inflammatory burden. But with the potential risk of elevated ApoB, elevated LDL-C, and unknown long-term plaque effects. So, friends, ladies and gentlemen, current position is no definite cardiovascular outcome trial has yet established superiority of ketogenic diets. Well, friends, so far MSALD concerned, keto diet gives you reduced hepatic fat, improved insulin sensitivity, improved ALT, AST, and reduced liver inflammation. with the mechanism reduced de novo lipogenesis, reduced hepatic glucose flux, and increased fat oxidation. So in MSALD, there is a low-carb diet has got a benefit. Well, friends, clinical relevance is particularly attractive in obesity, diabetes, and MSALD. Well, friends, emerging areas in neurology, if you go for the established one, it is used for treatment in refractive epilepsy. In 1921, at the hospital Mayo Clinic, it was used for treating refractory epilepsy with good results. Still now, the investigation is going on in neurodegenerative disease, that is Alzheimer's and Parkinson's disease. It is because of it induces membrane stability and reduces the brain excitability, neuronal excitability at the level by ketosis. You all know, and in neurodegenerative diseases, the energy dysregulation is being corrected by ketosis, so it may benefit Alzheimer's disease and Parkinson's disease. Well, friends, in oncology, as the cells are glucose dependent many times, so when ketone body is being used as a fuel, well, there could be, it could be used as potential metabolic adjunct in glioblastoma in certain solid tumors, and evidence remains, however, evidence remains preliminary. With all the better effects, there are safety concerns. Short-term keto flu, which is a temporary one, later it disappears, fatigue, headache, and constipation. In long-term, macronutrient deficiency could be there. Reduced fiber intake may lead to the problems. Nephrolithiasis may be the result, and LDL-C elevation may cause atherosclerosis. Well, friends, why should not follow keto? Who should not follow keto? So relative contraindications are there. So a patient with pregnancy, lactation, severe liver disease, pancreatitis, eating disorders, and frail elderly should not be advised keto diets. Imported drug interactions, SGLT2 inhibitors, if combined with keto diet, patient may suffer diabetic ketoacidosis, that is euglycemic diabetic ketosis, which is very harmful at times and may not be detected in time. And there is risk of, euglycemic diabetic ketosis remains there. Well, friends, pros and cons snapshot. Every diet has its strengths and challenges. So let us compare the pros and cons of keto versus low carb to help you decide which approaches might work best for you. Keto diet is fast fat loss and hunger control, boosts energy and mental clarity, helps stabilize blood sugar, but then it can be restrictive and requires macro tracking and commitment. Where low carb diet is more flexible and socially easy, easier to include fiber and whole grains, and still supports weight loss and heart health. But then weight loss may be slower and cravings for the diet may still occur if carbohydrate intake is too high. Well, friends, what is the practical clinical approach then? So low carb diet is best suited for obesity, pre-diabetes, type 2 diabetes, and MSALD. Ketogenic diet is best suited for selected motivated patients, intensive weight loss programs, drug-resistant epilepsy, as already said. In 1921, at Mayo Clinic, it was practiced especially in children, and it requires strict monitoring of all the metabolic parameters, renal parameters. Well, friends, nutritional density and long-term health. Both keto and low-carb diets can be highly nutritious when done right, but each requires thoughtful planning to avoid common pitfalls. Keto consideration may limit whole grain, fruit, and other high fiber food, can lead to low fiber intake or nutrient gaps if not balanced. May not suit people with kidney conditions, and of course requires careful fat choices to limit saturated fat and prioritize healthy fat like olive oil and avocado. Well, friends, low carb allow more variety in carbohydrate sources, but still requires limits for noticeable weight loss. Easier to maintain long term, but less likely to trigger ketosis or metabolic shifts. May lack structure, making it easier to slip back into old eating habits. No matter which diet you follow, build your meals around whole ingredients, lean proteins, healthy fats, and fiber-rich vegetables to meet your nutritional needs. Well, friends, clinical current guidelines, ADA and EASD, low carbohydrate diets are acceptable dietary patterns. Emphasis on personalization is there. No single dietary strategy is superior for all patients. take-home message, adherence is more important than dietary ideology. Well, friends, both keto and low-carb diets can support weight loss, but keto typically delivers faster results by shifting your body into ketosis, that is fat burning mode, while low-carb diets offer more flexibility and easier to maintain long-term. Keto restricts carb to under 50 grams daily to trigger ketosis, where your body burns fat for fuel instead of glucose, leading to rapid initial weight loss, reduced hunger, and stable blood sugar levels. Low-carb diets allow you to 50 to 150 grams of carbs per day without requiring ketosis, offering greater food variety, including whole grains, fruits, and legumes, making them more socially flexible and sustainable. Keto provides superior appetite control and satiety due to high fat and protein-rich foods, often leading to naturally reduced calorie intake without hunger, whereas low-carb results vary depending on food choices. Both diets require thoughtful planning for nutritional adequacy. Keto may limit fiber and certain nutrients from restricted food groups, while low-carb flexibility can make it easier to slip back into old habits without a structure. Your best choice depends on your goals and lifestyle. So choose keto for faster fat loss and structured eating, or low-carb for long-term sustainability and food variety. Both work when followed consistently. Friends, ketogenic diets are the most restrictive form of low carbohydrate diets. Both improves weight, glycemia, triglyceride, and insulin resistance, both the keto or low carb. Well, friends, cardiovascular benefits are promising, but outcome data remain limited. LDL-C and ApoB response requires monitoring. Patient selection and long-term adherence determine success. Well, friends, final take-home slides. Carbohydrate restriction is a powerful metabolic intervention, but not an universal solution. The future is the integration of precise nutrition, continuous glucose monitoring, metabolomics, cardiometabolic risk satisfaction will determine which patient derive the greater benefits. There are references for all what we have said today at the moment. So thank you very much for your presentation. And before you, common queries remains for the students. If time permits, we can go through. Thank you very much.
Thank you, Sinha sir. I think you believe keto diet is better than low carbohydrate diet.
No, it all depends upon the situation you are utilizing for, and what is your goal, what we said. Keto diet is enable, the person is not in a position to restrict to the keto diet usually. You require hard monitoring because keto diets may deprive you nutrients. So you need hard monitoring, renal and other metabolic parameters. So best is the low carb diet, but well, in a specific situation like refractory epilepsy, like the Alzheimer's disease and other diseases like carcinoma disease, as a specific therapy, you can utilize it. For weight loss, where both will work, but restricting to the diet is important, which is possible usually with the low carb, not with the keto diet. But it requires very strict policy.
One query I have, sir, the patient, those who are insulin dependent, they are very prone to passing into diabetic ketoacidosis. So this we prefer low carbohydrate diet or
already said in the slide, if you go with the ketogenic diets, he will slip into the euglycemic decay. So don't go with that diet in keto diets in decay. At the same time, keto diet is not preferred for type 1 diabetes. Earlier, in the beginning, it was the treatment. But now in the insulin era, we do not need keto diet to go for the type 1 diabetes.
Thank you, sir, for excellent presentation. Thank you.
So thank you very much again.
Thank you, Dr. P.K. Sinha, sir, for that insightful presentation.
We now move forward to our next presentation. It is my pleasure to invite Dr. Ranjan Kumar, sir, from Patna, who will be speaking on diabetes and echocardiography. Sir, please take the podium.
Is it the pointer? This one? No, next pointer. Pointer. To the respected seniors, teachers and dear friends, very good afternoon to all. First, I would like to express my sincere gratitude and a heartfelt thanks to the team RSSDI for inviting me to give a lecture here.
My topic, since morning we are dealing with the hardcore diabetes mellitus. So I will take you somewhat different dimension. That is the cardiology, towards the cardiology and more toward the echocardiography, which is little bit hardcore cardiography, and how the echocardiography is going to help you in the diabetes mellitus management patient. So my topic is echocardiography in the diabetes mellitus, a clinical guide, and I will be dealing to understand why echo matters in the diabetes, what are the echo finding difference between the DM and non-DM, what are the unique echo fingerprints of the diabetic cardiomyopathy, know when to refer diabetic patient for the echo, and then we able to read an echo report confidently, then what are the red flags and the action points according to them, and then at last the message to the clinician and the patients. So before going to the original topic, I would like to give you some few introduction to the simple introduction to the echocardiography, because what I am going to talk, there are certain terms, certain parameters, certain measurement. You should know before that. You should familiarize what I am going to talk, then it will be easier to understand the whole talk. So this is the 5 window into the heart, that is the 2D echocardiography, Doppler, color Doppler, tissue Doppler, and a speckle tracking known as the GLS or strain. So first is the 2D echocardiography. It is a simple, almost a probe placed on the chest, which sends sound waves, and then there is a monitor. This type of picture came out. It is used for, basically it uses for the chamber size, that is the LV, RV, and LARA. So this is the moving picture, and you can see that this is the 4th chamber, and then you can in this view you can measure the wall thickness of the septum and posterior. Then you can measure the ejection fraction, then the LV geometry, whether it is a dilated or thickened or eccentrically dilated, hypertrophied, and then the certain valve structures. Here you are seeing the mitral valve, and this is the tricuspid valve. So this is the 2D echocardiography. Next is the Doppler. In the Doppler, there are the 2 types of Doppler, that is the pulse wave Doppler and the continuous wave Doppler. Pulse wave Doppler is used for the specific point. If you want to know the velocity of the blood here, this is you need use the pulse wave Doppler. This is for the low velocity, and this is the continuous wave Doppler. Here along the whole line, the highest velocity will be picked up, and this is for the highest velocity. So this is for the stenosis or the regurgitation, and for the velocity. It's not working. Okay. And then here you can see in the Doppler the 2 wave is measured, that is E and A. Later on I will come to what is this. Now the next is the color Doppler. So color Doppler, it's a color. It is not like that red is arterial or blue is venous. It is the red. Red is towards the probe. Here is the probe. The blood moving towards the probe is seen as the red, and blood moving away from the probe, it is blue, known as blue. And when there is some sort of regurgitation, and there will be a mosaic type of patterns. Now, 2 new, which is more important, that is the tissue Doppler imaging. Here the tissue Doppler imaging, instead of blood velocity, we are measuring the myocardial tissue. अच्छा ये चेंज करेंगे क्या, ये आ नहीं रहा है? हेलो, इसमें कहाँ से? हाँ ये आ रहा है, हाँ ठीक है, ओके, इसको देखिए, हाँ पॉइंटर। So here instead of blood flow, we are measuring the myocardial tissue, and it will give a whole cardiac cycle. That is, if you are seeing the ECG, it is the R wave, and then from R wave to the T wave, it is the systolic, and from T wave to the next R wave, it is the diastolic. So in this, this is the systolic wave known as S1, and the two diastolic wave that is known as E prime and A prime. So this is the tissue value, and it is now the diastolic dysfunction is solely based on this tissue Doppler study. Now the more advanced now is the speckle tracking and strain. This is the most sensitive technique because it detects hidden dysfunction 2 to 5 years before EF drops below the normal range. And what it's measure? It's measure the change of length in the heart valve. Whenever a ultrasound wave hits to the valve, they produce a speckle, and that speckle, this much software calculate the deformation, how much that speckle contract and how much it is relaxing, and that gives the strain. And here, as you know, the LV is make of 3 fiber. That is, one is the longitudinal, one is circumferential, and one is the radial. So here, global longitudinal strain, this is the now the expected longitudinal strain. It was measured by this software, and as the wall is shortening, so the report is in the minus. More the negative, stronger is the muscle, and this is normally more less than 20% is the excellent. Between minus 18 to 20% is the normal, and as go it is less negative than 16%, then the systolic dysfunction is setting. So this is the spectral tracking, and that is, these are the few terms I am going to use in the next slide. And now coming to the basic topic, that is the echocardiography in the diabetes. So you can see the magnitude of the problem. According to the latest data of the IDF, 589 million people worldwide living with the diabetes. That accounts from the 11.1% of the global adult population, and it is projected to reach 153 million by the 2050. And the scary part is that the diabetic patient have 2 to 5 times more of higher risk of heart failure in the diabetes, and the 75% of asymptomatic diabetic have some echo abnormality at any points, and the 50% of heart failure with preserved ejection fraction patient have diabetes or pre-diabetes. So the data is very much scary. Now, what is the echo gap? Why we are missing cardiac disease in diabetes? Because symptoms appear late. Cardiac dysfunction in diabetes is asymptomatic for years. By the time patient develops symptoms, already it is late. They came to the grade 2 or grade 3 dysfunction according to the echo. Conventional investigation like ECG or biomarker, they are often normal, and BNP may be borderline. So to detect subclinical myocardial dysfunction or diastolic dysfunction, only echo is the sufficient. Now, many reports say that this patient is having normal EF, but normal EF is not reassuring, because I already said that the normal EF, almost 20 to 30% fiber to be lost to EF to be below normal. So a normal EF doesn't guarantee that the heart is okay. GLS reduction and grade 1 diastolic dysfunction are routinely missed without dedicated assessment. And the problem is that unlike diabetic retinopathy or nephropathy, cardiac echo screening is not yet universally protocolized. Many patients go a year without cardiac imaging. So this is the biggest magnitude of the problem. Now, what are the major cardiac conditions in the diabetes? First is the coronary artery disease, which is 2 to 4 times more common than in the non-diabetic. Almost many of times it is diffuse, multivessel, and a smaller vessel size, more calcified coronary vessels. So CABG preferred over the PCI. Up to the 40% patient diabetic have a silent MI, pain dulled by the cardiac autonomic neuropathy. Many may present only fatigue, dyspnea or vomiting, so there is a delayed treatment, so there is the worse outcome. Diabetic cardiomyopathy, which I am going to next, because this is the special cardiomyopathy for the diabetic patient. It is independent of coronary artery disease or hypertension. There is a diastolic dysfunction, then progress to the systolic function, systolic failure, fibrosis, lipotoxicity, myocardial dysfunction, and this type of diabetic cardiomyopathy often diagnosed as a heart failure with preserved ejection fraction. Then the heart failure, already discussed, 2 to 4 times higher risk of heart failure. Cardiac autonomic neuropathy, already discussed earlier, I am not going, and arrhythmia and sudden death. There is a 40% higher risk of atrial fibrillation and prolonged QT interval. There is a risk of malignant arrhythmia. Sudden cardiac death is also a leading cause of the mortality. Now, what are the clinical advantage of echocardiography in diabetes? One may ask, why echo? My patient has no symptoms. So, it detects subclinical disease. Echo identifies diastolic dysfunction and reduce GLS, global longitudinal function, year before symptoms. So, intervention window is now, not when the symptoms start. It is a non-invasive and repeatable. No radiation, no contrast, no needles, can be repeated every 1 to 2 years safely. It's a comprehensive single study. In 1 30-minute scan, you will get all the information about the LV structure, systolic function, diastolic grading, pressure volume, LA volume, valves, right hearts, all the condition of there. Then it guides treatment decision. If patient is having a grade 2, grade 3 diastolic dysfunction, then you have to start the specific therapy, SGLT2 inhibitor, AC inhibitor, ARB or ARNI. And if the reduced ejection fraction, then beta blocker is a mandatory until it is contraindicated. Then another important point is it is a tracked drug response. You have given the treatment, you want to have a objective evidence, then you have to do a serial echo documents, and you will find the reverse remodeling with the SGLT2 inhibitor, reduction in the LV mass, other echo finding. And one important point is the pre-procedure risk assessment, essential before major surgery or chemotherapy in the diabetic. It identifies high-risk patient who needs optimization or cardiology consultation before proceeding. So, echo is the only test that simultaneously answer, is the heart enlarged, is it stiff, is it weak, is pressure building up, all in one visit, 30 minutes. Now, if you compare the other common cardiac tests in the diabetes, why echo scores over? ECG, you can detect LV hypertrophy, bundle branch block, ischemic changes, arrhythmia, but you cannot detect the subclinical LV dysfunction, diastolic dysfunction grade, LA enlargement, filling pressure, GLS reduction. Same with the chest X-ray, you can detect the cardiomegaly, pulmonary edema, pleural effusion, pericardial effusion. And the BNP and NT-proBNP that say that it is patient is an overt heart failure, but it doesn't say that what is the cause of dysfunction, what is the grade of systolic and grading of the diastolic dysfunction. So echocardiography say all structure abnormality, EF, diastolic grading, filling pressure, volume, geometry. What it does not say that cardiac anatomy, for that you need a coronary angiography, perfusion, for that you need a nuclear or MRI study, or fibrosis, for you need a MRI. Now, what are the structural changes on echocardiography in the diabetes? One important change is the LV hypertrophy, and you may find in the echocardiography report sometimes it is a concentric remodeling, most common in the diabetes. What is concentric remodeling? Heart wall is thickening, but still the size of LV is small. So this is known as the concentric remodeling. This is the starting point of the LV hypertrophy. Even in a normotensive diabetic patient shows subtle hypertrophy. Then there is a left atrial enlargement. Its value is the more than 34 ml per meter square. Here the LV mass index, that show the LV hypertrophy. All the parameter, all the measurement is indexed to the body surface area. क्या खत्म हो गया? नहीं, अभी तो खत्म हो गया पूरा बहुत. So One important thing that the major emphasis on the epicardial adipose tissue, that is the if a pericardial fat, if it is more than 7 mm in the parasternal view, it secretes pro-inflammatory adipocene directly into the heart and directly linked to the diastolic dysfunction. And this then there is a aortic and valvular changes. There is a more aortic sclerosis and calcifications. So diabetic cardiomyopathy, it is a distinct myocardial disease in the diabetes, independent of CAD, hypertension or valvular disease. And according to the echo, there is a clinical staging on the echo. That is the stage 1, that is asymptomatic stage, where according to the echo, it is only the diastolic grade 1. In the grade 2, the stage 2, and grade 3 is the reversible phase, and grade 2 is the effort dyspnea. Now I am submitting, this is important, when to refer for the echo. So urgent referral, any diabetic patient with new breathlessness, immediately rule out heart failure with physical extraction or heart failure with reduced extraction. Diabetes with ankle edema, bilateral feeding, diabetes with orthopnea or PND, diabetes with syncope or pinsugar, you have to urgent referral for the echo. Semi-urgent within 4 weeks, diabetes with elevated BNP or anti-proBNP or poorly controlled hypertension or worsening exercise tolerance or pre-operative, that is a measure of a surgery, then the semi-urgent. Then elective, new diagnosis at any age, diabetes mellitus more than 10 years, no prior echo, diabetes with a CKD stage 3 or diabetes with the obesity, BMI more than 35 and dyslipidemia, and the routine surveillance, known diabetes, normal prior echo, repeat every 3 to 5 years if asymptomatic. Diabetes on SGLT2 or GLP agonist, echo at 6 to 12 months to document response, and grade 1 and type 2 diabetes, type 1 more than. Okay. So if a report say that patient EF is normal and no significant valvular disease, is an incomplete report. You have to look for the red flag in the echo report. If ejection fraction is less than 30%, then the action is the same day cardiology consultation, start beta blocker, AC inhibitor, MRA, or consider ICD assessment. Grade 3, again urgent cardiology consultation. So these are the parameters, that is the EF is less than 35%, grade 3 is diastolic dysfunction, left atrial volume index is more than 50 ml, pulmonary artery pressure is more than 50, new regional valve abnormality, GLS less than, more less than minus 12, pericardial effusion. These are the conditions where you have to send for the echo urgently and follow. These are the new drug and echo and what are the effect on the echo.
So concluding, sir, please.
Yes, the SGLT2 inhibitor, GLP receptor agonist and combination therapy, there is a objective evidence, that is that they reduce the LV mass index, they reduce the left atrial volume, they reduce the diastolic grade, they improve the GLS improvement. So minimum echo parameter, you have to look for the LVEF, that is the pump function, overall pumping extent of the left ventricle. Then reduced E prime, that is indication of the E impaired relaxation, heart wall is not relaxing properly between beats. Left atrial volume index is more than 34 ml, that means the chronic diastolic burden, that is left atrium stress from the long standing stiffness. GLS, it will show the subclinical dysfunction. Important point is E by E ratio more than 14. It indicates elevated filling pressure, that is blood backing up due to the stiff ventricles. And the TR velocity, if more than 2.8, that means the pressure has been transferred to the lung from the heart. So at the last, the clinical message, diabetes is a cardiac disease. The heart is damaged before symptoms appear. Echo is the only way to see this early. Normal EF is not equal to the normal heart. GLS and diastolic grading are mandatory in every diabetic echo. Without them, the report is incomplete. Diastolic dysfunction grade 2 is the greater imposter. Always use TDI and left ventricular, left atrium volume index, TR velocity, other parameters. Then come to the here. Important thing, the last 8 point, that is serial echo monitoring is one of the most underutilized tool in the diabetes management. It provides objective documentation of cardiac improvement over time. It motivates medication adherence and justify continuation of the drugs. And it also detects early deterioration before clinical decompensation. So at the last, I would like to end by a bold statement, that is diabetes is a cardiac disease that happens to also affect blood sugar. Comprehensive cardiac screening should take priority over HbA1c monitoring in isolation. Thank you.
Thank you, sir. Such a nice presentation. It will be a matter of time, in your words, any diabetic patient with any sort of time must go for echocardiography. Thank you, sir.
Thank you, sir, for sharing your valuable insights.
Our next speaker is Dr. Sajjad Ehsan sir, who will address an important and evolving area of diabetology. The topic is genetic screening in gestational diabetes mellitus. May I request Dr. Sajjad Ehsan sir to kindly begin his presentation.
Thank you. Thank you to with due permissions from the honorable chairpersons. And I thanks and I give my sincere gratitude in regards to all the dignitaries of RSSDI who gave me this wonderful opportunity to talk on this futuristic topic. I especially thank to Dr. Supriya Mukherjee sir, that really in every meeting we are talking about this, whether we have to do selective screening of gestational diabetes or whether we have to do universal screening. Of course, if you will see the data, if you will do the selective screening, the prevalence of GDM in India is 1.4%, but when we apply universal screening, then it goes up to 2.7%. So of course, there is a big difference. And if you see that, and if you try to find out in a country like India, that gestational diabetes has a huge impact on the futuristic, not only the maternal aspects, rather than the fetus and then the future course of the fetus when it grows up and it develops into the adolescence. There are multiple metabolic changes and adaptations from the placenta which carries on to in the adulthood also. So in this session we are trying to learn a little bit about the gestational pathophysiology. Already we know very well, but my main focus is to find out the genetic susceptibility in the GDM, and there are certain genes. We are not talking, we are really, even I was not aware of these genes, but when I dived into the literature, there are certain very important genes which are implicated in the GDM, and if you try to find out those genes, there are laboratories available in India. There are certain very good laboratories like MedGenome which detect these screening technologies for these genes. So we will evaluate this genetic screening for the future application for the betterment of the gestational diabetes management. So what is GDM? Of course, everybody knows that any degree of glucose intolerance which is first detected in the pregnancy or any hyperglycemia due to the pregnancy, of course, it also includes the previous diabetes which has been carried on to the pregnancy, and officially the guidelines we preferably screen in 24 to 28 weeks, but when we apply universal screening, the preferable method, we have a very good paper by Seshaya et al. In 2014 which after that paper, Ministry of Family Welfare said in a very emphatic statement that we have to do a first-time maternal screening for this GTM with 75 gram of oral glucose tolerance. Of course, GDM is transient, but it has a huge impact and significant condition. And if you see the global burden, of course it is rising, but I'm a little bit talking about Indian prevalence. It is just from 7 to 21% in the different states of the India, but it is rising in the epidemic proportion. Why? Because socialization, the obesity, several lectures have been discussed about the obesity, and the sir has taught that diabetes is a cardiac condition. So many huge impact, if you will see that with this GDM is a very huge impact on the fetus cardiac conditions also. And of course it utilizes healthcare cost also, substantial impact on the economic burden and healthcare systems also. So epidemiology, I have discussed, it is almost 5 to 25% in the different regions of the India, but there are certain very important things that before going for genetic screening, we have to be very selective for to identify those high risk of women who are at risk of this GDM, because we cannot apply genetic screening is very costly. We cannot apply to each and every female, but of course with those with strong family history of diabetes, previous GDM, PCOS patients, and maternal obesity, advanced maternal age above 35 years of age. So all these patients are at risk of GDM and subsequent risk of preeclampsia, cesarean delivery, increased fetal complication, that is macrosomia and shoulder dystocia, neonatal hypoglycemia, and future other several metabolic risks also. So how it happens? This is a very simple slides that renal threshold for fetus is less than 110, but when maternal blood glucose rises to 110 milligram per deciliter, fetal causes glucosuria, and that causes polyhydramnios. And when after 20 weeks, if you see that when fetus begins to swallow this amniotic fluid, this glucose in the fetus in the gut of the fetus, it stimulates the insulin production, and this causes this macrosomia and the other defects in the fetus, and that is also implicable in the future risk of obesity and type 2 diabetes in that fetus. So hyperinsulinemia in fetus induces many changes, starting from altered gene expressions, apoptosis, and all this happens at the level of placenta, and the various defects we know that facial femoral hypoplasia and caudal dysplasia. So why it is so important to discuss GDM? Because if untreated, it can immediately lead to maternal complication during pregnancy and of course postpartum also, but subsequent generations are always at risk for development of diabetes and other metabolic complications. So this is a simple pathophysiology. We know that pregnancy hormones, that is human placental lactogen, progesterone, cortisol, and prolactin, that causes insulin resistance, beta cell dysfunctions, and maternal glycemia, which is contributory to this gestational diabetes mellitus. And why genetics matter? This is the core of my topic, because GDM, if you look into the lineage of the GDM, it has a strong familial and hereditary patterns. Many genes linked to the GDM. I will discuss genetic factors which influence the insulin secretion, insulin sensitivity, and the various metabolism. And apart from that, if you look for the obesity and the environmental factor and the lifestyle, which is also contributory, which comes in under the epigenetics, which induces changes in the DNA like methylation. And altogether, pregnancy hormones are one important factor. Altogether, they increases the risk of the GDM. So concept of genetic screening came into the scenario right now for these higher risk women, which of course we can do screening by the routine glucose testing, but it is too late sometimes. So screening by these methods like single nucleotide polymorphism, different gene panels, and polygenic risk scores. So to early intervene and personalize monitoring and preventive healthcare strategies. These are the certain futuristic targets by which we have this concept of genetic screening by which predicts the future risk. And because if you see the most of the time, screening is done in the second trimester, 24 to 28 weeks, and early GDM has a great impact on, like for very good papers from Dr. Gupta from AIMS, which has produced a very good paper that small for gestational age babies is just that we miss this earlier gestational diabetes. So genetic screening that is why very important. So what are the types of genetic variations which contribute to this insulin resistance and glucose metabolism? So first is single nucleotide polymorphism. which small changes in single DNA base which affects this gene function, and it has an important role in insulin secretion, insulin signaling, and glucose metabolism. Other one is copy number variations. Like this happens by two ways. One is the DNA duplication and one is DNA deletion. So we get an extra copy of that DNA segment, and in another part we lose one DNA segment. So it has also a role in the GADM because it affects the beta cell functions and energy homeostasis. And there are last part that is also affected with this environmental factors, that is epigenetic modifications, certain chemical modifications in the DNA which activates or sometimes silence the existing genes which is enrolled in the glucose metabolism and the inflammations. So altogether this has a collective impact on the GDM susceptibility, all these genetic methods. So what are those genes? This is now the question in everyone's mind. So in nutshell, there are these genes like TCFSN-L2. Of course, the nomenclature is somehow difficult. We will learn this nomenclature. MTNR1B, melatonin signaling, which is associated with elevated fasting glucose. KCNJ11, we know this gene very well with the function of the beta cells and the sulfonylureas also. GCK is very important because this is with MODY2, which is a milder form of the young onset modified young onset diabetes, IRS1, CDCAL1. So all these gene network like TCFSN-L2, KCNJ1, IRS1, this all has in nutshell, if you try to know that they affect the insulin secretion and the beta cell function. I will come one by one for these genes. So first this gene, TCF7L2 gene and the GDM, how it is related. So it affects this WN2-NT signaling pathway which regulates pancreatic beta cell function. So those women who carry this risk allele may have a higher likelihood of developing the GDMs during the pregnancy. And this is a very important gene, and if you assess this gene, this is a very important genetic target for genetic risk prediction for these women. MTNR1B gene and the GDM, this is a melatonin receptor gene which is also involved in this diurnal pattern of melatonin signaling, but it is also affected this glucose metabolism and particularly this fasting plasma glucose. And the common polymorphism, this is AR7, this number, of course these numbers are complicated, but these are strongly linked, and most of those who are involved in the research, they are working on this. And this has a very strong association, and this variant MTNR1B is for early metabolic dysfunctions in the female of those who are prone for this gestational diabetes. So these two genes are also very important because this GCK, glucokinase, we assess for this MODY also, this glucokinase activity associated with glucose sensing and insulin secretion. So this is also associated with this glucose 6-phosphate pathways, and if they have a modification and alteration in this gene, this affects this glucose metabolism and future risk for GDM apart from this milder form of the diabetes MODY2. KCNJ1 gene, this is also important with beta cell membrane activity, potassium channel regulation, and the variants of these genes also alter the insulin secretion and future diabetes. The last part, which is associated with the environmental and metabolic factors like nutrition, obesity, several types of the stress, certain viral infections, and excessive hyperglycemia itself also. So that goes with this DNA methylation and histone modifications, these chemical tags added to the histone protein, and this created this microRNA regulate gene expression, and this altered gene expression that causes this insulin resistance and this GDM. So epigenetic changes affects insulin signaling and the glucose metabolism at the level of the placenta and influence this fetal programming and the future course of the obesity and type 2 diabetes of the offsprings. So all these interactions of these particular genes which I have talked, that affects this genetic susceptibility, insulin resistance, at the level of the placenta. Placenta is a very important organ for nutrient transport and hormonal regulation of the fetus, and placental gene variations with this fetal genetics affects the growth regulation of the fetus and the certain metabolic adaptation with these genetic variations, and that is the way and the basis of long-term metabolic consequences. So how we can do, because this we don't do in a clinical practice, so simply they do by these labs who are involved in these genomic techniques. They take you blood samples, sometimes they take sample from the buccal mucosa also. They extract the DNA by certain methods. I'm not into the detail, I'm not in the biochemistry, but by PCR, DNA microarrays and these techniques, they identify these risk variants and they assess for this GDM risk assessment. So certain large population sample, they also do genome-wide association studies, which is very much important to identify novel risk gene, important for understanding the different sets of the disease mechanism in the larger population also. But we have limitation, we have limited resources and expensive, and data are not sometimes with population variability, we cannot get this data, limited clinical application with this genome-wide. So that is why this is not quite in practice, but certain things like polygenic risk scores, they also affect the multiple genetic variants to estimate the individual genetic susceptibility also. They have a very good important clinical potential for early risk stratification, personalized monitoring. You have to strategize this preventive lifestyle and improve this antenatal management, but certain, once again, there are limitations with ethnic variability in the genetic data. We need larger population studies and lack of standardized values. These are the certain limitations currently. So early prediction of GDM in nutshell, if you identify before preconception, in either before first trimester, you do a genetic risk assessment along with clinical risk factors. This is very important to combine these two things and biochemical risk factors. Then you can apply early intervention strategies like lifestyle modifications, dietary interventions, weight management strategies, and CGM. We have a good talk on the CGM. So these things collectively can reduce the GDM complications, like very important complications like macrosomia, preeclampsia is very important. So earlier detection is always a better prevention, and that is why we are having this precision medicine. We are talking about this genetic screening in the GDM to improve this clinical applications of these markers. But beware of this very important current status of this genetic screening. This is not recommended for routine clinical practice. Research is ongoing. We need more evidences. Even WHO focus on clinical risk assessment, and they are not recommending this clinic. So, but for certain cases at a very super specialty level, you may need these genetic risk score for certain very important high risk patients. Routine genetic screening is yet not recommended. We still have to do with this either universal or selective screening for this future prospect and future betterment of this our GDM patients. Thank you everyone for patient hearing. Thank you so much.
Thank you, Dr. Sajad, for such a nice discussion and to help to diagnose the case of GDM on molecular basis or nuclear basis, DNA basis. But thing is, as you say, it is not possible anywhere, everywhere, and be still on basic clinical diagnostic tests. Thank you.
Thank you, sir.
Thank you, sir, for the enlightening discussion on the role of genetic screening in gestational diabetes mellitus.
We now invite our fourth speaker, Dr. Dharmen Singh, sir, who will be speaking on telemedicine in rural diabetes care. Sir, please come to the podium.
Good afternoon, everyone. First of all, I would like to thank Team RSSDI for giving me this opportunity to speak in front of you. The topic for today's discussion is telemedicine in rural diabetes care. So as we are already getting late, so let's dive into the topic. So definition of telemedicine by WHO: delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technology for exchange of valid information for diagnosis, treatment, and prevention of diseases and injuries, research and evaluation, and for the continuing education of healthcare providers
all in the interest of advancing the health of individuals and their communities. Coming to the origin of telemedicine, the origin of telemedicine dates back to the post-World War era, when the countries were facing poverty and lack of infrastructure. Then in that period, they come up with a program, radio broadcast program called the Radio Doctor, where the doctor sitting in the radio station used to advise the patient on the prevention and the management of the diseases. Coming to the concept of telemedicine in India, the concept of telemedicine in India is also very old. It dates back to year 1975, when the telecardiology system was started in the GR Medical College, Gwalior, where a ECG machine was mounted on a van, where it used to carry out the ECG of the patient in the van itself, and the ECG was transmitted to the lab via the telephonic cables, where it was analyzed by the cardiologist and was helping those vans and the patient for the trials whether they need admission in the cardiology department or not, or they can be managed in the van itself. So coming to the evolution of telemedicine, it all started in the year 2001, when the first telemedicine pilot project was launched by ISRO, connecting Apollo Specialty Hospital in Chennai with Apollo Rural Hospital in Araganda village in Chittor district of Andhra Pradesh. In 2004, there was further extension of telemedicine to Andaman and Nicobar Islands for post-tsunami disaster support, along with extension to the northeastern regions. In between 2005 and 2015, there was massive upscaling to connect 350 rural hospitals with the 50 urban super specialty hospitals, along with the launch of 50 mobile televans. During 2020 COVID pandemic, there was acute precipitation of the acute adoption of telemedicine and official launch of eSanjeevani by the government of India and upscaling of telemedicine. eSanjeevani is the world's largest government-led national telemedicine platform, which has been integrated with Ayushman Bharat health account for universal health coverage. Key modalities of telemedicine. There are 3 modalities. One is synchronous, where real-time audio-video interaction connecting rural health posts and top-tier endocrinologists for live consultation and triage. Asynchronous, that is stow and forward method, where lab reports, clinical data and images are recorded locally and analyzed by the specialist later. Remote monitoring, continuous transmission of the physiological data from the patient to the cloud portals. Modalities suited for rural India, assisted provider model, where the rural health workers like ASA ANM utilize the standard tablets inside the sub-center to capture clinical data, acting as a facilitator in between the patient and the consultants. Hybrid store and forward method. Reports are safely stored locally inside the offline databases and uploaded to the tertiary hospitals for analysis and management later. Automatic synchronization, clinical files automatically sync to the urban hospitals. What is the need for telemedicine for rural diabetes care? As we all know that there is a rural-urban disparity. Over 70% of the Indian population resides in the rural locality, yet less than 20% of the specialized clinic operate there. The diabetic burden of all the total diabetic patients, 65% of the diabetic patient resides in the rural areas where is dearth of diabetic care clinics and teams. So there's critical shortage of diabetic care team, and also there's financial burden. Travel costs to reach urban hospital compounded by the daily visit losses of the patient. Role of telemedicine for diabetes care. So continuous monitoring enables frequent tracking of blood glucose without requiring long and expensive commute to urban diagnostic centers. Titration and adjustment provides a direct channel for timely insulin dose adjustment and oral hypoglycemic agent change based on the data. Self-care education enables virtual teaching groups regarding hypoglycemic event identification, insulin administration, critical diabetic food care protocols, counseling for lifestyle modification, diabetic diet, and regular exercises. Impact of telemedicine on targeted glycemic outcomes, HbA1 reduction. There's a large-scale studies shows that clinical telediabetology program in rural cohort demonstrate massive long-term improvement in HbA1c. That is, there is a reduction of 1.36% of HbA1c. Clinical significance. A sustained reduction of HbA1c reduces the relative risk of macrovascular complication by over 35%. which mitigates the progression of neuropathy, nephropathy, and diabetic retinopathy along with the coronary artery disease in these patient groups. Impact on diabetic parameters, HbA1c level, significant baseline reduction from an average of 9.25% down to 7.89 following 6 months of rural telemedicine intervention. Fasting glucose, baseline average drop from 178 down to 122, that is an improvement of 56 milligram per deciliter. Postprandial glucose shift from high baseline of 245 to 168, that is an improvement of 77 milligram per deciliter, which impacts the control outcomes. Empirical data illustrates excellent control outcomes matching the or exceeding the standard face-to-face health consultancy. Impact on non-glycemic parameters. With teleconsultation, it was seen that the BP dropped by 11 millimeters of mercury, whereas there was a drop in the weight by 1.33 kgs and body mass index of 0.43. Preventing complication, diabetic retinopathy screening, integration of smartphone-based digital fundus cameras at rural health hubs allows image to be transmitted directly to the specialist. Diabetic foot and nephropathy, ASHA workers can be easily trained to perform simple monofilament tests under real-time specialist oversight via video consultation. Cardiovascular and renal monitoring, regular virtual tracking of the blood pressure and the urine albumin creatinine ratio ensures prompt therapy adjustment to shield organs. Supporting dietary choices, culturally tailored nutrition, telemedicine allows remote dietitian to curate region-based specific dietary modification. Local ingredients, leveraging the traditional millets and grains and indigenous local vegetables to be included in the dietary modification. Sustainable modification achieves long-term patient compliance and dietary discipline within the native rural diabetic cohorts. Impact on prescription. Digital prescription teleconsultation automatically generates legal QR-coded electronic prescriptions sent directly to the patient, mitigating the patient inertia for new prescription. Adherence boost. Completely prevents medication non-adherence due to long distance retail deficit and mitigates the critical out-of-stock scenarios. Automated restocking of the medicines. Coming to the hurdles in implementing telemedicine in the rural areas. So there's a digital divide between the urban and the rural area. Telecommunication disparity. Urban centers are benefited by high-speed optical fiber broadbands and robust 5G networks, while the rural area depends upon the intermittent 3G, 4G connectivity. Device ecosystem. Urban centers focus on CGM and smart standalone apps, whereas rural models leverages shared community tablets. Operational models, software self-operated by the patient itself, whereas assisted consultation led by the primary health workers. Rapid rise of rural internet and expanding digital footprint. Active internet users in rural India has officially outpaced the urban market, reaching over 548 million active rural internet users in comparison to 410 urban users. Data tariff, driven primarily by the high affordable cellular data, world's cheapest data is there in India, and rapid smartphone penetration across the remote areas. Foundation for chronic care. This unprecedented digital growth provides the ideal framework for transition from traditional management to program to the remote healthcare programs. Rural India catching up. BharatNet broadband program, ongoing government deployment of high capacity optical fiber connectivity to over 250,000 gram panchayats. High value, low weight Indian health apps, development of low bandwidth multilingual telemedicine portals and apps that operate seamlessly under the minimal condition. Public-private initiatives. Clinical fallouts of telemedicine. What is the hindrance of the telemedicine, or rather what is the disadvantage? So missing physical touch, device inaccuracies, interrupted calls and transmissions. Challenges in implementing telemedicine. Physical examination is not possible, rely on the patient or primary healthcare worker. Infrastructure, identification of the suitable site, synchronization of the various departments, civil, electrical, medical, telecommunication. Identification of the nodal officer is a challenge. Sensitization of all the staff in the hospital and is also a challenge. Coordination, and there's a smooth and problem with the broadband and the smooth connectivity in these centers. Mitigating telemedicine risks. hybrid intervention programs mandating one comprehensive physical examination and diagnostic checkups every 6 months, standardized device calibration, encrypted offline protocols, prevention of complication, annual screening of lipid profile, serum creatinine and eGFR, liver function test, CBC, eye evaluation and ECG should be done annually, quarterly for HbA1c. Scaling assisted telediabetology, assisted care domination. National data shows assisted care via local health and wellness centers vastly outperforms standalone patient apps. Digital literacy resolution, immediate resolution of digital literacy barriers by using various trade operators to navigate the healthcare portals, optimized resource routing, crucial role of ASA workers in telemedicine, human link to technology. ASA and A&M workers represent the vital human core of rural health telemedicine. Community integration by conducting door-to-door diabetic screening, assisting with translation during teleconsultation. Adherence enforcement, act as a trusted local figure in enforcing compliance and prescribed clinical treatments as well as the follow-ups. Future of rural care, AI-driven automatic screening, unified Ayushman Bharat Health Account digital ID linkage, drone-based medication delivery system. So what AD has to say on telemedicine? Telemedicine is a growing field that can increase access to care for patients with diabetes. In type 2 diabetes patient, compared with usual care or in addition to usual care, various telemedicine modalities can be effective in reducing HbA1c. Way forward, integration of telemedicine activities with health management information system for regular reporting, including telemedicine activities in performance appraisal for individuals and institutions. Introduction telemedicine as a part of medical curriculum and CMEs. Take-home message, telemedicine is a powerful tool for health information and exchange between patient and healthcare system. Telehealth facilities partnership with patient for promotion of positive health lifestyle changes, personalization of self-care measures, personalized health intervention in management of diabetes. Telemedicine, one step for IT, a giant leap for healthcare. Thank you.
Thank you, Dr. Dharmendra. Really, you have discussed a topic which is emerging, basic in our country or practicing the place where we are is the rural area. What you will do on telemedicine is everything is data-based. What information you get, you analyze and you answer the same questions. So in such a patient, you must need a net connection, app, mobile, or whatever person who put data. But our patient is like that कि जब तक डॉक्टर साहब को देख न लें, बात न कर लें, बात बनती नहीं है. तो I think we are going towards, no, topic is really interesting. We wait for coming 5 to 10 years and everything which is to all our patients.
Even buying a yoga mat from Amazon is also telemedicine.
Yeah, a good thing. Now session is open for question and answering. Or any discussion and any suggestion of our audience. Dr. Amit, I think you have some questions.
I must admit that with changing times, we need to be, we have changed over so many years. From finger pricks to CGMs, we have changed. We have accepted things. Science is the other name for change. So change is the only constant in life. So I think telemedicine is here to stay, and we must admit that during the COVID times, we all might have practiced telemedicine, telehealth. So if telemedicine can be practiced during difficult times, it should be promoted during easy times as well. So I think telemedicine is here to stay.
Yes, right,
Thank
absolutely.
लोग कहते हैं कि छोकर काम चलेगा, हाँ, तो बात बनती है, लेकिन बात तो आप फोन पे करते ही ना, आप उनसे लगातार बातचीत करते हैं.
Robotic surgery is also there.
Robotics, मतलब कंसल्टेशन की बात करेंगे तो you keep on talking with the patient while doing ticket.
नहीं
क्या?
तो बात वीडियो कॉल पे भी होती है ना, हाँ, और ऐसे जो फोन पे दोनों में अंतर है.
नहीं बिल्कुल, सबके अपने एडवांटेजेस हैं, डिसएडवांटेजेस हैं। सपोज डॉक्टर सुजीत जो है वो बिहार शरीफ में है और मुजफ्फरपुर का एक बहुत करीब सा इंसान सुजीत बॉस के एक्सपर्ट से रूबरू होना चाहता है और इतना रुपया वो खर्च करके बिहार शरीफ नहीं जा सकता है, तो उसके लिए टेलीमेडिसिन तो एक बहुत ही साधारण और शानदार उपाय है। जैसे किसी पेशेंट का सपोज की एल्बो की सर्जरी करानी है और दिल्ली के किसी डॉक्टर से उसे करानी है, तो वो अपने एक्सरे एमआरआईज को प्लेट को अपलोड करके कम से कम ये डिसीजन तो ले सकता है ना कि किस तरह की सर्जरी हो सकती है। तो टेलीमेडिसिन इज हियर टू स्टे एंड वी नीड टू एक्सेप्ट दिस। तो ये आज न कल इसको आपको और हमको सबको यूज करना पड़ेगा। थैंक यू।
उन्होंने मेरे चैम्बर में एक सॉफ्टवेयर लगा दे रखा है, वो आते रहता है ईसीजी और विद इन 10 मिनट आई हैव टू रिपोर्ट। ऐप नहीं है ये, बिहार गवर्नमेंट का ये है। ट्राइकॉग ये सब लोग करते ही हैं, लेकिन बिहार गवर्नमेंट ने पीएससी, बहुत सारे पीएससी में ईसीजी मशीन और सॉफ्टवेयर लगाया है। मेरा ब्रिज हेल्थ केयर करके है, तो वो लोग क्या करता है कि वहाँ से पीएससी से भाया सॉफ्टवेयर, मेरे सिस्टम लगा हुआ है, सॉफ्टवेयर लगा हुआ, वहाँ ईसीजी आ जाता है। विद इन 10 मिनट्स आई हैव टू गिव द रिपोर्ट। तो बेसिकली दिस प्रोग्राम इज एसटीएमआई प्रोग्राम, एसटीएमआई के लिए तो महीने में 3-4 एसटीएमआई तो मिल ही जाते हैं, और बाकी सारे तो पीएसवीटी या एयरटेल फिब्रिलेशन तो बहुत मिल जाते हैं, तो बहुत हेल्प हो जाता है ना वो इमीडिएट टाइप्स के लिए। हाँ
चंडीगढ़ में भी हम थे तो वहाँ भी इस तरह पर बात हुई ईसीजी वाले। धर्मेंद्र को तैयारी करके आने दो।
Thank you, sir, for your informative presentation.
Thank you everyone for being a part of this enriching scientific session. We would like to request all the volunteers to escort the chairpersons and speakers to felicitation area, and the next session will begin in few minutes.
मैडम शुरू कीजिए ना। क्या यहाँ पर सबने इसीलिए भेजा था कि समय बचे।
चाय मंगाते हैं।
Good evening, everyone. I hope you have had an enriching day of academic learning so far. Diabetes is no longer just a disease of sugar. It's a disease of systems, science, and strategy.
And today's session brings all three together. And so now we welcome you to session 6, clinical and research updates, where evidence meets practice and research translates into better patient care.
Over the next hour, we will journey through childhood diabetes, perioperative glycemic management, diabetic emergencies, and cardiovascular challenges in diabetes. To guide the session further, I would like to request our esteemed chairperson, Dr. Om Prakash sir and Dr. Chandan Kumar sir, to please take their seats on the dais. I would like to take permission of Chairperson Sir to begin this session.
Yeah. So, let's straight dive into our first presentation.
When diabetes enters childhood, it affects not just the glucose levels, but families, schools, and future.
To guide us through the nuances of diagnosis and management in young patients, we invite our first speaker, Dr. Ved Prakash Sir, for his talk on childhood diabetes approach and protocols.
So at the outset, I would like to thank the team RSSDI for giving this opportunity to me. It's a very important topic, childhood diabetes. Childhood diabetes is basically a heterogeneous disorder in which clinical presentation and disease progression may vary considerably. Slide नहीं आ रहा था उसमें. So childhood diabetes is basically a heterogeneous disorder comprising of various types of diabetes. As we previously thought that every childhood diabetes is a type 1 diabetes, but this is not the fact. In fact, nowadays various types of diabetes present during childhood. It is very true that type 1 diabetes is still the commonest cause of childhood diabetes, but there is gradually rapid increase in the number of childhood type 2 diabetes, and besides childhood type 2 diabetes, there are other forms of diabetes like MODY, LADA, malnutrition modified diabetes, and various pancreatic diabetes is also common in childhood, in the childhood. Next slide, please. So the incidence is one. So the incidence, now coming to the epidemiology of childhood diabetes, basically the 1 in 300 children by the age of 20 years in the Europe and North America develop diabetes. So in North America and Europe, the incidence is very high, but the rate is lower elsewhere in the world, and overall more than 1 million cases of type 1 diabetes exist worldwide, and more than 1 lakh new cases of childhood diabetes diagnosed annually. So this incidence is very rare in the newborn and infant age group, and the special terminology given to the diabetes which occur during the first 6 months of life or first 12 months of life is the neonatal diabetes, and it is very rare entity, and the incidence is 1 in 250,000 children born. And the diabetes between the age group of 9 months to 10 years, and almost in this age group almost all of the diagnosed diabetes is 99.9% cases are due to type 1 diabetes. So the incidence of type 2 diabetes is also increasing worldwide very rapidly, and the whole world is involved as the epidemics of there is marked increase in the childhood obesity incidence, and as the childhood obesity increases, there is gradually increase in the number of the type 2 diabetes during the childhood, and this epidemics is present throughout the world. Now coming to the diagnosis of diabetes during childhood, the diagnostic criteria is same as in the adults. The fasting plasma glucose more than or equal to 126, postprandial more than or equal to 200, HbA1c more than or equal to 6.5, and RBS more than 200 in the presence of classical diabetic symptoms like polyuria, polydipsia, and polyphagia, weight loss, etc. So the diagnostic criteria is same during childhood also. And now coming to the classification of diabetes during childhood, it is very important because that if you don't know the type of diabetes in the childhood, then you cannot treat the child properly, because the treatment of type 1 diabetes is different, type 2 diabetes is different, MODI is different. So etiological classification is very important. These are the types of diabetes present during the childhood. The commonest is the type 1 diabetes, followed by the type 2 diabetes. These two are the two most common type of diabetes seen during childhood also, followed by the monogenic diabetes like MODI. Diseases of exocrine pancreas like pancreatitis or chronic calcific pancreatitis, which leads to the fibrocalculous pancreatic diabetes, is also very commonly seen, at least during our OPD in IGMS. We see very, at least in each month, we see 5 to 7 cases of fibrocalculous pancreatic diabetes. But since our institute is the referral institute, so it may be possible that there is selection bias, but the fibrocalculous pancreatic diabetes is not very rare. Other endocrine disorders like acromegaly, Cushing syndrome can cause diabetes during the childhood. The glucocorticoid used during childhood is very common, which can result in the drug-induced diabetes mellitus, and the other genetic syndromes like Down syndrome, Turner syndrome, Klinefelter syndrome are associated with diabetes mellitus during the childhood. So now coming to the first case, a 5-year-old child presented with the pain abdomen, vomiting, rapid breathing, altered sensorium, and after taking history, the child is suffering from the polyuria, polydipsia, weight loss from the last 3 months. There is no history of fever and cough. There is no family history of diabetes. Signs of marked dehydration is present, and child has acidotic breathing with fruity odor. Random blood sugar was more than 400, and during ABG analysis, pH was 7.1, bicarbonate is 12, and urine ketones is strongly positive. So this is a classical case of type 1 diabetes presented with the diabetic ketoacidosis. So this is the usual presentation of type 1 diabetes with DKA, and the most common presenting symptom in the type 1 diabetes are the polys like polyuria, polydipsia, polyphagia, unexplained weight loss, and it is seen in 85% of the children presented who have first time diagnosed with type 1 diabetes. But in the low or middle income countries like India, even in these days, 30 to 40% of the type 1 diabetes presented as diabetic ketoacidosis for the first time. So young children, besides the presentation, young children may present with the bedwetting, recurrent infections, or irritability instead of classical diabetic symptoms. And early identification at the community and primary care level can significantly reduce decay-related mortality, as we all know that diabetic ketoacidosis is a very serious condition, and even in current scenario, the mortality rate is between 5 to 15%. So diabetic ketoacidosis should be avoided, and diabetic ketoacidosis can be avoided by the early diagnosis and the proper treatment of the type 1 diabetes. So as we all know that diabetic ketoacidosis is diagnosed by the classical triad of hyperglycemia, acidosis, and ketosis. These are the clinical features of diabetic ketoacidosis, mainly presented with the symptoms like polys plus abdominal pain, breathlessness, etc. And on examination, there is marked tachycardia, hypotension, dehydration, small breathing is there, fruity odor to breath is a classical sign of this diabetic ketoacidosis. Abdominal tenderness may be present, and patient can present with the altered sensorium also. So if any child presented with the DKA, then almost diagnosis is certain that this is a case of type 1 diabetes. There is no confusion. But when there is confusion, in that cases we can go for the auto antibodies like anti-GAT65 antibody, anti-islet cell antibody, or anti-IA2 antibodies, anti-zinc transporter 8 antibodies. These are some of the important antibodies which indicate that this is an autoimmune type of diabetes, and this auto antibody there is autoimmune destruction of the pancreatic beta cell, leads to the either absolute insulin deficiency, or there is relatively less production of the insulin in comparison to the requirement, and that is the reason for the type 1 diabetes. And these antibodies are present in more than 85% of the type 1 diabetes patients at the time of diagnosis, and after 12 to 15 years, it is almost 100% autoantibody positive in cases of type 1 diabetes. So treatment are this decay, there is no use at this forum. So the first case where the diagnosis is very clear that this is a type 1 diabetes. But there is a confusion. There is overlapping presentation of type 1 diabetes, type 2 diabetes and monogenic diabetes during the childhood. And the overlapping is like that about 6% of the individual with young onset type 2 diabetes can present with the diabetic ketoacidosis. In the today study, 10% of the individuals considered to have young onset type 2 diabetes have a positive diabetes autoantibody also. And roughly 1/3 of the young with type 1 diabetes are overweight or obese. As we all know that there is marked increase in the incidence of childhood obesity, so even type 1 diabetes baby can be either overweight or obese also. So it is not true that 100% of the overweight or obese cases are type 2 diabetes. It can be type 1 diabetes also. So the distinguishing type 1 diabetes from type 2 diabetes in children may not be easy, as obesity in childhood is increasing, and almost 30% of the newly diagnosed type 1 diabetes or MODY patients may be obese. So these are the risk factors for the development of the type 2 diabetes. So now coming to this slide. So if HbA1c is more than 6.5% or diabetes is diagnosed, and if BMI is less than 85th percentile, age is less than 10 years, or child is prepubertal, there is no signs of metabolic comorbidities, and if there is history of diabetic ketoacidosis or cerebral edema, then that child is type 1 diabetes. And if BMI is more than 85th percentile, age is more than 10 years, or that is postpubertal, child is postpubertal, there is signs of metabolic comorbidities, and there is no history of diabetic ketoacidosis and cerebral edema, then that child should be considered as type 2 diabetes. So I have already discussed this. Now coming to the few slides about the MODY. MODY is basically the onset of diabetes below 25 years of age, and there is a strong multi-generational family history. The onset, there is at least 3 generations of positive family history of diabetes at the young ones at the age of below 25 years or 30 years. And there is mild stable hyperglycemia. In most of the cases, there is only fasting hyperglycemia. Autoantibodies are negative, and the only way to confirm the diagnosis of MODY by 100% is genetic testing. So classically, MODY teaching is onset less than 25 years, index case, and there is a strong family history, autosomal dominant inheritance in 3 generations. Onset of diabetes less than 25 years or 30 years, there is mild stable hyperglycemia, and autoantibodies is negative. So some of the diseases of the exocrine pancreas can lead to the diabetes, like any case of acute pancreatitis can cause transient hyperglycemia, and even in cases of chronic pancreatitis that can lead to the permanent diabetes. Any type of surgery like pancreatectomy, pancreatic cancer, the genetic diseases like cystic fibrosis, hemochromatosis, this can lead to the can lead to the pancreatic diabetes. And one of the most common pancreatic diabetes is the fibrocalculous pancreatic diabetes, and in these cases the child is young, very underweight, or usually underweight, belongs to the low socioeconomic status. Usual presentation is the abdominal pain with the diarrhea, recurrent diarrhea, hyperglycemia is mild to severe, and they can respond to the either oral hypoglycemic agent or the insulin. And one of the main thing is that fibrocalculous pancreatic diabetes is ketosis resistance. They may be insulin dependent, but they never go to the diabetic ketoacidosis, because besides insulin secretion, the glucagon secretion is also impaired. That is the reason and also they are lean and thin, there is less fat is present, so they are ketosis resistance. So decay is very rare in a fibrocalculous pancreatic diabetes. Classical presentation is abdominal pain, diarrhea and diabetes. Diagnosis of PepsiPD can be done by the simple X-ray, but few cases can be missed with the X-ray, and that can be picked by either ultrasonography or the CECT abdomen, and ERCP is considered as the gold standard for the diagnosis of fibrocalculous pancreatic diabetes. So this is one case, 13-year-old male presented with the diabetes, and he does not respond with the oral hypoglycemic agents. And in CCT abdomen, there is severely atrophic pancreas. When there is on imaging, there is atrophic pancreas is there, so there is less likely that this case respond to the oral hypoglycemic agent. And when insulin was started, there is a dramatic response in the glycemia reduction in the fasting plasma and HbA1c. So other cases of diabetes like mitochondrial diabetes is also seen in the childhood, and this mitochondrial diabetes can, besides the diabetes, there is neurological syndromes like progressive bilateral sensory neural hearing loss since the early childhood. And besides these neurological symptoms, ocular symptoms are also there, like mild retinopathy observed during ophthalmological examination. Wolfram syndrome is another form of childhood diabetes in which diabetes insipidus is there, diabetes mellitus is there, optic atrophy and deafness is there. So this child can present with the diabetes along with the diabetes insipidus, and also there is reduction in the decreased vision and sensory neural hearing loss. So with this, I have tried to finish in time, and I have discussed briefly the all types of diabetes which present during the childhood. So with this, thank you. I don't know. Fibrocalculus type 3C बोलते हैं इसको सर. I don't know type 5 diabetes क्या होता है, मैं जानता ही नहीं. बस बताओ, आप बताओ. MMDM को बोलते हैं. अच्छा, हाँ, MMDM का एक स्लाइड था मेरे को, मैंने दिखाया. हाँ, वो बोलते रहता है कोई, कभी कुछ वो जो बोलता है. हाँ, 1.5 डायबिटीज तो लाडा को भी बोलते हैं सर, लाडा को बोलते हैं. लाडा बेसिकली प्रेजेंटेशन होता है टाइप 2 डायबिटीज की तरह प्रेजेंट करता है, बट ऑटो एंटीबॉडी इज पॉजिटिव, एंड for the initial 5 years they respond with the oral hypoglycemic agents, and after 5 years due to autoantibody mediated destruction of the pancreatic beta cells, ultimately they are insulin dependent. They will become insulin dependent. That is latent autoimmune diabetes of the adult, and type 1.5 diabetes is. Yeah. MMDM rarely ही मिलता है, बस rarely ही मिलता है. एडोलेसेंट में हमने जो देखा है, एडोलेसेंट में ही देखा है. 2-4 डायबिटीज मैंने 2-3 केसेस देखे हैं. इसका कोका कोला डायबिटीज जिसको बोलते थे, जिसको फ्लैटबुश डायबिटीज बोलते हैं. हाँ, द इनिशियल प्रेजेंटेशन विद द डायबिटिक कीटोसिडोसिस, सीवियर डायबिटिक कीटोसिडोसिस, एंड द चाइल्ड इज वेरी सीरियस, एंड आफ्टर ट्रीटमेंट मतलब द चाइल्ड इज ऑल राइट, एंड आफ्टर फ्यू डेज the insulin goes to the zero, and there is no requirement of any drug, and the child maintains blood sugar with the only lifestyle diet control. That is known as the Flatbush diabetes or Coca-Cola diabetes. Another term, type 3 diabetes, is known as is the term used for the Alzheimer's disease. Alzheimer's disease. Yes, Alzheimer's disease को भी type 3 बोला जाता है. टाइप 3, हाँ, डायबिटीज. टाइप 3C इसको बोलते हैं, फाइब्रोकैल्कुलस को बोलते हैं, टाइप 3C.
Thank you, sir, for that insightful presentation.
While HbA1c has long been the cornerstone of diabetes monitoring, advances in continuous glucose monitoring are helping us look beyond averages.
The concept of time in range is rapidly emerging as a more dynamic and patient-centered metric for assessing glycemic control. To enlighten us on this evolving paradigm, we invite Dr. Atul Kumar sir to deliver his talk on time in range, the new HbA1c.
Very good evening, ladies and gentlemen, and our respected seniors and juniors too over here. Today we have to have a nice and exhaustive evening. Still I have to go for the time in range. So the new HbA1c, a paradigm shift in diabetes management. Contents what we are going to deal in with the HbA1c paradox, clinical evidence, clinical implementation, intertime in range, guidelines and targets, the Indian perspectives. The HbA1c paradox, understanding the limitation of our traditional and gold standard, HbA1c, the traditional gold standard, historical foundation. HbA1c has been a cornerstone of diabetes management over 30 years, providing an estimate of average glycemic control over 2 to 3 months. HbA1c complication correlation, strong epidemiological evidence links with HbA1c to both microvascular and macrovascular complications like retinopathy, nephropathy, and neuropathy. How HbA1c works? As we know, HbA1c measures glycated hemoglobin, glucose bound to hemoglobin molecules, high average blood glucose, that is higher HbA1c. Glucose attached to hemoglobin reflects 2 to 3 months average, red blood cells lifespan. The question arises over here is that if HbA1c is so well established, why do we need a new metric? The answer lies is what HbA1c cannot tell us about daily glucose patterns. The hidden truth, HbA1c limitation and glycemic variability. Major limitation of HbA1c misses glycemic variability. Identical HbA1c can hide extreme glucose swings, anemia and hemoglobin variants, inaccurate in iron deficiency, hemoglobinopathies, delayed feedback, 2 to 3 month lag provide no real-time actionable data. Invisible hypoglycemia cannot detect nocturnal or asymptomatic lows. Racial and ethnic disparities are also seen. Same glucose level yield different HbA1c by race. Pregnancy, unreliable physiological changes make HbA1c less accurate. So the case study which means the HbA that misleads, which will go in the further slide, inter-time in range, the cesium revolution and new glycemic matrix. Continuous glucose monitoring technology overview, how cesium works. A tiny sensor inserted under the skin measures interstitial fluid glucose every 1 to 5 minutes, providing 288 to 1,440 readings per day versus 4 to 6 finger pricks test. As you see over here, the daily readings is 288, 10 to 14 sensor days, and MARD accuracy is below 10%. The cesium evolution, when it started, the first generation was from 1999 to 2005. That was professional cesium, required calibration, limited accuracy. The second generation has come in the 2006 to 2015. The real-time cesium, predictive alerts, improved accuracy. The third generation was 2016 to 2023. That was factory calibrated or no fingerprints, smartphone integration, smaller sensors. Fourth generation was that what we are using it right now is multi-analytic sensors, AI integration, longer wear, predictive analytics. cesium matrix beyond single number, the time in range that previously told by our chairman, Dr. Sehwal, that he has given a slide for that in that his speech. The time in range is more than 70 to 180 mg per deciliter. Time below range, that is TBR, that is less than 70. Time above range, TAR, that is around more than 180. And glycemic variability, that is CV, coefficient of variation is less than 36. Remember that I'm going a bit fast because time is short. RT cesium versus IS cesium, choosing the right tool. RT cesium is real-time cesium. How it works? Automatically transmits glucose data every 5 minutes without using action, provides continuous data stream. Key features: predictive alerts, customizable alarms, urgent low glucose alert, rate of change arrows, and IS cesium is intermittently scanned. How it works? Users scan sensor with reader smartphone to get glucose reading, stores for 8-hour data. That clinical evidence by for RT cesium is superiority, and there are many studies which has been given. Clinical evidence, the data supporting TIR as a new standard. The TIR and diabetic complication, the evidence, the landmark studies has been done over here, and they have given the TIR advantages is the major point over here. The better microvascular prediction captures hypoglycemia, detects glycemic variability, real-time assessment, HbA1c limitation, misses glucose swings, invisible hypoglycemia, delayed feedback, and affected by anemia. The clinical implication is that TIR provides superior prediction of microvascular complication compared to HbA1c, especially after adjusting for confounders. Clinical trials, TIR as primary outcome, and you can see over here that it has given a good result over with some of the chemicals. TIR versus HbA1c when they diverge. Again, I am skipping one. TIR HbA1c relationship, that you can see the TIR 80% is HbA1c is 6.5, TIR 70 is 7, TIR 60% is 7.5, TIR 50 is 8%, and TIR 40, that is very poor, that is 8.5, and TIR 30 is dangerous, and that is more than 9 of the HbA1c. Why TIR despite correlation? That is there, that more information is there, real-time feedback, hypoglycemia safety, pattern recognition, patient engagement. Expert consequences. TIR doesn't replace HbA1c. I just repeated. TIR doesn't replace HbA1c, it completes the picture. The correlation validates TIR as a reliable metric while providing superior clinical utility. Guidelines and targets, international consequences of TIR goals, international TIR targets and special populations. All targets should be individualized based on age, diabetes duration, complication, hypoglycemia risk, comorbidities, and patient preferences. CGM report interpretation is there. Clinical implementation, practical strategies for our practice. Who should get CGM? Strongly recommended for all type 1 diabetic patients, that is ADA standard care, type 2 diabetic patients on intensive insulin therapy, hypoglycemia unawareness, pregnancy with diabetes. Consider useful type 2 diabetes on basal insulin, suboptimal glycemic control, glycemic variability concern, recurring hypoglycemia. Patient education onboarding before sensor placement, explains CGM benefits, sensor wear time, calibration needs skin care. Data review, schedule follow up to 14 days to review the AGP report together. During wear, teach data interpretation, trend arrows, LR management, action planning, set 1 to 2 achievable TIR goals, adjust treatment based on patterns. Cost effectiveness and the economic case, I will go in the Indian perspectives. CGM adoption in India, barriers and solutions. That is a high cost. CGM sensors are around, CGM sensors are around 300,000 to 6,000 each. No reimbursement is there under Ayushman Bharat or most insurance. Urban-rural drive, limited availability beyond tier 1 and 2 poor connectivity rules areas, climate changes, heat and humidity affect sensor adhesion and accuracy, need climate-adapted devices, dietary complexity, high carbohydrate, high glycemic index meals cause sharp postprandial exertions. Limited awareness, both healthcare provides and patients lack CGM education and interpretation skills. Proposed solution for that is that intermittent CGM model, 10 to 14 days sensor wear, 2 to 4 times a year for type 2 diabetes, reduces cost by 60 to 70% while maintaining climate benefit. Telehealth integration, remote CGM interpretation for rural patient, digital nuts, and AI-based pattern recognition. Indian specific reimbursement, advocate for partial or full coverage under Ayushman Bharat, prioritize type 1 diabetes, pregnancy, high-risk patients, climate-adopted devices, develop stronger adhesives, heat-resistant sensors, and extended wear options for Indian conditions. Structured education, Indian-specific CGM training for HCPs, patient education in regional languages, peer support programs. The path forward practical recommendation for physicians: start with high-risk patient, prioritize type 1 diabetes, pregnancy, frequent hypoglycemia, suboptimal control on insulin, use intermediate CGM for type 2 diabetes on basal insulin or OADs for 10 to 14 days quarterly to guide therapy adjustments, invest in education, attend CGM interpretation workshop, learn AGP report reading, join professional networks. For healthcare systems, that is telehealth infrastructure, now Dharmendraji already discussed about it, the digital integration, quality metrics, implementation roadmap, that is in 3 phases. Phase 1 is 0 to 6 months, start with type 1 diabetic patient, establish CGM clinic, train staff. Phase 2 is 6 to 12 months, add insulin, treated type 2 diabetes patient, introduce intermittent CGM, patient education program. Phase 3 is for 1 to 2 years, expand to all high-risk patients, health integration, outcome publication. But still I will say that, remember, TIR complements HbA1c, doesn't replace it. Start small, think big, and let the data drive better diabetes care. Time in range, the future of diabetes care. TIR doesn't replace HbA1c, it completes the picture. Precision care, as we have talked, 288 daily readings versus 4 to 6 finger pricks. Reduced complications, 44% lower microvascular risk per 10% of TIR, improved quality of life, less hypoglycemia, more confidence. The future of diabetes management is continuous, personalized, and data-driven. Thank you. Thank you for your patience here.
Thank you, sir, for that insightful presentation.
Also, the operating room presents a whole new set of glycemic challenges.
The success of surgery often depends not only on the surgeon's skill, but also on meticulous metabolic management.
To shed light on this crucial topic, we now invite Dr. Amit Kishore sir to deliver his talk on perioperative glycemic control.
Good evening. So, perioperative glycemic control, why it is important? Because many times during anesthesia, the PSC, during PSC workup, the anesthesia team sends you the files for his blood sugar, and it's generally the medicine department who is responsible for managing the blood sugar. So, hyperglycemia, the prevalence is up to 40% in general surgery and up to 80 to 90% in cardiac surgery. So perioperative hyperglycemia is an independent marker of adverse outcomes. Due to hyperglycemia, the consequences are delayed wound healing, increased infection, increased rate of ICU admissions, prolonged stage, and higher post-operative mortality. So the pathophysiology of stress hyperglycemia. During surgery and anesthesia and the illnesses can trigger a release of counter-regulatory hormones, namely cortisol, glucagon, growth hormones, and catecholamines, which reduces the insulin secretion, elevates insulin resistance, and increases lipolysis and proteolysis. The result is gluconeogenesis and glycogen lysis surge, causing stress hyperglycemia. So uncontrolled hyperglycemia then drives osmotic diuresis, electrolyte imbalance, ketogenesis, production of pro-inflammatory cytokines, and immune dysregulation. So glycemic targets, the different societies, they have set their targets. Like the American Diabetes Association has set the target of 80 to 180 milligram per deciliter of glucose for perioperative period, and in critically ill patients it's up to between 140 to 180 milligram per deciliter. Similarly, other groups are there like Society for Emergency Anesthesia, Society for Critical Care Medicine, American College of Physicians. So they all have set their target for blood sugar between the range of 140 to 180 or 200. So what to do? So during pre-operative phase, first we take our medical history. We focus on the type of diabetes, the type of medications they are taking before coming here, and the previous glycemic control, and any complications which are there in the patient like nephropathy, neuropathy or retinopathy or cardiovascular diseases. Then you assess for the history of susceptibility of hypoglycemia and awareness, any history of unawareness for hypoglycemia. Then the type of surgery, whether the patient is going elective surgery or emergency surgery. Then you obtain a preoperative HbA1c level, but the link between elevated HbA1c level and poor postoperative outcomes is not yet correlated. So during pre-operative phase, you ask a history of what are the types of medications the patient is taking. Sorry for that cross marks. So if the patient is taking metformin, earlier it was not recommended, but nowadays it is recommended to continue taking metformin and avoid the medication in cases of patients who are undergoing any contrast procedure, like patient taking any contrast or patient with renal dysfunction. Sulfonylureas, there is a risk of hypoglycemia, so it is recommended to discontinue the drug on the day of surgery. Then SGLT2 inhibitors, there is a risk of euglycemic ketoacidosis, so it is recommended to discontinue the drug between 1 to 3 days before the day of surgery. GLP-1 agonist, earlier it was not recommended to use GLP-1 agonist, but now it is said that if the patient is taking GLP-1 agonist, then you can put the patient on a 24-hour liquid diet prior to the day of surgery, and then you can continue GLP-1 agonists. Regarding DD4 inhibitors like sitagliptin, it is generally safe and efficacious, but current ADA guidelines do not recommend to use this drug during surgery. So now coming to insulin adjustments. So apart from drugs, if the patient is taking insulin, so how to adjust the dosage? If the patient is taking long-acting insulin, like larginoterimide, then we should reduce the dose of long-acting insulin by 20 to 25% on the day before surgery, or if he is taking the drug in morning, then you can reduce the dose on the morning of surgery. If the patient is taking high dose of basal insulin, like more than 60% of the total daily dose is basal insulin, then reduce the dose of basal insulin by 50 to 75% on the day before surgery. If the patient is taking intermediate acting insulin, then it is recommended to reduce the dose of intermediate acting insulin by 50% on the morning of surgery, not before day of surgery. And if the patient is taking premixed insulin, then it is recommended to switch to long-acting insulin on the day before surgery, on the evening of surgery, or reduce the dose of premixed insulin by 50% on the morning of surgery with initiation of IV dextrose. Another approach is to skip the morning dose and arrive early in the operation theatre and receive a long-acting insulin. So before starting surgery, it is mandatory to check the blood glucose in the pre-operative phase, treat any hypo or hyperglycemia before proceeding, and consider postponing the surgery if blood glucose is not being controlled and if it is more than 250 mg per deciliter or patient is having metabolic decompensation. Then intraoperative glucose management. So intraoperatively, if the patient is undergoing for short procedures, and if like less than 4 hours, and the patient is hemodynamically stable, then you can give subcutaneous insulin, rapid acting insulin, every 2 hours only by doing regular blood checks. And if the patient is undergoing long surgery for more than 4 hours, or the patient is hemodynamically unstable, then it is recommended to start IV insulin infusion if the blood glucose exceeds more than 180 milligram per deciliter, and the blood glucose monitoring will be done every 2 hourly. Now, intravenous insulin is preferred during long surgeries or in patients with hemodynamic instability or hypothermia because of its short duration of action and better absorption and better titration. Now, post-operative management, what to do after any surgery. So, if the surgery was short duration and the patient is ambulatory, then stable patients can be discharged by prescribing the oral medications which they were taking earlier. In non-critically ill patients who are shifted to ward after surgery, they can be shifted on subcutaneous insulin regimens, basal plus correctional insulin for patients who are taking very less by mouth for poor oral intake, and basal plus nutritional plus correctional insulin for patients who are taking feeds by mouth. In patients who are critically ill, who are shifted from operation theatre to ICU, in such patients, it is recommended to use continuous intravenous insulin infusion with blood glucose monitoring every 1 to 2 hourly and shift the patient directly to ICU. So, subcutaneous insulin regimens, the components are first is basal insulin, then nutritional and correctional and combined. So, basal insulin controls hyperglycemia during periods when patient is also not eating, like such during nights or during meals or in fasting state, like glargine meal. Nutritional insulin is given, referred as the insulin which is given during the meal time, or prandial insulin, which helps in managing the hyperglycemia associated with carbohydrate intake from meals. So, for nutritional insulin, we use rapid acting insulin or regular insulin. Correctional insulin is used to treat hyperglycemia that exceeds the targeted level during those periods when you monitor blood glucose every 1 to 2 hourly. And if there is any surge in blood glucose level, then you give correctional insulin either by using rapid acting insulin or short acting insulin. So, how to decide dose? So, by weight-based insulin dosing, generally in an average patient, the dose of insulin is around 0.4 to 0.5 units per kg per day. In older age people, insulin new patient or patient with renal hepatic deficiency, it's around 0.2 to 0.3 units per kg per day. And in insulin resistant patient, it is 0.6 to 0.7 units per kg per day. So, after deciding the total dose to be given, the 50% of the insulin is given as basal, and 1/6 of the total dose is given as nutritional in 3 settings with each oral intake, and the rest is given as correctional. Now, blood glucose monitoring in these patients who are being shifted to subcutaneous insulin regimen, it is done 4 times, 3 times before meals and 1 at bedtime, and administer correctional insulin if the sugar is raised. And patients who are not eating by mouth, then you have to give correctional insulin every 6 hourly after checking blood sugar levels, or every 4 hourly with rapid acting insulin. So, in critically ill patients who are shifted to ICU, they are managed with continuous intravenous insulin infusion, and once these patients achieve hemodynamic stability with no vasopressor requirement, and when they start showing good glycemic control, then we plan to shift the patient from continuous intravenous infusion to long or intermediate acting insulin. So once you decide of shifting from IV to subcutaneous preparation, there should be an overlap of 2 to 3 hours before discontinuing IV insulin because premature discontinuation of IV insulin may lead to rebound hyperglycemia. So, when we switch from IV to subcutaneous insulin, the dose of insulin is calculated. First is the rate-based method, second is weight-based method, and third is home insulin method. So, when the patient has been put on continuous intravenous insulin infusion, we see the infusion rate of insulin over the last 6 to 8 hours, and we multiply it by 24 hours, and the last 6 to 8 hours infusion rate will decide the total daily dose, and uska 70 to 80% will give as the subcutaneous total insulin. Now, patients who are not taking any caloric intake, 100% of their dose will be given as basal insulin, but patients who are taking optimal caloric intake, 50% will be given as basal and 50% as nutritional insulin. In weight-based method, we will calculate the total daily dose by weight, and 50% of that will be given by basal insulin and 50% by nutritional insulin. And patient discharge for home therapy, the 70 to 80% of insulin dose will be given during transition period, plus correctional insulin will be given. Pre-mixed insulin should be avoided in the perioperative setting due to increased risk of hypoglycemia. Clinical significance of intensive versus conventional control. It has been seen that in the landmark NICE sugar trial, that conventional glucose control, that is keeping the blood sugar up to 180 milligram per deciliter, compared with intensive control, that is keeping the blood sugar between 80 to 108 milligram per deciliter in critical patients. It was seen that intensive control resulted in higher incidence of mortality and morbidity and more chances of severe hypoglycemia. Now, special populations like patients with type 1 diabetes, they require a continuous, during the perioperative period, they require a continuous supply of basal insulin at all times. So either it can be given by IV route or by subcutaneous infusion, insulin infusion pumps. Patients, this intraoperative subcutaneous insulin infusion pumps, they are normally used for procedures which are of shorter duration, like for less than 2 hours, and they are helpful in giving a better glycemic control. They provide a basal coverage with continuous subcutaneous infusion of small dose rapid acting insulin. In patients who are put on enteral nutrition, it is after operation, it is recommended to use a low carbohydrate, high monounsaturated fatty acid formulas, and basal insulin plus nutritional plus cholesterol insulin is used. Normally, the 30 to 50% of total daily dose is given as basal, and 50 to 70% is given as nutritional insulin. Another idea of calculating the dose is around, another alternative idea is to use 1 unit of insulin per 10 to 15 gram of carbohydrate per feed. Now, patients who are put on total parental nutrition, for them a separate IV infusion of regular insulin is given until the blood glucose is at goal, and then when the blood sugar comes at control, then we calculate the total dose of insulin and incorporate the total 82% of total insulin dose in the infusion itself. Or the second idea is to add 1 unit of regular insulin per 10 gram of dextrose of the treated TPN solution to the bag only. So, hypoglycemia.
Please summarize.
Yes, just 2 minutes. The contributing factors for hypoglycemia are inappropriately dosed insulin. If we set aggressive targets for glucose correction, when insulin is not aligned with the meal time, when there is change in caloric intake and insulin is not given appropriately, and poor provider-nurse communication. Now, last slide. There are some anesthetic drugs which can affect glucose levels, like initial agents like sevoflurane, isoflurane. They can increase sympathetic tone and release of catecholamines, leading to insulin resistance and increased hepatic glucose production, resulted in elevated blood glucose levels. Second is propofol. Propofol generally is safe drug and it is a mild glucose lowering effect. But in contrast, third is ketamine. Ketamine can cause significant hyperglycemia. And fourth is beta blockers. Beta blockers may sometimes mask the symptoms of hypoglycemia. So we have to be cautious while using those three drugs. So key takeaways are, we have to keep the glycemic targets between 140 to 180 milligram per deciliter. And we have to choose the oral agents carefully, especially avoid sulfonylureas and SGLT2 inhibitors. Insulin strategies should be basal, bolus, correctional and nutritional. And avoid extreme glucose control because it may increase the chance of hypoglycemia and morbidity. And overall, there should be a team approach, interpersonal coordination between anesthesia and medical team and nurse team. Thank you.
Thank you, sir, for simplifying an area that every clinician encounters but often finds challenging.
As diabetes continues to impact every organ system, its relationship with cardiovascular disease remains a major area of focus.
Heart failure with preserved ejection fraction is increasingly recognized in patients with diabetes and often tests our clinical acumen. To discuss this evolving challenges, we now invite Dr. Ananya Mohanty ma'am to deliver her talk on heart failure with preserved ejection fraction in diabetes and its clinical challenges.
A very good evening to one and all present. It is an absolute honor to be a part of this distinguished gathering, and I'm grateful to have been given an opportunity to present this topic of heart failure with preserved ejection fraction and the clinical challenges that we face. So amongst all cardiovascular complications of diabetes, heart failure with preserved ejection fraction is perhaps the most underdiagnosed. Today, more than half of heart failure patients with diabetes have preserved ejection fraction. Of all heart failure patients, diabetes is present in almost 40 to 50% of the cases. Now, that is why this topic is extremely important, and most cases, since the presentation is late, plus we are late in diagnosing the patient, the mortality is high. Now, the learning objectives for today would be recognizing diabetic heart failure with preserved ejection fraction cases, understanding the basic pathophysiology involved, applying diagnostic algorithms, implementing evidence-based therapies, and using a phenotype-based treatment. By a phenotype-based treatment, I mean that we cannot put a single treatment for all patients. It has to be individualized according to the patient's age, symptoms, complications, and at what stage we are facing the patient. Now, I would like to come to a clinical case that had personally come to me. However, it was misdiagnosed earlier. It was a 58-year-old female with a type 2 DM for about 12 years. The patient was also hypertensive. I had a BMI of about 33 kg per meter square, and the HbA1c was 8.1. The patient has progressive dyspnea with the echo was done earlier, and it showed an ejection fraction of about 60%. Now, the question of the hour is, does this patient have heart failure? Now, I would come back to this slide later after we have discussed all the algorithms in this topic. Now, why heart failure matters? That is heart failure with preserved ejection fraction. Because diabetes increases the risk of heart failure by 2 to 4-fold. The mortality is high. In fact, it is comparable to the cases of heart failure with reduced ejection fraction. 50% of heart failure cases are heart failure with preserved ejection fraction cases. Now, coming to the central illustration of the epidemiology, now the prevalence of heart failure in Asia, as you can see in the slide, is very high, mostly with China, Indonesia, and Malaysia. Here, India lies at about 5th to 6th number in the epidemiological geographical distribution. Now, the most common causes would be ischemic heart disease, hypertension, other cardiomyopathies, hypertensive heart disease, etc. Now, diabetes and heart failure, why is it important? Because diabetes causes insulin resistance, there will be inflammation, which will cause diastolic dysfunction, which will further lead to heart failure with preserved ejection fraction, and which will increase the number of times the patient is being hospitalized. Now, I would like to emphasize on this slide, heart failure with preserved ejection fraction is not normal EF, normal EF. There is something that is going wrong in our body. So the normal heart has a normal filling, has a compliant LV and a low filling pressure. However, the heart failure with a preserved ejection fraction has an impaired filling, stiff LV and a high filling pressure. Now these are the contributing factors. We basically attribute the pathophysiology to glucotoxicity and lipotoxicity. Now, glucotoxicity can be increased. Why? Because of the increased production of AGEs, that is advanced glycation end products. Now, how are these products produced? When we say no to excessive deep frying foods, when we say no to excessive using of corrosive materials while you are cooking, now this causes increase in AGE production, and that could cause mitochondrial dysfunction and increase oxidative stress, which is a definitive proven risk factor for developing heart failure. Now there is also coronary microvascular dysfunction, which causes endothelial dysfunction, and there is myocardial ischemia as well. Now there is also fibrosis and ventricular stiffness attributed to heart failure with preserved ejection fraction. Now here you can see a normal heart where the fibroblast is present, and whereas in ventricular stiffness and fibrosis, when it is developed, it shows a hypertrophic cardiomyocyte and a myofibroblast that is present, along with few perivascular fibrosis also present in the pathological specimen that we found. Now, why do we miss heart failure with preserved ejection fraction commonly? Because the symptoms commonly overlap with conditions like obesity, autonomic neuropathy, and CKD. Now, the clinical pearl here I would like to again emphasize is a normal ejection fraction is not equal to a normal heart. The diagnostic roadmap would be simple. We'll assess the symptoms, get an echocardiography done, go and do the NT-proBNP, which is very commonly missed, get a HFpEF score done, and assess the HFA-PEF guideline, which I would be discussing in the further slides. Now, is NT-proBNP the only thing that can diagnose along with the echo that if a patient has heart failure or not? No, NT-proBNP has its own pitfalls. For example, a patient who is morbidly obese, you cannot trust NT-proBNP in those cases. Why? Because it has, now in an obese patient, adipose binding is present in BNP and not to NT-proBNP. Now when there is no binding, we cannot expect NT-proBNP to rise as in normal patients who are not obese. There's also lower inflammatory cytokine activity attributed to obesity and decreased cardiac release. So no, NT-proBNP cannot be the only cardiac marker along with the echo which can suggest that the patient is in heart failure or not. Now the HFpEF score that I've already discussed, it is 2 points for the H, that is heavy hypertensive, heavy with a BMI of more than 30, and hypertensive if the patient is on more than 2 drugs. F is for atrial fibrillation, P is for pulmonary hypertension, E is elder patient, that is more than 60 years of age, and F is a filling pressure with E and E prime ratio more than 9. Now it's a total sum of about 9, the highest ranging to 9, with an increased risk of heart failure, developing heart failure with preserved ejection fraction. Now the HFpEF score is the newest guideline which has a symptomatic assessment. First will be the pre-test assessment. E is a diagnostic workup that has echocardiography and natriuretic peptide. F1 would be the advanced workup with a functional testing, and F2 will be the etiological workup that declares our final etiology. That can be genetic testing, laboratory test, cardiovascular MRI, cardiac and non-cardiac biopsies as well. Now, echocardiographic assessment, this I have already discussed. There are majorly 4 factors that we see into consideration. That is the E-E prime ratio, the septal and the lateral E prime, the TR velocity, and the LA volume index. Now AI is coming into picture with every scope that we go into. Now similarly, we also have AI diagnosis in this topic as well, diabetes and heart failure. The watches that we use nowadays, Apple watches, Android watches, you can just tap on the watch, get your ECG monitor, and you can just have a rhythm that if you're having atrial fibrillation currently or not. That's the importance of AI in today's life. The Apple Watch or your monitor will detect an abnormal rhythm if you're in sinus rhythm or if it is abnormal, and it will definitely give you an alert that probably you need to go and see a physician immediately or a cardiologist for that matter. Now, important trials over here, I'll go through it quickly. Emperor Preserve trial is on the importance of empagliflozin in heart failure, and the conclusion was empagliflozin definitely reduced the combined risk of cardiovascular death in the patients and reduced the number of hospitalizations that a patient had to go through. Deliver trial again is a very important trial which considers dapagliflozin. Now, the basic difference between Deliver trial and Emperor trial here is the age criteria for Deliver trial was less than 40 years and older, and Emperor was 18 years and older. And a major difference was in the BMI, that is less than 50 in Deliver and Emperor less than 45. But both have a significant importance in reducing the cardiovascular mortality. Now, the STEP HFpEF DM trial includes semaglutide, that is our newest molecule. It's a once weekly dose, and semaglutide in the dose of 2.4 mg once weekly in patients with obesity related heart failure was extremely crucial in reducing the hospitalization and decreasing body weight as well. Summit trial is also important as it includes tirzepatide for heart failure with preserved ejection fraction and obesity. Now, SGLT2 inhibitors, most important here because natriuresis reduce the preload, improve energetics, and outcome is obviously better after using SGLT2 inhibitors. Now, the guideline update according to various societies, the European Society of Cardiology places a class 1 recommendation for the use of SGLT2 inhibitors. Again, ACC also puts it as a strong recommendation of using SGLT2 inhibitors. ADA guidelines also have a grade A evidence along with the Research Society for the Study of Diabetes in India. Now, the Indian perspective is the basic challenges that we face. Number 1 is underdiagnosis. Number 2 would be the cost. Number 3 is limited imaging, considering the kind of people that are coming in rural backgrounds. Now, what every diabetologist can do from tomorrow is ask if the patient is having any dyspneic complaints, check for NT-proBNP, perform an echocardiography, calculate HFpEF, start the patient on SGLT2 inhibitors. Now, coming back, extremely sorry for the inconvenience here. However, I would like to come back to the previous case that I had already put up. Was a 58-year-old female. She was a type 2 diabetic with hypertension, a history of hypertension since past 10 years. She was morbidly obese with a HbA1c of 8.1. Now, her complaints were fatigue, reduced exercise tolerance, and progressive exertional dyspnea. Now, the investigations that were done, ECG had a sinus rhythm, NT-proBNP was normal, EF was 60%. Now, I had raised that question that if the patient has heart failure or not. Can heart failure with preserved ejection fraction be excluded in this patient? So the answer was no, it cannot be excluded, since when echocardiography, not a screening, when the complete echocardiography was done, the PASP of the patient was found to be 38, which is more, and the E by E prime ratio was 16, and the LA volume index was also increased, that was 38. Now, we'll also calculate, for that case, we'll also calculate the HFpEF score. The HFpEF score for that patient was 5 on 9 according to the HFpEF score that we had already discussed. Now, the important part here is, if we had already seen the screening echo which showed a EF of 60% and normal NT-proBNP levels, we would have just sent the patient home thinking that probably the patient does not heart failure. Now, when HFpEF score was calculated and the patient's echo was done again, it showed that the patient was in heart failure with preserved ejection fraction. Now, why was that diagnosis missed? The common cognitive errors could be the symptoms attributed to obesity. She was morbidly obese, came with complaints of shortness of breath, so that could have been missed. Fatigue attributed to diabetes, normal NT-proBNP, and preserved EF. Now, management, in this case, we could start with initiating a SGLT2 inhibitors like empagliflozin or dapagliflozin. The step 2 would be aggressive weight reduction, calorie restriction, exercise prescription, and considering adding GLP-1 receptor agonist. And step 3 would be optimizing the BP. And volume management, of course, if the patient is having congestions. Now, the take-home message that I would like to tell everyone is it's very important to diagnose heart failure when there is time and not to treat the patient when the patient is in advanced heart failure. So, diagnosing heart failure when there is still time is the beauty of heart failure with preserved ejection fraction in diabetes. Thank you so much.
Thank you, ma'am, for the enlightening presentation. We have heard from our distinguished experts, and now it's time to hear from our audience.
We welcome questions from the audience for the panel. Please introduce yourself briefly before asking your questions.
Any questions, please? So we proceed our session.
What an engaging session at first. From childhood diabetes to heart failure, we have covered a remarkable spectrum of contemporary diabetic care.
As we conclude this session, we extend our sincere gratitude to all the esteemed speakers, moderators, and delegates for their valuable contribution.
Knowledge grows when it is shared, and medicine advances when knowledge is translated into practice.
Let us continue to learn, innovate, and work together towards the advancing diabetes care.
Thank you, and have a wonderful evening and enjoy the rest of the conference.
We request our distinguished guests to kindly collect their mementos as a token of gratitude for our valuable presence. I request the volunteers to please escort our respected guests and the chairpersons to the felicitation area. Thank you, sir.
May I first invite our chief guest, Shri Govind Narayan Singh Ji, Honorable Pro-Chancellor, to kindly grace the dais.
We are delighted to welcome our esteemed guest of honor, Dr. Rajesh Kesri sir, National RSSDI EC member. May we request you, sir, to kindly take your seat on the dais.
May I now invite our distinguished guest of honor, Dr. B.K. Singh Sir, National RSSDI EC Member, East Zone. Sir, kindly join us on the stage.
We are honored to invite Shri Trivikram Narayan Singh Ji, Honorable MLA of Aurangabad Constituency, cum Managing Director, Narayan Medical College and Hospital, Sasaram. Sir, kindly grace the dais.
May I request Dr. Professor Jagdish Singh Sir, Honorable Vice Chancellor, Gopal Narayan Singh University, to kindly come forward and take his seat on the dais.
We now invite our esteemed patron, RSSDI Bihar, Dr. Ajay Kumar Sir, to kindly grace the dais with his presence.
May I request Dr. Shehbal Guha Sir, Chairman, RSSDI Bihar Chapter, to kindly join the distinguished panel on the stage.
It is my pleasure to invite Dr. Atul Kumar Sir, Scientific Chairperson and Chairman-elect, to kindly take his place on the dais.
May I now request Dr. Jitendra Kumar Sir, Organizing Chairperson and Head of the Department of Narayan Medical College and Hospital, Sasaram, to kindly grace the stage.
We warmly invite Dr. Mahendra Pratap Sir, Organizing Secretary, to kindly join the dignitaries on the dais.
And finally, may I request Dr. Abhishek Kamendu Sir, Co-Organizing Secretary, to kindly grace the dais. We now invite our esteemed dignitaries for the lighting of lamp ceremony marking the formal inauguration of the conference.
या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्म विचारसार परमां आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीमभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा.
Thank you, sir. I request you all to please take your seats. With the dais now adorned by our eminent dignitaries, we shall proceed with the felicitation ceremony as a token of our gratitude and appreciation for their presence and valuable contribution.
May I request Dr. Jitendra Kumar sir to kindly felicitate our chief guest Shri Govind Narayan Singh ji.
May I now request Dr. Atul Kumar sir to felicitate our esteemed guest of honor, Dr. Rajesh Kesri sir.
May I request Dr. Abhishek Kamendu sir to felicitate our distinguished guest of honor, Dr. B.K. Singh sir.
May I request Dr. Mahendra Pratap sir to felicitate Shri Trivikram Narayan Singh ji.
May I now request Dr. Jitendra Kumar sir to felicitate Dr. Professor Jagdish Singh sir.
May I request Dr. Shehbal Guha sir to felicitate our patron Dr. Ajay Kumar sir.
May I request Dr. Abhishek Kamendu sir to felicitate Dr. Shehbal Guha sir.
May I again request Dr. Mahendra Pratap sir to felicitate Dr. Atul Kumar sir.
May I request Dr. Atul Kumar sir to felicitate Dr. Jitendra Kumar sir.
May I again request Dr. Atul Kumar sir to felicitate Dr. Mahendra Pratap sir.
And finally, may I request Dr. Shabal Guha sir to felicitate Dr. Abhishek Kamendu sir.
I request all the dignitaries to please be seated.
To formally welcome our distinguished guests and delegates, I invite Dr. Jitendra Kumar sir, organizing chairperson, to deliver the welcome address.
Good evening, everybody. It's a matter of great pleasure, and I feel honored to welcome all of you in this midterm session of RSSDI. I especially thank and welcome our chief guest, Sri Narayan Singh ji, Pro-Chancellor, who has spared his time from his busy schedule to encourage all of us, and he has come here to encourage all the organizing committee and the postgraduate students. I also welcome Sri Narayan Singh ji, Managing Director and MLA of Aurangabad, who has spared his valuable time for us. I welcome Professor Jagdish Singh sir, Dr. B.K. Singh sir, and all the dignitaries sitting over here, and all the respected delegates and dignitaries who has come here from different parts of the state and from different parts of the country. Definitely, I also welcome all the postgraduate students. Definitely this is going to be very helpful for us, not only us, especially postgraduate students. And in fact, पूरे सेशन में एक बहुत अच्छी बात निकल के आई कि आम खाने से HbA1c कम हो जाता है। हाँ, तो ये हम लोग के लिए बहुत अच्छी बात है, लेकिन अभी हम लोग इसको ज़्यादा पेशेंट को भी सजेस्ट नहीं करेंगे। एक और स्टडी है, इसी से मिलता जुलता है कि एक और स्टडी है कि वाइन इन मॉडरेट डोज इज हेल्पफुल फॉर इस्केमिक हार्ट डिजीज, लेकिन हम लोग पेशेंट को नहीं बताते हैं। नहीं तो पता चला कि पेशेंट बाहर जाएगा यहाँ और बोलेगा हम तो गए थे नारायण मेडिकल में, हमको सजेस्ट किया है अल्कोहल लेने के लिए, और जब भी वो पीकर आएगा घर से बाहर से, उसकी वाइफ हम लोग को गाली देगी, ये मेरा हस्बैंड एकदम बिल्कुल अच्छा था, वहीं गया तो फिर जाके पीना शुरू कर दिया है। So I'll not take much time. There are lots of speakers to say their feelings. So with these words, I conclude. Thank you once again.
Thank you so much, sir, for your warm welcome and kind words. To set the tone for today's academic deliberations, I now invite Dr. Shehbal Guha, sir, Chairman, RSSDI Bihar Chapter, to share his valuable input. Please, sir.
Thank you. Respected dignitaries on the dais who have spared their valuable time for this occasion, all the dignitaries of the dais and their students, it's a privilege and honor to organize this midterm election, and my sincere thanks to entire team of Narayan Medical College and Govindan University to have helped and organized this program so nicely and so warmly, and they have given warm welcome to all the delegates who have come from around the state and from outside. So a great amount of thanks to all of them. RSDI, as you all know, is the largest organization of diabetologists across the globe, and we are proud to be part of that. And we have already had the national meeting in Patna a few months back, and we decided to have the midterm session here. And it's nice that we held it here, and we are having a nice discussion on various topics on diabetes since the morning, and we'll have it continue it tomorrow even. And we expect all the students to gain a lot of info and knowledge from the deliberations by the experts in their fields. And once again, I thank all of you who have attended here this conference, and thanks once again. Thank you.
Thank you, sir, for your inspiring remark. We now invite the scientific chairperson of the conference, Dr. Adil Kumar, sir, to address the gathering.
Hello. Good evening, ladies and gentlemen. और सभी लोगों को नमस्कार, और मंच पर आसीन सभी आगंतुकों को मेरा बहुत बहुत नमस्कार और बहुत बहुत धन्यवाद। नारायण मेडिकल कॉलेज के जितने भी डीन, प्रिंसिपल और गोविंद बाबू खुद जो इन्होंने श्रेय और आशीर्वाद दिया है और हम लोग का साथ दिया है, इस संस्था को आगे बढ़ाने के लिए हम लोग हमेशा कर्तव्यबद्ध हैं और आगे भी करेंगे। और इस तरह की जो शैक्षणिक चीज़ें आती हैं, जिससे आने वाले बच्चे जो हमारे सामने बैठे हुए हैं उनको एक प्रेरणा मिलती है कि हम भी आगे आकर के इस तरह का स्टेज को शेयर करें, साझा करें, और हम चाहेंगे कि आगे भी इस तरह का व्याख्यान यहाँ पे हो। इन्हीं शब्दों के साथ मैं बहुत बहुत धन्यवाद देता हूँ। एक बार कोटि कोटि धन्यवाद मंच आसीन सभी लोगों का। धन्यवाद। थैंक यू।
Thank you, sir, for your inspiring remarks. It's now our privilege to invite our patron, Dr. Ajay Kumar, sir, to address the audience.
Honorable dignitaries on the dais, fellow delegates, ladies and gentlemen, and very dear students. Yesterday in the Times of India, I was reading an article which mentioned that now we are going to see humanoid doctors, which will be in the form of robots. When I looked at the caption, I actually laughed out. But then I read the details of the article. It's already on sale in America. Ladies and gentlemen, and my dear students, now we are not going to compete with each other. I passed out in 1978 from Bhagalpur Medical College, and then I thought that I have to compete with products of Patna Medical College and Darbhanga Medical College, or AIMS or PGI, or maybe a British graduate or an American graduate. Today we are standing at the crossroad of medical education and medical practice, where we are not going to compete with our colleagues, but we are now going to compete with artificial intelligence. Now this is not in the domain of dreams, it is here. And the challenge with all of us today in medical profession is to ensure highest quality of clinical excellence. How far is that happening in our medical schools? Our hospitals actually poses a big question mark. There is humongous difference in the quality of teaching in different medical colleges of this country. At the outset, let me congratulate the builders of this university and this medical college who had the vision so many decades ago to establish this university out of nowhere. At that point of time, it was a challenge. Like him, I also come from a political family. My father and mother both were MLAs. My father also established a college way back in 1968. I established 2 schools in my village, and now I am in the process of establishing a university in my village. So I know the pains and pangs of establishing an educational institution. Quality educational institution is the key to success for the prospering of the medical education and medical practice. What these CME programs bring to us is a continuation of knowledge that you achieve during your undergraduate and postgraduate days. If you just sit back after that I was the topper of my batch and therefore I am going to be the most successful physician or surgeon, then you are living in a fool's paradise. Medical practice, I am now 73 years old. It's a process of continuous learning. You first start learning at home from your parents, then from your teachers, then from your colleagues. And at this stage of my life, I am going to learn most from my students. If we continue to have this wisdom of continuously learning our science, then only we will be able to deal with the competition that is looming in front of us. So just with these few words, I would like to wish the best of this scientific extravaganza, which has been so well organized under the leadership under Dr. Shaibal Guha and the RSSDI Bihar team. RSSDI, ladies and gentlemen, I can tell you, is an organization which has really come of age. It has started with a small number of doctors in India, and now it's the biggest organization after API. And it speaks volume of the credibility of this institution, that it has been possible to do not only these clinical seminars and meetings, but hardcore research at the ground, which is published in all index journals, and this is for all of you to see the good work done by the RSSDI. We have the governing body member, Dr. Rajesh Kesri, Dr. B.K. Singh, and the entire team of the RSSDI Bihar chapter. I am sure will give you something on platter on these 2 days, which will be extremely beneficial to you. Thank you once again for calling me.
Thank you, sir, for your guidance and encouragement. We are honored to invite Dr. Professor Jagdish Singh, sir, Honorable Vice Chancellor of JNSU, to address the gathering.
Honorable Pro-Chancellor of this prestigious university, who also happens to be the chief guest of this inaugural session of this RSSDI conference. The guest of honors, Dr. Rajesh Kesri ji and Dr. B.K. Singh sahab, our managing director, Shri Trivikram Narayan Singh ji, the organizing chairman, the organizing secretaries, and the other office bearers of RSSDI, who had been the force behind organizing this conference. Good evening, esteemed guests, dedicated healthcare professionals and participants. On behalf of GOPAL Narayan Singh University, it is my distinct privilege to welcome you all to this inaugural session of the midterm conference of RSSDI Bihar chapter. We are here today because the landscape of diabetes is evolving very faster than ever. Over 101 million people living with disease and another 136 million classified as pre-diabetic. This rapid surge is driven by a mix of genetic predisposition and rapid urbanization, sedentary lifestyles, as well as the dietary changes. While the core understanding of the disease as a metabolic disorder remains foundational, the introduction of emerging therapies, advancements in remote glucose monitoring, and the integration of digital health technologies have fundamentally transformed how we approach care. However, the technology and medicines are only part of the solution. The true progress in diabetes management requires a holistic, sustainable, and inclusive approach. It requires us to look at not just blood glucose regulation, but at the whole patient, addressing the mental health, lifestyle integration, and equitable access to care across the diverse communities. The purpose of this conference is to bridge the gap between clinical research and the real-world implementation. Over the next 2 decades, you will hear from leading experts on Over the next 2 days, you will hear from the leading experts on the breakthroughs in both type 1 as well as type 2 diabetes care. You will also have the opportunity to participate in vital discussions about preventing complications and improving the overall quality of life for those living with these conditions. The type 2 diabetes management basically focuses on lowering and stabilizing the blood glucose levels to prevent complication. It involves around 3 pillars. Basically, it is lifestyle changes, diet, weight loss and exercise, regular glucose monitoring, and medications which may be oral or injectable. As we all know, the nutritional interventions are a key component of type 2 diabetes management. Making health supporting changes in eating patterns can improve the postprandial glycemic exertions and lower the HbA1c to reduce diabetes related morbidity and mortality. The nutritional management of diabetes centers on stabilizing the blood glucose through a balanced diet. It emphasizes whole grains, lean proteins, healthy fats, high fiber, non-starchy vegetables while minimizing refined carbohydrates and added sugars, which directly regulates the blood glucose levels and reduce the risk of cardiovascular diseases. The actionable management strategies also includes the plate method, which visually divides your plate so that half of the plate consists of non-starchy vegetables like spinach. I am basically a vegetable biochemist, so I am just I try to incorporate these components. So the plate method, it visually divides your plate, which consists of half of the non-starchy vegetables like spinach, broccoli and okra, etc. 1/4 consists of lean proteins like pulses. These are an important ingredients, fish or chicken, and the remaining 1/4 consists of a high quality carbohydrates such as whole grains, millets, oats, quinoa, buckwheat, barley and corn. I don't know how many of you know what is buckwheat. कुट्टू का आटा आपने सुना होगा, that is buckwheat. It is highly it is having a lot of fiber and other raffinose family oligosaccharide content, so it is very useful for managing diabetes. The carbohydrate quality, somebody was speaking on low carb and keto diets. Basically, it is not the quantity of carbohydrate which you are consuming, it is the quality, which is usually conceptualized in terms of fiber content or the glycemic index or glycemic load of the foods. The physiological advantage of high fiber diet blunts the glycemic exertion caused by the digestible carbohydrates. Then comes the consumption of pulses, which you commonly know are chickpea, mung bean, lentil, peas and beans. They have been shown to be inversely associated with type 2 diabetes incidence, as they are packed with soluble fiber, resistant starch and raffinose family oligosaccharides. Since this resistant starch and the raffinose family oligosaccharides are not metabolized in the small intestine, it prevents the rapid spikes in post-meal blood glucose level. Basically, the resistant starch and the raffinose family oligosaccharide, which are the major component of pulses, they travel to your large intestine where it gets fermented to produce beneficial short chain fatty acids like acetate, propionate and butyrate, which acts as a vital metabolic fuel and signaling molecules, providing profound health benefits including reduced inflammation, improved metabolic regulation, enhanced gut integrity and also cardiovascular protection. So with this, now not taking much of your time, I hope that you will find the next 2 days to be an enriching, thought-provoking and transformative experience, and will share your clinical experiences and build partnerships that will extend far behind the walls of this conference room. Thank you, and I wish you all a highly successful event. Thank you.
Thank you, sir, for your motivating words. Now I invite Shri Trivikram Narayan Singh ji to share his thought with us.
It will not be much of thoughts, rather it will be a thankful session from my side, because me here as a part of the management board, I am here to thank the team for giving us this opportunity, the RSSDI team, and giving this university, this campus, this medical college a chance to host you all and welcome. So आप सबों का तहे दिल से मैं शुक्रिया अदा करता हूँ कि आपने नारायण मेडिकल कॉलेज और गोपाल नारायण सिंह विश्वविद्यालय को ये मौका दिया कि इतनी बड़ी संस्था का एक पार्ट बन सके और इस ऐतिहासिक क्षण का हमारे बच्चे, हमारी पूरी यूनिवर्सिटी को वहाँ बन पाए। इसके लिए आप सबों का मैं धन्यवाद देता हूँ। मंच को सुशोभित कर रहे blessing this dais on the occasion, the Pro Chancellor of Gopal Narayan Singh University, Sri Govind Narayan Singh sir, our Vice Chancellor, Sri Professor Dr. Jagdish Singh sir, EC member and guest of honor, Dr. Rajesh Keshri sir, another member of EC and guest of honor who has been a part of this family and has been always helping us throughout the sessions in all the struggles, Dr. B.K. Singh sir. We just heard Dr. Ajay Kumar Singh sir talking about the changes of the medical sciences and the changing world for the clinicians. Then Dr. Shabal Gupta sir, chapter chairman, Atul Kumar sir, we just reminded after meeting us कि हम लोग बहुत सालों के बाद मिल रहे, हम लोग एक ही जगह रहते थे साथ में. It has been what 25 years that we are meeting here. So this is again a good occasion for all of us. Our head of department and somebody who has been together with this organization since the inception of this medical college, Dr. Jitendra Kumar sir, Dr. Mahendra Pratap sir, and Dr. Abhishek Kamendu sir, and all the esteemed dignitaries, all the esteemed faculty members, and my dear students. There's not much a history honors student can talk about diabetes or medical sciences, but yes, couple of things like very much pointed out by Jitendra sir. It was quite satisfying time of this whole session कि आम से diabetes अब नहीं हो सकता है. ऊपर से इस season में जब वो बात करते हैं तो thank you so much sir. This is probably the best thing a history honors could understand from this conference. But yes, one of the issues that Dr. Ajay Kumar was talking about, the competition and the road ahead for the clinicians, especially in the current arena, that we have to compete the bots. I 100% agree sir, but I have a different take on this. India खास करके, I am not talking about the world, my exposure is not that big, but मुझे लगता है कि कभी भी हमारा competition किसी bot, किसी AI साथ कभी हो नहीं सकता है वहाँ पे, because in India and the part of world we are in, here the disease, here the distress, here the pain is not expressed in words, but it is expressed through the eyes. As far as I know, I understand the people, and being a representative of the people, यहाँ लोग अपने भावनाओं को दर्शाते, बताते कम हैं, दर्शाते ज़्यादा हैं. और मुझे लगता है कि आने वाले कम से कम 20-25 सालों तक साइंस उतनी डेवलपमेंट कभी नहीं कर पाएगा जब वो लोगों के आंखों के एक्सप्रेशन से वो समझ पाएं. एंड टू जस्टिफाई दिस, अभी एनएमसी लगातार whenever there is the inception और हमारे जब नए स्टूडेंट्स, जब बच्चे जब आते हैं मेडिकल कॉलेजेस में अपने एजुकेशन को शुरू करने के लिए, तो जो पहला कोर्स उनका होता है वो फाउंडेशन कोर्स का एक इनकॉर्पोरेशन हुआ है. आई रिमेंबर आई वाज द पार्ट ऑफ दिस टीम व्हेन डॉक्टर शरीन वाज देयर इन द विजन 2020 which was laid out in 1998 I guess 98 I guess. तो उस समय विजन 2020 की जब चर्चा हो रही थी तो वहाँ पे एक सबसे बड़ा जो एंड द रिवाइज करिकुलम 2018 इट वाज, एंड रिवाइज करिकुलम की जब बात हो रही थी तो वहाँ द बिगेस्ट चैलेंज
which NMC had faced उस समय कि how to understand the local needs and the local language of the people, जो हमारे डॉक्टर्स को सेंसिटाइज करे वो ह्यूमन टच के बारे में। तो एक तरफ जब हमारे बच्चों को, हमारे स्टूडेंट्स को, हमारे ग्रेजुएट्स को when we are sensitizing about this human touch, तो हमारा कंपटीशन कभी इन ह्यूमन टचेस के साथ कभी हो ही नहीं सकता। तो दैट कंपटीशन इज नेवर गोइंग टू बी विद द बॉट्स और द एआई। हाँ, कुछ फीड्स जो हम करते हैं वहाँ पे, जैसे अभी अल्ट्रासाउंड्स भी हमारे एआई के साथ आना शुरू हो गया, कुछ कंपनीज उसको डाल रही हैं, साथ में अपने इमेजिंग और पैथोलॉजिकल्स हो सकते हैं। लेकिन जो सबसे बड़ा चैलेंज हमारे लिए आज के डेट में है वो गॉडिज्म से कंज्यूमरिज्म का जो एरा अभी हमारे क्लिनिशियंस को फेस करना पड़ रहा है, जहाँ एक तरफ से हम कहते थे और कहते हैं भी आज भी कहते हैं, जब हमको ज़रूरत होती है तो डॉक्टर भगवान का रूप होता है, और वहाँ से जब जिस तरह का वायलेंस अभी, हालांकि वी हैव मेड अ रूल आल्सो फॉर वायलेंस अगेंस्ट द मेडिकल प्रैक्टिशनर्स एंड उस एक्ट में कवर भी हम इसको करते हैं, तो वहाँ से जब कंज्यूमरिज्म तक आते हैं तो आज के डेट में हमारा सबसे बड़ा चैलेंज हम खुद होते हैं, और हमारे जिस पेशेंट्स के सामने हम इंटरैक्ट करते हैं वो हर दिन हमारे लिए एक नया चैलेंज होता है, जिसको किसी भी बॉट या किसी भी एआई में हम फीड करके प्रिडिक्ट नहीं करा सकते हैं। सो आई गेस फॉर अगेन आई माइट बी क्रॉसिंग द लाइन, इज history honors should not be talking on all these issues, but what I feel from the where we are attached from the ground and from the people, मुझे लगता है कि आने वाला समय भी 15-20 साल तक तो कम से कम ये चिंता नहीं करनी है कि any bot or any AI is going to take our place, but yes, how जिस एक्सप्रेशन और जिस टच की मैं बात कर रहा था, जो हमको कनेक्ट करता है सोसाइटी के साथ भी और अपने पेशेंट के साथ भी, जो हमारे एक एज है हमारे किसी भी साइंटिफिक एडवांसमेंट्स के ऊपर, उस एज पे शायद हम लोग को ज़्यादा काम करना चाहिए रादर देन एवरी डे एक क्लिनिशियन की तरह, एक ह्यूमन बीइंग की तरह, एक बेटर ह्यूमन बीइंग, एक बेटर क्लिनिशियन हम कैसे बन सकते हैं। प्रॉब्ली दिस इज द ओनली एज विच इज़ गोइंग टू गिव अस इन द फ्यूचर, एंड बी रेस्ट एश्योर्ड इस फ्रेटर्निटी को, जिसके लिए मैं इतने आउटपोस्ट रिस्पेक्ट से मैं फाइट भी करता हूँ, और इस फ्रेटर्निटी के ग्रैंडनेस को भी मैंने देखा है, मैमथनेस को भी मैंने देखा, और मेरे आउटमोस्ट रिस्पेक्ट है इस फ्रेटर्निटी के लिए। मैं आप सब इस कैंपस में आए और हमारा आतिथ्य आप सबों ने स्वीकार किया, उसके लिए बहुत बहुत धन्यवाद।
Thank you so much, sir. It was our pleasure listening you. It is now my privilege to invite our esteemed guest of honor, Dr. B.K. Singh, sir, to please address the gathering.
बहुत बहुत धन्यवाद मुझे यहाँ पर आमंत्रित करने के लिए। आप सबों का, इस विश्वविद्यालय परिवार का और RSSDI का भी। हमारे चीफ गेस्ट माननीय गोविंद नारायण सिंह जी, और मेरी याद है कि मुझे 1 साल पहले भी आपसे मुलाकात करने का अवसर प्राप्त हुआ था, और RSSDI के समय में ही, उस समय औरंगाबाद में RSSDI हो रही थी, और हम लोग आपको निमंत्रण देने के लिए महेंद्र प्रताप जी के साथ आए थे। चलिए, इस बार मेरा सौभाग्य भी है और दुर्भाग्य ये है कि मुझे आशा थी कि गोपाल बाबू जी से मुलाकात होगी, लेकिन इस आशा के साथ कि आगे फिर मुलाकात होगी, हम आप सबों का फिर से RSSDI परिवार की ओर से बहुत बहुत शुक्रगुजार व्यक्त करते हैं, और इस महती सभा को यहाँ परिसर में करने के लिए आपका धन्यवाद भी देते हैं। माननीय हमारे औरंगाबाद के माननीय मेंबर ऑफ असेंबली हमारे त्रिविक्रम नारायण सिंह जी का, मैं औरंगाबाद का वासी होने के चलते भी और औरंगाबाद और RSSDI परिवार का होने के साथ भी आपका अभिनंदन करता हूं, और इस इनॉग्रेशनल फंक्शन में आपका स्वागत भी करता हूं, और आपसे आशा भी करता हूं कि IMA ने जो आपको मूलभूत एक प्लेटफॉर्म दिया था, तो IMA के लिए ज़रूर वहाँ पर कुछ आप करेंगे, ऐसी आशा और पूर्ण विश्वास भी है। तो मैं आप सबों का बहुत बहुत धन्यवाद, और वाइस चांसलर जगदीश सिंह से भी पिछले साल ही मुलाकात हुई थी, और बड़ी अच्छी मुलाकात, बड़ी देर तक मुलाकात हुई थी,
और उस समय भी बायोकेमिस्ट्री की हम लोगों ने ज्ञान की बातें आपसे सुनी थी और बहुत ही अनुग्रहित हुआ था, तो इसके लिए भी आपको बहुत बहुत धन्यवाद। और त्रिविक्रम नारायण सिंह जी, डिफरेंस ऑफ ओपिनियन ही ब्यूटीफुल है, बहुत ही शानदार होता है जब कोई व्यक्ति किसी चीज को डिफरेंट नजरिए से देखता है और उसको आत्मसात करने की कोशिश करता है। मैं आपको यहाँ इस प्लेटफॉर्म से बताऊं कि बिहार में ऐसे 3 व्यक्ति जिसको मैं अपने पर्सन, मैं नहीं कहता हूँ कि मैं किसी को जज कर सकता हूँ या मैं एक जज हूँ, लेकिन मेरे विचार से ये है कि 3 व्यक्ति जिन्होंने डायबिटीज़ के फील्ड में रिसर्च वर्क किया, और इसमें इस समय एक बहुत बड़ी रिसर्च पर जिस पर सारी डाटा आज जो डायबिटीज़ की आप देते हैं, इंडिया डायबिटिक स्टडी, तो आपको ये बताते हुए मुझे बहुत ही खुश हो रहा है कि इस मंच पर वो आदमी माशीन है डॉक्टर अजय कुमार, जिसने इस बिहार के इंडिया में किया है। इतनी कम तालियां उनके लिए अच्छी नहीं लगती है, इसलिए जोरदार तालियां बजाइए। तालियां इसलिए भी बजाइए कि इसमें 31 एक्यूप्रेशर पॉइंट होते हैं जो आपके मस्तिष्क से लेकर सभी ऑर्गन को झंकृत करते हैं और बेहतर बनाते हैं। तो एक बार फिर तालियां बजाइए। तो 3 रिसर्चर की मैं बात कर रहा था, त्रिविक्रम नारायण सिंह जी, जैसा आपका नाम है त्रिविक्रम, उसी तरह 3 आदमी का नाम मैं कर रहा था। उसमें से 2 आदमी सामने बैठे हुए डॉक्टर संतोष कुमार सिंह जी और डॉक्टर सुप्रियो मुखर्जी, जिन्हें मैं मानता हूं कि ये 3 व्यक्ति हैं जिन्होंने रिसर्च के फील्ड में, और हमारी संस्था का नाम भी है रिसर्च सोसाइटी फॉर स्टडी ऑफ डायबिटीज इन इंडिया। तो रिसर्च एक ऐसा अहम मुद्दा है जो अभी भारत में लैग कर रहा है। हम वहां पर नहीं पहुंचे हैं उस लेवल तक कि हम उस रिसर्च की बात कर सकें। अभी भी आप देखें कंप्यूटर की बात, चाहे किसी चीज की बात, आप सॉफ्टवेयर बनाते हैं, कभी हार्डवेयर नहीं बनाते हैं। आपके पास मशीन टेक्नोलॉजी उतनी एडवांस नहीं है जो होनी चाहिए थी, और सिमिलरली मेडिकल फील्ड में हम वहाँ नहीं हैं जहाँ हमारे पड़ोसी चाइना खड़े हैं। तो हम क्यों नहीं हैं और किस कारण से नहीं है, इसको आत्मसात करने की जरूरत है, इसको मेहनत करने की जरूरत है, इसको समझने की जरूरत है कि कल आने वाला समय एआई किसने क्रिएट किया? हमने बनाया। आप उसे झुठला नहीं सकते हैं इसमें। अभी मैं आज पूरे सेशन में देख रहा था स्लाइड्स, तो 80% स्लाइड्स एआई के द्वारा निर्मित किए गए थे। आप समय बचाने के लिए आप एआई का इस्तेमाल अब जरूरी है, उसको आप कंपटीटर नहीं, उसको एक टूल समझिए, उसका इस्तेमाल कीजिए और बेहतर लाइफ को बनाइए। तो मैं RSSDI बिहार चैप्टर के डॉक्टर सहवाल गुहा, डॉक्टर अतुल कुमार जी, सभी का भी बहुत बहुत, ये लोग इतनी बेहतरीन काम करते हैं जिसकी की परिकल्पना नहीं है, और इतने बेहतर तरीके से इन्होंने काम किया। और ऐसे छोटे छोटे जगहों को चुना जाता है जहाँ पर लोगों को रिसर्च के बारे में ये सोचने के लिए, समझने के लिए प्रेरित किया जा सके। ऐसी भावनाओं के साथ हम वहाँ भी जा रहे हैं जहाँ की जाना संभव नहीं है। जैसे सीतामढ़ी हम गए हैं, जैसे जयनगर गए हैं हम लोग, और ऐसी छोटी छोटी अभी हम लोग सारण के छपरा जिला में छपरा भी गए हैं। तो ऐसी छोटी छोटी जगहों में हम लोग जाने का प्रयास कर रहे हैं, लोगों को जगाने का प्रयास कर रहे हैं कि भैया अब तो जाग जाइए, कल आने ह्यूमनॉइड आपको रिप्लेस न करे, उससे पहले आप ह्यूमनॉइड को अपने बस में कर लीजिए। तो मैं इसी आशा और शुभकामनाओं के साथ और इस मेडिसिन डिपार्टमेंट और विद्यालय के सभी छात्रों और फैकल्टीज का भी धन्यवाद देती हूँ। RSSDI की तरफ से व्यक्तिगत रूप से यह धन्यवाद देते हुए मैं कहता हूँ, जितेंद्र जी है, डॉक्टर अभिषेक कामेंदु है, डॉक्टर महेंद्र प्रताप बहुत ही मेहनती आदमी है, और इनके ऊपर काम का इतना बोझ पड़ जाता है कि बेचारे बहुत ही मुश्किल दौर में पड़ जाते हैं। तो खास करके आप सबों के लिए, जो इसमें में राणा RK सिंह जी मुस्कुरा रहे हैं, रंजन जी भी मुस्कुरा रहे हैं, मैं सभी लोगों का स्वागत करते हुए आपके बारे में, आपके विद्यालय परिसर के बारे में, आपके कॉलेज के बारे में ये बात कहना चाहूँ, सभी व्यक्तियों के बारे में कहना चाहूँगा एक रामधारी सिंह दिनकर की कविता है, बहुत ही, कर्म भूमि पर चलो निरंतर, कर्म भूमि पर चलो निरंतर, थमना यहाँ निषेध है, कर्म भूमि पर चलो निरंतर, थमना यहाँ निषेध है, जीवन की राह कठिन है, संघर्षों का मेह है, जीवन की राह कठिन है, संघर्षों का मेह गे है, आशा मत बांधो फल की, केवल कर्म तुम्हारा सत्य, आशा न बांधो फल की, केवल कर्म तुम्हारा सत्य, परिश्रम से भी खिलते हैं सफलता के मधुर रथ, परिश्रम से खिलते हैं सफलता के मधुर रथ। इसी आशा और शुभकामनाओं के साथ आपका पुनः एक बार धन्यवाद देते हुए मैं आपसे विदा लेने की इजाजत चाहता हूँ। बहुत बहुत धन्यवाद।
Thank you, sir. May I now invite our esteemed guest of honor, Dr. Rajesh Keshri, sir, to address the gathering.
So first of all, I would like to greet you all on behalf of RSSDI. This is a wonderful meeting of the RSSDI Bihar chapter, the midterm conference. And Honorable Shri Govind Narayan Singh Ji, Shri Trivikram Narayan Singh Ji, Dr. Jagdish Singh, Dr. B.K. Singh Sir, Dr. Ajay Kumar Sir, Dr. Shaibal Guha, Dr. Atul Kumar, Dr. Jitendra Kumar, Dr. Abhishek, Dr. Atul Kumar, and Dr. Mahin Pratap. And I'm sorry if I have missed someone. On the dais, all honorable guests and faculties of the dais and delegates present here. It's indeed a very great pleasure for me to be here amongst yourself and listening to all the wonderful things that I have been listening. You know, it is, I think it is very interesting, even though mentioned as an anecdote about the research on arm. So what I found in this was that there is this passion and fire of research in you. And I think the good thing about this is that you're asking the right questions. What is very important in any research is formulating the right question. It is good to hear that the questions being formulated are pertinent to our society, are pertinent to our patients. So this is a good thing about these questions, about these research, because these are the situations which our patients face in their daily lives. And it is our duty as members of RSSDI, as doctors, as students, to have that fire of research in our belly, asking the right questions. Only then we would be able to get the answers, and only then, with our hard work, with our dedication, we would be able to translate those answers into our practices and give benefit to our society, to our patients. And this is where RSSDI comes in. Fortunately, we are very fortunate to have such senior members as patrons of RSSDI who are present here, who have done a great amount of research. And we look forward to them to guide us, and they are lightning, a beacon of light for all of us to follow. So this was about research. One thing I wanted to say in continuation to what he was, telling was that, you know, that we would definitely have a time when there would be humanoid doctors. So I think that is not going to go away, that is going to be there. But I think what I am worried about not is humanoid doctors, but that doctoroid humans. So I think this is a current problem, because we are so engaged and we are so involved in technology. Not only artificial intelligence, I won't go that far. I would go into social media, Instagram, WhatsApp, stories, Facebook. You know that sometimes we make a lot of decisions, or rather we are not able to make any decisions or do any productive work just because of our engagement in such activities. So I think we have to deviate, or rather we have to get our focus on the right things, concentrate on the right things, and maximize the use of technology for our benefit and for the benefit of patients, just as Sir was mentioning. AI is a good thing. It is a tool. It is good as long as it is used as a tool for the benefit of patients, for the benefit of research. Now, I use AI a lot in my research as a tool of research, because there are a lot of information which you can find, which you can process with the help of AI, which would have earlier taken me perhaps a year. Those things I can do in just few minutes or maybe seconds. So that's how you should be using technology and AI. And fortunately, in RSSDI, we are very active about it in all our conferences. I'm sure in this conference also I have seen papers and presentations which are about engaging, about education, about educating our coming up generation, and even the doctors who are not very well familiar with digital technologies, with artificial intelligence, on teaching and imparting knowledge about such technologies. The other thing which I wanted to, since I see a lot of students who would be coming out in practice, or they might be practicing, they would obviously be dealing with patients, is in spite of having so much technologies and mobiles and digitization, not to lose the human touch, especially in management of chronic diseases like diabetes, hypertension. Because your patient is sick, not just 1 day, 2 days, or 10 days. The patient, this is a chronic disease. The patient has to live with it. It is like the patient's spouse. So please try to give time to your patient. Talk to the patient. Be a human being. Be compassionate. I think these are some qualities of medicine which we should all have, but unfortunately because of lack of time and because of many other circumstances in our lives, we somehow are forgetting this and moving very fast ahead. So first of all, be a human being, be a good and a compassionate, empathetic human being, and then become a professional doctor deciding the medications and treatment and other things. Other important thing is I wanted to tell you about RSSDI. There's been a lot of discussion about RSSDI. So RSSDI is involved in research, wishes to promote research, and it is one of the forums like this that we are a part of. But RSSDI is doing other things also. We are going out and we are going in the community, in the society, screening people and trying to help them get the proper treatment, start early treatment, educating people about diabetes. Like last year we did a camp in the Mahakumbh. I'm sure you must all be knowing about Mahakumbh in Prayagraj. We did a dedicated diabetes awareness camp, and sir, you would be happy to know that we have screened more than 40,000 people there, given education to them, distributed free medications to them. In RSSDI, we have a rural outreach program in which we adopt villages, and we pay salary to people, to paramedical staff. They do door-to-door blood tests. They check sugars and blood pressure and other vitals which are important. And those who require treatment, they are referred to centers for treatment. They are given education about their diet, about exercise, about lifestyle. So this also is an activity of lifestyle. Now, one important thing that we should be doing is to prevent diabetes. Type 2 diabetes, to a very great extent, is preventable. If we do the right things, if we take the right steps, we can prevent it. So now RSSDI has started its work in this direction also. And as a first step, we are going to start the school outreach programs, where we are going to sensitize our school children about healthy lifestyle, about diet, about diabetes and other things. So there are a lot of initiatives which we are taking up in RSSDI and coming up with the coming up generation and young blood, fresh mind, new ideas. I'm sure that with guidance and support of all of you present here, we're going to reach new heights and achieve and attain better results. Thank you so much.
Thank you, sir, for your valuable insight. And now, the moment we have all been eagerly waiting. It is our immense privilege and honor to welcome our esteemed chief guest, Shri Govind Narayan Singh Ji, whose vision, dedication, and relentless efforts led the foundation of Narayan Medical College and Hospital. Sir, your unwavering commitment to the healthcare and academics has created opportunities for students, doctors, and healthcare professionals, and we are deeply grateful for your inspiring leadership and guidance. Please address the gathering.
Thank you for such a kind words. I mean, all these words is dedicated to the Chancellor of this institution and Chairman of Dev Mangal Memorial Trust, who run all this institution, my legendary father Gopal Narayan Singh, who unfortunately due to some engagement, he couldn't be here today. And it is his dedication that we are here, this great institution has been made and it is flourishing. Respected Professor Jagdish Singh Sir, MD NMCH, Trivikram Narayan Singh Ji, Rajesh Keshri Sir for your excellent deliberation here. Our extended family member BK Singh Sir, Ajay Sir, for whom in this part of the world we look or think no further in diabetics than him. Sehwal Guha Sir, Atul Kumar Sir, our fellow colleague Jitinder Sir, Mahendra Pratap Ji, Abhishek Kamendu Ji, my all colleagues sitting in front of dais, in front of me, their students and all the delegates who have come from across Bihar to participate in this RSSDI mid-term conference. First of all, from institution part, I'm very grateful and thankful that we were given an opportunity to host this event, which again is going to be a great learning curve for our students and all of whom who are participating in these events. As an institution, we try to provide the best of facilities what we can provide in an academic environment, the best economic environment that we could provide. A lot of things have been deliberated from morning itself. I mean, we see a lot of tiring faces as well. So in that part, one thing which has been continuously, which has been coming is about AI and all. See, AI is here to stay. We have to live with it. And it is on us how you utilize it. A lot of things has been said here as well. Now, we as an institution, what we are doing for that. I'm glad to inform you that in our institution, in our university, we are working very closely with IBM, and we have introduced certain curriculums for BTech, and in first phase we started with BTech and BCA programs, wherein core developers could be made. Because, you know, for us, what we think for India, for a country like India, this AI revolution is a big opportunity. Why I must tell you? Because see, in past, our priorities was very different, and it has been pointed out that we lacked in research. This opportunity gives us to leapfrog in front league if we apply ourselves smartly. जो टाइम लॉस हम लोगों ने इस दौरान किया है रिसर्च डेवलपमेंट खासकर, एआई एक ऐसा अपॉर्चुनिटी है, अगर आज के डेट में इफ यू टेक इट अप judiciously and very honestly, we can be up with the top. And keeping that in mind, we have taken it beyond. What we are doing is we have been working with IBM, and we have introduced last year AI in pharmacy. Our pharmacy college we have already introduced, and we are very happy to inform you all that we send those curriculum what we are doing to Pharmacy Council of India, and now Pharmacy Council of India this year has introduced AI in this curriculum. So it might be it is on right now, they're taking feedbacks on it, and they're very similar to what we have introduced with them. We have introduced last year AI, application of AI in nursing. We have already students doing their courses, first year have passed out, they're gone in second year. And we are working with IBM how to introduce it for our medical students as well. So because it is here to stay, it is, you cannot shed it off. It is here, it is better, we should be equipped with it. And this opportunity, what is giving to us, and the kind of talent we have and kind of mind we have in this country, I think I'm very hopeful we are going to be amongst the leaders in this. Because government is backing up like anything. We as an institution, we are trying very hard, because I like to inform you that in the recent AI mission, because of virtue of population, Bihar has got 3 AI Center of Excellence. Now, unfortunately, Bihar government has clubbed it all together and based in Patna. We are finding and we are fighting it out to spread it out. And we as an institution, we are trying to establish a AI Center of Excellence here as well. So let us hope things goes well and it moves in the right direction. So for me, I think we can manage AI much better. And it is a scary part. I mean, the threat is always there if we not handle it properly. But every threat has an opportunity. If we do it, manage it if correctly, we can do very well in this. And I think we have talent, we have the skills to manage it out. And we as an institution were trying our best to be a part of it. If we'll try at least within a year or so introduce some kind of courses for MBBS students, because most of the equipment, what is happening right now, because there are because we run an incubation centers as well. Even in such a remote place, there are equipments where students are coming up, especially in agriculture and healthcare, where they are utilizing this AI and making devices. So we have to be equipped. It is there and it is immediate. It has already arrived. We have to equip ourselves because of lack of expertise. There are 2 students from our institution whom we have incubated. We have requested IIT Patna, and one it is getting incubated at IIT Mandi. So because the kind of expertise that was required for them, we didn't have. It is always better to have a very honest confession, because you must know your limitations. Only to hold them for sake of being in our university, we decided not to do it, because they were a serious talent and a lot of good ideas they had. So we have incubated them. One of them is already that is an agriculture application AI in agriculture. That fellow is being incubated at IIT Patna, and one in healthcare, he is about to be incubated in IIT Mandi. One more startup has come up, just in his very initial phase. We are providing seed funding to them. And I'll request all students here as well, if any kind of such innovations or any startups, anybody from medical fraternity also, university will welcome them all. And I will be more than happy to incubate students here and to create a certain startups, because application in healthcare, nobody can do much better than a doctor itself. Because abhi problem kya hoti hai ki every small times we have to attach certain faculty or teachers with them to give feedbacks, because you are getting live feedbacks for yourself. So said that, I wish a great success to this conference, and a special request to please give a person who has that Mango research, who has done a special certificate to them. I mean, because I always had the guilt, I'll end up with narrating a very story, anecdote, which is a real story. मेरे फूफा जी के साथ ये हुआ था, उनका bypass surgery एम्स में हुआ. So at that time, it is before this medical college, even we started off this medical college at that time. So once he got operated, bypass जब हो गया, तो my father was obviously accommodated him. अब जब वो अलग हुए, तो उन्होंने डॉक्टर को अलग से बोला कि ये मेरा साला है, बहुत तंग करता है, इसके सामने मत बोलिएगा कि हमको आम नहीं खाना है, इस साल खा लेने दीजिएगा हमको, बाद में हम उसको मान लेंगे. So that mango is very important product. And whosoever has come up such a brilliant research, he should be awarded. And thank you very much.
Thank you, sir, for your inspiring words. As we conclude the inaugural session, it is time to express our heartfelt gratitude to all those who contributed to its success. May I invite Dr. Mahendra Pratap sir, Organizing Secretary, to propose the vote of thanks. Sir, kindly deliver the vote of thanks.
Good evening, everyone. Respected Chief Guest, our Pro-Chancellor Sir Shri Narayan Singh Ji, all dignitaries on the dais, esteemed faculty members, dear delegates, sponsors, ladies and gentlemen, along with the media person sitting over there, on behalf of the organizing committee of RSSDI Midterm Bihar Conference 2026, I extend our heartfelt gratitude to everyone. We, the organizing committee, are deeply honored by the gracious presence of our chief guest and all the dignitaries present on the dais, along with the faculty members who have participated in this. Your blessings have elevated this event. I sincerely thank our head of the Department of General Medicine, Narayan Medical College and Hospital, Dr. Jitendra Kumar sir, the organizing chairman of this visionary program, for his leadership, and Dr. Abhishek Kamendu sir, the co-organizing secretary, for his dedicated support. I also thank Dr. Atul Kumar sir, Dr. Shabal Guha, the chapter chairman, and in absentia Dr. Vijay Kumar, the chapter secretary of this RSSDI Bihar chapter, for his constant guidance and support. Our sincere thanks to all the faculty members, sponsors, industry partners, and media persons for their valuable contribution towards this RSSDI Bihar Midterm Conference. I also express a big thank you to all the delegates and all of the organizing team for making this inaugural ceremony a great success. We, the organizing team, wish you a scientifically enriching and memorable conference over the next 2 days. And lastly, I thank you once again for being here. Thank you. Jai Hind.
Thank you, sir. Thank you all for your gracious presence. With sincere appreciation and warm regards, we decide the inaugural session formally concluded and look forward to a truly enlightening and memorable conference ahead. Thank you so much. Everybody please stand for the national anthem. नायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल वंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष मागे गाये तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे. Dinner is ready. You can all have the dinner.
नहीं सर, गरीब आदमी कहाँ पर्स रखेंगे उतना